Hello, good morning everyone. Good morning, everybody here. Did you all sleep well last night? Good morning. So I'm informing that it has started, Aswati. Good morning. So everybody is here. Good morning. Did you sleep well last night? Had a proper dinner? So let's talk about, for 10 minutes, let's talk about something else. Let's talk about some things that I want you to inculcate in your habit at the beginning of your preparation. And one of the most important things is sleep hygiene. See, I can talk a lot about sleep hygiene because I was one of those people in medical college who had one of the worst schedules ever. So we were a group of 8 people, and somehow we landed up, because we didn't want to wake up early and go and grab a seat in the library. We thought it is not something that we want to do. So we really started going at 10 p.m. to the library and then coming out at 6 a.m. all throughout our MBBS. So we never slept at night. We always slept in the day. And I feel that that was one of the worst things that I did when I was in my college, to have a very, very bad sleep schedule. Now, what you have to understand is that everything has to be aligned according to your exam time, and the one there you get maximum productivity. So exam is from 9:30 a.m. Your exams are always going to be from 9:30 a.m. So there are certain things that you need to inculcate in your habit from day one. And day one means today. From today. Not tomorrow, not next week, not even day after tomorrow. It has to be inculcated from today. You have to get into the habit of sleeping between 10:30 to 11 p.m. Yes, I'm being that strict. 10:30 to 11 p.m. Every medical student thinks that whatever extra time they want for study should come from their sleep time, because traditionally we have been taught by our parents, especially middle class parents, that you need to sleep less and work harder. While all the research in the world has shown that you can only work hard, you can only work effective if you get adequate sleep. So you need a total of 8 hours of sleep. Total of 8 hours of sleep. Now I would recommend that you take that at night, but usually that is not possible to. So you split into 7 at night and 1 during the day. Post lunch session is a slumber period for everyone. So instead of struggling a lot and then passing time on Facebook, WhatsApp, Insta, rather than that, just have your lunch, move about for 10-15 minutes and then sleep for an hour, and then get up, have a cup of tea and then start studying. Okay. Third is clean bed. Always keep your bed area and your study area different. Even if you are somebody who studies on the bed, before you sleep you need to clean the bed. I have seen so many of my friends, my juniors, who used to sleep with all the things on their bed. So they used to not get space. Their laptop was also on the bed. There were all the books, notes, files, everything on the bed. So clean bed. Clean bed. No electronics 1 hour prior to bed. Now we all are into the habit of till the last moment keeping the phone on, and then keeping the phone down and sleeping, right? And then we grumble that we didn't get good sleep at night. Now what happens is, as you all know, that we are all using LED phones. The brightness from the phone is just too much. It is very bright. It's almost like day. What eyes would feel like, it's day. Now what happens is, if till the end of the time, till you are about to sleep, if you keep on scrolling on the phone, and Insta is something that takes up a lot of your time, and the bright pictures of Instagram. So what will happen is, what will happen is your brain will always feel that it is day, and so it will keep on pumping hormones that will keep you awake. But then suddenly if you close your eyes and decide it's time to sleep, the brain doesn't really understand that thing, and therefore for a very long time after you have decided that you want to sleep, you don't get sleep, and then the vicious cycle starts. Because you are not getting sleep, you use more phone. Because you use more phone, you're not getting any sleep. So 1 hour before you decide, so it's 10:30 or 11 your sleep time, so after 9:30 you will not touch your phone. Whatever you have to do, you will not touch your phone. All right. And last but very important, 2 hour gap between sleep and dinner. This is something that is very, very important. So if you're supposed to sleep at 10:30 or say 11, you will not have your dinner later than 9 p.m. Ideally, it should be around 8 o'clock, and then you sleep around 10:30. So that is good 2.5 hours between your meal time and your bedtime. If you follow these things from day one, I'm telling you, I cannot emphasize more on this thing. Over the course of next 1 year, you will get lot of motivation from lot of amazing teachers. Most of them are my teachers as well. I was a damn student as well. And there will be no problem it will be available on the app. Bache, I have just sent it, and it takes a day for them to edit the videos and then upload it. By tomorrow afternoon, all the videos will be uploaded. Mostly this video will be yesterday's class will be uploaded before the end of the day, but today's class will again take half of tomorrow's days, because they have to edit the video and then they combine and make it one file and then upload it along with the names of the topics in it. So you just have to wait. Right now you can concentrate on today's class, Muskan, and then for yesterday's class you can later on refer to the video. Okay, if you follow these things, and I'm telling you this thing, that you will get lot of motivation from everyone, how to study, what all things are there, everything. But these soft skills which I'm going to tell you will be discussed rarely, and I usually try to concentrate on these soft skills because everybody is studying the same thing, right? Everybody has some institute that they are associated with. Everybody has amazing notes. All the teachers out there are just amazing. Whatever content every teacher is giving you is more than sufficient for a first year postgraduate. So let alone undergraduate and NEET. But still there is a gross variation. Some people make it through, some people don't make it through. Why? Because of the soft skills, because of how do they approach the exam. And therefore everybody needs to understand that unless and until they are in a positive framework of mind, they are positive intent, and they know what they are doing, they will not be able to extract the best out of what they are reading. So don't think that having notes is the only thing that is going to get you selected, because everybody is having these notes, isn't it? All of you, everybody in India who is a student of DAMS has the same DAMS note. Some people also get notes from outside in Xerox and stuff like that. And it is not like only students from institutes are only getting selected. There are a lot of students you also know who have never taken any coaching and still they get selected. Why? Because at the end of the day, it's an exam which is based on the content, and the content can be read from anywhere. We are giving you processed content. So you're getting extracted material, experience of a teacher from years and his assessment of the exam. So you're getting very processed material, but at the end of the day, you have to consume that material and then you have to bring the outcome from it. That is your job. And this can only be done when you have a particular positive intent in your mind and your preparation in mind. So remember, everything starts when your brain is very free. If you are constantly in the state of worry, or if you are sleepless, or if you are tired, mentally tired, physically tired, emotionally tired, then you will never be able to extract the best out of what you are studying, right? So one of the many things that I am going to tell you, the first thing is sleep hygiene. Keep these things in mind. This is not just for your exam. Remember, this is something that you can develop as a habit for your life. And I was a very bad sleeper when I was in my medical college in MBBS, but somehow I realized the importance of sleep when I went on to do my post graduation. And being in a very, very emergency oriented field, See, today also I barely get to sleep, 7 nights in a row. I have never slept 7 nights in a row. Yesterday also, after I finished the class at 9:20, I immediately grabbed dinner and I had to go and do two emergency LSCs because it's what our job is. And then I came back and then it took me a while before I got sleep because of the adrenal rush of the class. So it's like I barely get sleep. So the days when I know that I have nothing planned and I bank that there is no emergency, you won't believe it. These days I'm asleep at 10 p.m. and I get up fresh at 6 o'clock in the morning. 8 hours of uninterrupted, amazing sleep. And the next whole day I keep on working. I'm standing, I'm doing cases, I'm teaching, and it doesn't feel a thing. So sleep is, I feel, one of the most underrated yet most important things that you can inculcate in your schedule. If you get into the habit of waking up early, then I'm telling you, you will be an amazing success all through your life because our productivity is maximum during the day. And if you extend your day, if you wake up early, suppose you wake up at 4, so your day becomes very long because 4 a.m. till 8 p.m. But if you wake up at 10 or 11 or 12, that is what we normally do, then your day is very short. It is say only 6-8 hours. So you're not able to generate that much of productivity. All right. So keeping this in mind, I hope everybody has joined and there are no more people. If somebody comes, then you can tell them the number of pages to be left. And let's start with the next part of the discussion. We started with the steps of general anesthesia. We covered pre-operative assessment and preparation done. We have attached the monitors on the patient done. And now we have induced the patient, which is the most common induction agent, say propofol. So I've given an induction dose of propofol, and the moment I induce the patient, now the patient has lost consciousness. The patient is also apneic. You can see in propofol, when you give an induction dose of propofol, there is apnea. The next step would be to check for bag and mask ventilation. So before I go ahead and give muscle relaxants for intubation, I will do the step of checking for bag and mask ventilation. Can anybody, it's a very indirect kind of a question, but can anybody think of a reason why I need to do this bag and mask ventilation between induction and intubation? That means between, after giving induction agent, but before giving muscle relaxant. Why do you think we need to do a bag and mask ventilation? Why do you think we need to do a bag and mask ventilation? Anyone? So that respiratory muscles don't paralyze? How will bag and mask ventilation make sure that respiratory muscles don't paralyze? Anyway, you are going to give muscle relaxants, right? That will paralyze the respiratory muscle. To check for patent airway. But what is the importance of patency of airway after you have already made the patient apneic? No, I understand that bag and mask ventilation is to check for respiration. Obviously, when bag and mask ventilation will be successful, that means that you can give breaths to the patient. I'm asking why. Why specifically between induction and intubation? Jatin says increase apnea time. You have already done pre-oxygenation for 3 minutes. Your apnea time is already maximum. You cannot increase it more, right? You have already replaced all the nitrogen with 100% oxygen. Can you give more? Will it make any difference if you give more oxygen? No. Yes, to check whether assisted respiration will work is absolutely correct, but why? See, what you are saying is that what is the implication of bag and mask ventilation? I'm saying why we have chosen this particular point only to check for bag and mask ventilation. Okay, so Varun is saying if intubation fails, then so what? Go ahead, complete your sentence, Varun. Prince, don't say rubbish stuff. Non-invasive method. क्या non-invasive method? You are going to intubate the patient in the next 2-3 minutes. What is the point of doing a non-invasive ventilation? I am asking about implication of bag and mask. You are telling me what is bag and mask ventilation. Don't give me that final year answers. Varun, complete your statement. If intubation fails, what? Absolutely correct. Absolutely correct, Varun. See, this is what our awareness of what is happening intraoperatively is. See, you remember what is difficult airway guidelines, DAS guidelines? We have plans, plan A, B, C and D. What is plan A? Laryngoscopy intubation. What is plan B? SAD insertion. If you fail in plan B, then what is plan C? Final attempt at face mask ventilation. And if you fail in that, then the condition is CICO, which is almost a fatal condition. Very difficult to revive a patient from CICO, right? So your last line of defense in a case of unanticipated difficult airway is, yes, it's bag and mask ventilation. And once you gave muscle relaxant, now you are taking away patient's ability to breathe. So don't you think it would be prudent to check whether we will be able to bag and mask the patient in case we need to use plan C? Yes. So just write in front of this bag and mask ventilation for plan C. This is just an assurance that we are giving ourselves that before we go ahead and give muscle relaxant and paralyze the respiratory muscles of the patient, we should at least be in a state to know whether we can bag mask this patient in case this turns out to be a difficult airway where we are not able to execute plan A and B. This is the importance of bag and mask ventilation, specifically between induction and giving of muscle relaxant. Specifically between induction and giving muscle relaxant. Okay. So this is something that I wanted you to know, and it's a derivative, so I don't expect you to know the answer, but Varun did a splendid job in understanding, okay, this might be the reason why we want to check for bag and mask ventilation between induction and intubation. So let's start with muscle relaxants. And for understanding muscle relaxants, we need to understand the physiology of this part of the body. Can you identify this part of the body? It's a favorite thing right from first year till final year. In every year, possibly this particular part of physiology is being taught in one or the other way. Can you name this part of the physiology? Yes, this is a neuromuscular junction. One of the most unique things in the human body, where an electrical impulse of a nerve, see, synapse is such a vague term, no? Synapse is joining of any two things. A nerve also synapses with a nerve. A muscle also synapses with a muscle. It is not synapse, it is neuromuscular junction, yes. Or neuromuscular synapse specifically, okay. This is the part of the body called as NMJ, neuromuscular junction. It is amazing. Why? Because an electrical signal from a peripheral motor nerve will get converted into the physical manifestation of a muscle contraction. So there is change of energy from electrical energy to mechanical energy, which is done in such a seamless manner. Right now I am doing it, you are doing it voluntarily, involuntarily, and it just doesn't feel that we think, and our thinking creates a motor response. The sensations, they go through the motor nerve endings, and then they produce a response in the form of contraction of the muscle. Our whole civilization is based on the fact that we have extremely good NMJ, extremely good NMJ, and that is why whatever we think is something that we can do, right? Be it arts, be it science, be it drama, be it dance, anything. It is all about NMJ. If we do not have such a good NMJ, then it would be very, very difficult for us to execute what we are thinking, right? So let's just discuss NMJ physiology in short, and based on this NMJ we have the mechanism of action of muscle relaxants, which is one of the most common questions asked from muscle relaxants, right? So let's start with neuromuscular junction physiology. So every neuromuscular junction has a peripheral motor nerve that come and terminates in the part of the muscle called as muscle end plate, right? And this forms a NMJ. The area between the two, there is an empty space called as synaptic cleft. The peripheral motor nerve is filled with a neurotransmitter called as acetylcholine. And when the nerve impulse arrives at the peripheral motor nerve, it causes calcium influx. And this calcium influx causes these vesicles that are filled with acetylcholine to fuse with the plasma membrane and release acetylcholine in the synaptic cleft. Now it traverses through the synaptic cleft and reaches the post-synaptic muscle membrane, that is the muscle end plate, where they find their receptor. What is that receptor? Acetylcholine receptors. So acetylcholine, when binds to acetylcholine receptors, then initiates a wave of depolarization. And this wave of depolarization is then propagated through sodium channels that are present all through the muscle. So there is perijunctional sodium channels, junctional sodium channels who are present at the junction, and then perijunctional sodium channels that go into the muscle. So they will take this wave of depolarization from the muscle end plate into the muscle. And we know what happens inside the muscle. There is a system of sarcoplasmic reticulum. So this wave of depolarization causes the sarcoplasmic reticulum to release calcium. The calcium goes and binds to the active site on actin and myosin and causes the muscle to contract. In the meantime, in the depths of these crepts that are present at the NMJ is a enzyme called as acetylcholine esterase, which is present right there. So it will immediately break the acetylcholine into acetyl and choline. Acetyl gets absorbed and choline gets recirculated in the presynaptic nerve terminal, and this muscle end plate gets repolarized, ready for next action potential. Ready for next action potential. Just a second. Next action potential. This is the physiology of neuromuscular junction. This is NMJ physiology. है ना? Understood? This is something basic. This is something basic. Now based on this, we have two types of muscle relaxants: non-depolarizing muscle relaxants and depolarizing muscle relaxants. We'll first discuss the non-depolarizing muscle relaxants, which are easier to understand. And if you look at non-depolarizing muscle relaxants, they are very, very easy to understand. Non-depolarizing muscle relaxants are called as curares. Non-depolarizing muscle relaxants are called as curares. And they are basically competitive antagonists at nicotinic acetylcholine receptors in post-junctional muscle membrane. They are competitive antagonists at nicotinic acetylcholine receptors in post-junctional muscle membrane. So what do you understand by competitive antagonism? First, what is the meaning of the word competitive? So it is concentration dependent. So more in concentration, more will be the action. And antagonist means affinity towards the receptor present, but no intrinsic activity. Isn't it? This is how we define an antagonist. One that has affinity towards the receptor, yes, but no intrinsic activity. No intrinsic activity. No intrinsic activity. So this basically means that in this NMJ physiology, suppose I have now introduced molecules of an NDMR, say atracurium. So it will diffuse from blood via plasma membrane, plasma, and it will reach the NMJ. It will come, and because its concentration will be higher than acetylcholine, so it will come and bind to the acetylcholine receptor and not do anything. So it will not let acetylcholine bind and also not do anything. So what will happen? The impulse will come, it will release acetylcholine, but this acetylcholine will not bind to the receptor, and because it is not binding to the receptor, so what will happen? It will not cause a wave of depolarization. So no wave of depolarization means no release of calcium from sarcoplasmic reticulum. No release of calcium from sarcoplasmic reticulum means no muscle contraction. And we know when the muscle is not contracting, it is in a state of paralysis, and in this case it would be flaccid paralysis. In this case it would be flaccid paralysis. In this case it would be a case of flaccid paralysis. All right, so this is one of the easiest mechanisms that you can have in anesthesia, and you won't believe it, this is a very frequent exam question. Most recently it came in NEET PG 2019, and the question was, which of the following is the mechanism of action of curare? The only catch in the question was they didn't give NDMR, didn't give the names of NDMRs, they asked curares. They are derived from a South American arrow poison, and that arrow poison was called curare, therefore all NDMRs are called as curares. All NDMRs are called as curares, right? And the question was very simple, which of the following is the mechanism of action of curare? And the options were also simple: competitive antagonist at nicotinic acetylcholine receptor, non-competitive antagonist at nicotinic, competitive at muscarinic, non-competitive at muscarinic. And still most of the students that gave me the recall, they said, sir, we marked it wrong. Because at the outset it appears very okay, so we don't pay attention, but it is the easier things that we make most mistakes in. It is the easier things that we make most mistakes in. And that is what hurts us a lot. So everybody, when they start their preparation, they think, okay, we have to cover the tougher parts for PG entrance, and tough parts is what are important, tough topics, tough subjects, tough concepts, new questions. Am I right? Isn't it what you are sitting here and thinking, okay, now sir will teach us something that nobody has ever taught us or nobody will ever teach us, and he will teach us the toughest parts of the subject, and he will make us deal with the toughest things which are not able to understand otherwise and not given in books, and which are the new questions and which are the recent advances, isn't it? Isn't it what drives you most towards making notes in classes? Tell me. क्या हुआ? Everybody is gone quiet after an MJ? Have gone back to sleep or what? Just a minute. right? Now let me tell you again a fact-based thing. Pick up any paper you want in the last 10 years, any paper, any NEET paper, any INI-CET paper, any paper, and just go through the questions and then mark it or categorize them into something that is in any subject easy or difficult. See, I define easy and difficult by easy, that is one that is in books. That is in books. And difficult, that is new. And there are a lot of subjects where there is a lot of new that is happening that is not per se in the books, or it doesn't get in the text, but it is still asked in the exam, right? And what you will realize is that almost 70 to 80% of the paper comes from easy, while there is only 20% that comes as difficult or new. How much did I tell you you need to score? What is your target for your entrance exam? What is your target? 70%. And 70% is what is coming from an easy part. So don't you think it is easy to get selected? Now normally, with best possible preparation, you can not achieve more than say 80% efficiency. 80%. So 80% efficiency in the say 70% of easy things that have come. Yeah, sorry. So I also happen to have one small ICU setup which I manage. There was one road traffic accident patient that got admitted, so they were informing me. Otherwise, they don't disturb me when I have classes. But if I've got a call from them, that means it is important. So I had to attend it. Sorry. Yeah. So let's suppose we on the downside we have an efficiency of say 80%. in the 70% easy portions, right? 80% efficiency is something that you have to achieve in the easy portion, right? So that would make it how much? So it's around say 56 to 60% that you will score. And for being topper, you need 70%. So see, from the easy portion, you are already selected. Now from the remaining 30% tough, even if you have a 20% efficiency, that will add on 6 more percent, and you are very near your selection criteria. So tell me, and this is against any logic that usually we build up, you should concentrate while you are preparing on which things in every subject, in every topic. The easy 70% or the difficult 30%? You only tell me from this calculation. Easy 70% or difficult 30%? You should concentrate on which topics? Easy 70% or difficult 30%? Always remember this thing. Whenever you start studying a subject, always concentrate on the 70% easy part. You have to have an efficiency of 80 to 90% in this easy portion. इसका क्वेश्चन गलत नहीं होना चाहिए. Whatever happens, इसका क्वेश्चन गलत नहीं होना चाहिए. Remember this thing. If you manage to do this, and in the end, if you put real hard work in your GTs, CVTs and mock, I am telling you, don't really need to read anything tougher for the exam. Anything. Whatever is tougher, whatever is new, whatever is the new guidelines, you don't really need to pay any attention. Just focus on the easy 70% of any subject and you will be amazing. You will easily crack the exam without you even feeling कि अरे यार ये तो exam था. अरे everybody said it is going to be very very difficult. But ऐसा नहीं हुआ. It was very easy. Why? Because you concentrated on the mass. First thing I told you, na, don't think of becoming a topper. First thing is to become selected. So for selection, you need bulk. For bulk, you need to revise more of the easy 70% rather than going directly for the tough 30%. We tend to spend too much of our time on things that are controversial, that are difficult to remember, that are difficult to understand, and that are new. We spent almost 50% of our time on these things and rest of the 50% for rest of the 70-80%, while you should devote at least 70 to 80% of your time for 70 to 80% of the content, which is easy, straightforward. Like in anesthesia, whatever I am teaching you, the easiest portion, straightforward, mechanisms of actions, pharmacokinetics, pharmacodynamics, indications, all this is the easy portion of anesthesia. Always concentrate on that. Okay, but students will do, sir, what about pulmonary artery catheter? Sir, what about advanced cardiac monitoring? Sir, what about advanced neuro monitoring? Sir, what about mechanical ventilation? Sir, I have to understand, I didn't understand this mode of ventilation versus that mode of ventilation. Sir, what happens if we give pressure control, pressure support? While it has been proven historically that in the last 10 years, we have got only 1 or 2 questions from mechanical ventilation. That is one of the worst topics for preparing for an undergraduate student, and that is why I do not include mechanical ventilation in my theory classes. I do not. I have made a module that you get in AIMS capsule that gets uploaded every year. It's a 65-minute module, and I'm telling you that is more than sufficient for mechanical ventilation. More than sufficient for mechanical ventilation. But still students, they keep pestering me about mechanical ventilation because here there are some new mock test that comes, free test that comes. They give a difficult question on mechanical ventilation just to make themselves jazzy, and then they feel that it is going to, but traditionally they have not asked, because understanding and implicating mechanical ventilation is not something that should be done at the undergraduate level. It is very, very difficult to understand the nuances of mechanical ventilation. It takes years for somebody to master mechanical ventilation. All right. So this is one small message that I wanted to give you, that these questions like mechanism of action, don't ignore them. This is so easy, humko aise yaad rahega. Nahi. We tend to make mistakes in easy things. We'll come to the types of mistakes also in some time, but let's just go to the next part of our discussion, which is this amazing drug called as depolarizing muscle relaxant, or DMR. Depolarizing muscle relaxant, or DMR. So we have got 2 types of muscle relaxants, NDMRs and DMRs. So NDMR is competitive antagonist. It is very, very simple. Competitive antagonist at nicotinic acetylcholine receptors in post-junctional muscle membrane. So basically it will come, bind, not do anything, and therefore call muscle relaxation. So it's very easy to understand. But can you understand that muscle relaxation, depolarization means contraction. So can a muscle relaxant be both contracting and relaxing at the same time? Can a muscle relaxant be both contracting and relaxing at the same time? Very unlikely, and that makes choline such a beautiful drug. So whenever you hear the word choline, it should come to your mind that it is basically diacetylcholine. So the two molecules of acetylcholine have joined. So this is basically a younger brother of acetylcholine. It's a brother of acetylcholine, and therefore most of its properties are similar to acetylcholine, but not exactly the same, because it is not a twin. It is just a younger brother. So tell me, what is the mechanism of action of acetylcholine? Anyone? Mechanism of action of acetylcholine? Mechanism of action of acetylcholine? Mechanism of action of acetylcholine? Yes, it is a complete agonist at acetylcholine receptor. This is a younger brother, so it will not have all the qualities of elder brother. So it's a partial agonist at acetylcholine receptor. Tell me, how does acetylcholine gets metabolized? See, when I say mechanism of action, then you don't tell me that depolarization, that repolarization. That is not how acetylcholine works. Acetylcholine is a neurotransmitter. It is not a ion channel. I'm not talking about how acetylcholine receptor acts. It is the acetylcholine receptor that depolarizes and repolarizes, not acetylcholine. Acetylcholine is a neurotransmitter. And Shreyasi, it doesn't only act on muscarinic. Is acetylcholine only a muscarinic agonist? So what about nicotinic? What did I just tell you in NMJ? Acetylcholine is not acting on nicotinic acetylcholine receptor. It is, right? So it acts on both. It is a acetylcholine agonist. Now, how does acetylcholine gets metabolized? Acetylcholine esterase, which is present where? At the junction. But this is younger brother, so it is little deviant. So it is metabolized by plasma cholinesterase. This plasma cholinesterase is also called as pseudocholinesterase or butyryl cholinesterase. It is also called as pseudocholinesterase or butyryl cholinesterase. These are the 2 points of difference between choline and acetylcholine. It is two molecules of acetylcholine that are joined together, and it differs in these two basic things, and this forms the basis of action of succinylcholine. So despite of being a partial agonist, it is still acting as a muscle relaxant. Let's see how. Now first try and understand. This is NMJ, right? Now you have injected succinylcholine into the system, and now the succinylcholine comes and diffuses and attaches to the acetylcholine receptor, right? Now what is the mechanism of action of succinylcholine? It is a partial agonist, so there will be depolarizations, but they will not be complete. There will be partial depolarizations, right? So there will be depolarizations, but they will be partial. If complete depolarization in NMJ causes muscle contraction, complete contraction, then partial depolarization will lead to muscle fasciculation, fast contraction of individual motor units, muscle fasciculation. So it is coming and causing partial agonism that produces fasciculation. So partial agonism causes fasciculations. Partial agonism causes fasciculations. Partial agonism causes fasciculations, right? Now what happens? How does acetylcholine gets metabolized? Acetylcholinesterase, which is present where? At the junction. So it immediately metabolizes the acetylcholine, splits into acetyl and choline, and the muscle gets repolarized. But where is plasma cholinesterase present? Back in the plasma. So will succinylcholine stay at a receptor for lesser or longer time as compared to acetylcholine? Longer. Why? Because for it to get metabolized, it has to diffuse out from the NMJ and reach the plasma membrane, plasma, then only it will get metabolized, right? So it stays at the receptor for a longer time. So there is a persistent depolarization of the NMJ. Persistent. So under normal condition, this persistent depolarization would have caused persistent contraction of the muscle. But here's the catch point. There are two types of sodium channels that propagate the nerve impulse through the NMJ. One is the junctional sodium channels, which is present right at the junctional. And another is perijunctional sodium channels. Another is perijunctional sodium channels. Now these junctional sodium channels are voltage gated. That is, they open and close based on change in the voltage across them, while these perijunctional sodium channels are time gated. That is, after they open through a wave of depolarization, they close after a particular point of time. They are time gated. So this is like an inherent safety mechanism in the NMJ so that there is not undue muscle contraction because of increased stimulation. So what happens that after a particular time, these perijunctional sodium channels will close. So what will happen? There is persistent depolarization from the top, but because perijunctional sodium channels are closed, there is no more impulse transmission through the muscle, and therefore the muscle relaxes. This is the mechanism of action of succinylcholine, and I want you all to write this properly, that partial agonism causes fasciculation, while metabolism by plasma cholinesterase causes persistent depolarization. And this persistent depolarization leads to closure of time dependent perijunctional sodium channels. Closure of time dependent perijunctional sodium channels that will cause muscle relaxation. And this type of block is called as phase 1 block of scoline. This type of block is called as phase 1 block of scoline. I'm going to wait here for a minute and let you analyze what I have just told you, and if there is any doubt, I want you all to ask now, because everything in muscle relaxants is an outcome of their mechanism of action. So if you understand the mechanism of action, then you will understand everything. But if you are not able to understand the mechanism, then it becomes very, very difficult to relate to anything that I'm going to teach in the next 1.5 hours. So take 5 minutes of your time and analyze both mechanisms, and then if there are any doubts, then you can let me know. No, Suvankar, I will not explain the mechanism part again. That is why I am making you write everything. You have to read it and you have to specifically ask what is that you did not understand. Explaining the whole mechanism again is just counterproductive because I take every bit of time to make you understand every single point step by step. So read it. You have already written it. Now tell me what is the part that you did not understand. And then I'll only specifically with that part, deal with that part. Yes, that is more like a specific query. Why persistent depolarization leads to closure of time dependent channel? What do you mean? What do you understand by a time dependent channel, time gated channel? That means once it is open, it will close after a particular point of time, right? Now, it doesn't matter whether there is persistent depolarization or not, but this persistent depolarization should ideally keep the channel open. But because it's a time gated channel, irrespective of persistent depolarization, it will still close it because its function is to close the channel after a particular time. So it is not persistent depolarization that is leading to closure. It is the closure of the channel that is leading to muscle relaxation. You are getting my point? It is like an inherent safety mechanism in the NMJ so that for any reason, if there is constant stimulation of the muscle, that can lead to muscle damage. So it is like a physiological safety mechanism where even if there is constant stimulation of the muscle will stop contracting after a point of time because the time dependent sodium channels will close and therefore it will give time for the muscle to regenerate. Okay. It has nothing to do with the time it takes for muscle relaxant to act. In fact, it is the fastest acting. Anamika, under normal circumstance, even if you try, you can never cause persistent depolarization because there will always be acetylcholine that will still get metabolized. But if you see, you do get tired, right? You do get tired. So you are not able to cause muscle contraction. So you cannot keep this time gated channel in the context of normal physiology because in normal physiology there is no drug induced persistent depolarization. Acetylcholine will get immediately metabolized from the NMJ. Okay. And Varsha, it has nothing to do with the onset of action. In fact, choline is the fastest onset muscle relaxant. The idea is what is the mechanism that a depolarizing agent, one that is partial agonist, is causing muscle relaxation. No, why? How can acetylcholine cause perijunctional block? Acetylcholine gets metabolized immediately. So in no circumstance will acetylcholine cause persistent depolarization of the muscle of the NMJ. You have to understand this is a drug induced persistent depolarization. Drug induced persistent depolarization. And you have to also understand the time scale is so, I mean, this is not something that I should actually tell you. But when we say that Choline stays on the receptor for a longer time as compared to acetylcholine. It is only 1/10 of a second more. And all of this will happen in that time. Only 1/10 of a second, 0.1 second more than acetylcholine. Okay. So Anamika, you got your doubt. Varsha, Varun, Suvankar, you haven't replied. You ask a doubt. When I reply, please give me a feedback whether you have understood, not understood, or you have left the doubt, so that I can move on. You know. So once again, I'll repeat. Succinylcholine, two difference than acetylcholine. Acetylcholine is complete agonist. Succinylcholine is partial agonist. Acetylcholine gets metabolized by acetylcholinesterase, which is present at the junction. Succinylcholine metabolized by plasma cholinesterase, which is present in the plasma. A combination of these two causes muscle fasciculation, and persistent depolarization leads to muscle relaxation. This type of block is called as phase 1 block of choline. And choline is one of the most interesting things that you read in anesthesia. So let's first discuss choline in detail. So choline, also called as succinylcholine, also called as succinylmethonium. Let's start with pharmacokinetics. Onset of action is 30 to 60 seconds, which is fastest. Duration is less than 10 minutes, which is shortest. And in front of these you can write overall. Overall means if you compare all muscle relaxants, that is NDMRs and DMRs, overall succinylcholine is fastest and shortest. Metabolism is by plasma cholinesterase. Excretion is renal, and dose is 1.5 to 2 mg per kg. Dose is very important. I have not given you many doses till now. I will in total give you 7-8 doses in anesthesia. Not that doses are not important for anesthetist. We have to remember hundreds of doses. Everything is about dose for an anesthetist, but at your level, if I give you doses of everything, you will not remember anything. So there are 7-8 drugs, 7-8 times when doses are important for you. Wherever in your notes you find a dose, you have to remember it. No questions asked. Alright, so this is pharmacokinetics, and the most important part of the action of choline is this fast onset and very short duration of action, and this forms the basis of its use because it is fastest in onset and shortest in duration. Therefore, it is considered as agent of choice for tracheal intubation. Tell me, what was the safe apnea time after pre-oxygenation? How much was the safe apnea time after pre-oxygenation? 10 minutes. And what is the duration of action of choline? 10 minutes. So even if you fail to intubate a patient, before the patient starts to desaturate, the patient will start breathing. That is why for drug of choice for tracheal intubation is succinylcholine. Also, it is a preferred agent in RSI, rapid sequence induction, which is a part of complication in anesthesia that we will discuss later today. Okay, so just write preferred agent in RSI. Preferred agent in RSI. Very good. So agent of choice for tracheal intubation and preferred agent in RSI. Now the pretext of use of succinylcholine is that it has got a very predictable and short duration of action. So therefore anything that increases the duration of action of choline needs to be known and treated accordingly. So let's look at increased duration of action of choline can be divided into two major parts: phase 2 block and altered metabolism. Phase 2 block and altered metabolism. Let's understand altered metabolism. Succinylcholine can have a prolonged action due to altered metabolism because of three factors. hypothermia. In hypothermia, metabolism of all drugs gets decreased. Therefore, almost all drugs, they have increased duration of action because overall the metabolism slows down. Deficiency of the enzyme, deficiency of plasma cholinesterase or decreased enzyme, or genetically abnormal enzyme, genetic abnormality of enzyme. Which enzyme? Plasma cholinesterase. So you can have genetic abnormality of the enzyme, right? Now let's look at the reasons for deficiency of plasma cholinesterase. It can be seen in conditions like liver failure, renal failure, pregnancy, and certain drugs. Which drugs? Ones that inhibit the activity of cholinesterase, like ichthyopate. It's a topical anti-glaucoma drug. Ichthyopate, neostigmine, cyclophosphamide. Now you will say, sir, ये क्या लिख रहे हैं? ऐसे तो हजारों drugs होंगी. Yes, होंगी, but ichthyopate has already been asked in a question as a drug interaction. The question was, a 72-year-old glaucoma patient was taken up for a surgery and was given succinyl choline, and after giving choline he didn't breathe for 1 hour. Which of the following drugs would be implicated? And one of the drugs was ichthyopate. They gave 4 anti-glaucoma drugs. So ichthyopate is an anti-glaucoma drug that is a cholinesterase inhibitor. Alright, so this has already been asked in the exam once. This is a very interesting concept, genetic abnormality of the enzyme. So an abnormal enzyme will not be able to metabolize choline, and therefore the choline will have prolonged action. Okay? So genetic abnormality will produce abnormal enzyme. Abnormal enzyme will not be able to metabolize choline. Less metabolism of choline, and this will lead to prolonged action. Now, there can be 2 types of genetic abnormality. Either it can be a homozygous genetic abnormality or heterozygous. So we need to find out which type of genetic abnormality is present, right? So let's look at the diagnosis of abnormality. How do you diagnose this abnormality? So for this we have a test called as Dubuquin number. We have a test called as Dubuquin number. What is Dubuquin number? So Dubuquin is a long acting local anesthetic that has a tendency to inhibit the activity of plasma cholinesterase. Dubuquin is a long acting LA that inhibits the activity of plasma cholinesterase. So the percentage inhibition of plasma cholinesterase by Dubuquin is called as Dubuquin number. Whatever percentage of plasma cholinesterase gets inhibited by Dubuquin will be called as Dubuquin number. Based on this, we can comment about the genetic abnormality, because an abnormal enzyme does not get inhibited by Dubuquin that well. So let's look at Debukane number genetic abnormality and duration of action. So a normal enzyme will show a Debukane number between 60 to 80. So 60 to 80% of normal enzyme gets blocked by Debukane. So the duration of action less than 10 minutes. So if Debukane number is 60 to 80, you can say that the enzyme is normal and the action would be less than 10 minutes. But if the Debukane number decreases, it becomes 40 to 60. That means it's an abnormal enzyme and this abnormality is not that high. So it is a heterozygous abnormality and the action becomes twice 20 minutes. The action becomes twice 20 minutes. While if there is severe abnormality, that means it's an abnormal homozygous enzyme, then the Debukane number will fall too much. That means it will be in the range of 20 to 40 and then the action could be 1 to 3 hours. The action could be 1 to 3 hours. So you can have a genetically abnormal enzyme which will prolong the duration of action of choline, because this genetically abnormal enzyme will not be able to metabolize choline properly. How to diagnose this genetic abnormality? So we take a long-acting LA. This long-acting LA has a tendency to inhibit the activity of plasma cholinesterase, but it only effectively inhibits normal plasma cholinesterase, that means 60 to 80. But if it is not inhibiting the plasma cholinesterase, that means you can say that okay, there is some problem with the enzyme. If it is between 40 to 60, that means it is abnormal homozygous. So the action would be say twice. But if it is an abnormal homozygous enzyme, abnormal homozygous is 20 to 40. If it is abnormal homozygous, that means it's a severe type of abnormality and the action could be 1 to 3 hours. So where you were expecting less than 10 minutes and up to 3 hours, the patient will not breathe. So you should know as a diagnosis that okay, this can happen. Now look at this table of Debukane number and tell me if I ask you that Debukane number is a qualitative assessment of enzyme function or it's a quantitative assessment of enzyme function. If I ask you that Debukane number is a qualitative assessment of enzyme function or a quantitative assessment of enzyme function, qualitative or quantitative? Qualitative or quantitative assessment of enzyme function? Okay, Shreyasi says qualitative, but Bhaskar says quantitative. Very good, Bhaskar. I was expecting you to say quantitative. Very good, quantitative. Everybody is saying quantitative. Very good. So the majority says quantitative. Why? Because there is number, right? So let's, for an example, say that I have got a sample of a plasma cholinesterase where I have done Debukane test and I have found out that the enzyme activity is suppressed by 50%. So the Debukane number is 50. Debukane number is 50. Now look at this table above and tell me what information can you get from this Debukane number of 50? Debukane number of 50. Does it tell you that the percentage of enzyme that is normal is 50%, or it tells you that it is a normal or an abnormal enzyme, and if it is abnormal, then what type of abnormality is present? Tell me. A Debukane number of 50, you have the table in front of you. Can you tell me by looking at this table that 50% enzyme is normal and 50% is abnormal? Is it telling you what the quantitative assessment of enzyme function? Or it is merely telling you that it is a normal or abnormal enzyme, and if it is abnormal, then what kind of abnormality? It is only commenting about the type of abnormality. So it is not a quantitative assessment of enzyme function. Zaruri nahi hai that if you see a number that means it is quantitative. Quantitative means it should tell you about the quantity of normal and abnormal enzyme, which doesn't happen with Debye number. So write in front of Debye number that it is a qualitative assessment of enzyme function. It is a qualitative assessment of enzyme function, right? It can only tell you whether an enzyme is normal or abnormal, and if it is abnormal, then whether it is a homozygous abnormality or a heterozygous abnormality. Okay, homozygous or heterozygous. ठीक? So these are altered metabolism. Now let's come to this unique entity called as phase 2 block. Phase 2 block. So again, it is more of a complication of overuse of scoline rather than one of the reasons, but it can prolong the duration of action of scoline. So the dose of scoline is 1.5 to 2 mg per kg. So what if you kept on giving scoline? So when you use scoline in high dose, that means 7 to 10 mg per kg for long time, more than 60 minutes, then this causes some non-specific changes in the receptor and now the block starts to behave like NDMR type of block. This is phase 2 block. Block starts to behave like NDMR type of block. Okay. Now look at this. This is increased duration of action of scoline. Scoline is a muscle relaxant. So if its action is prolonged, then how will the patient present to you? Clinically, you gave 1 dose of scoline. The patient was supposed to start breathing in 10 minutes and the patient has not started to breathe. So prolonged duration of action of scoline will present to you as apnea in the patient. And how do you manage apnea? How do you manage apnea? How do you manage apnea? Remember in this thing, remember, anywhere if you have to manage apnea, then how do you do it? One word answer. If patient is not breathing, you give them breaths. Mechanical ventilation. So treatment of any type of apnea would be sedation plus mechanical ventilation. So prolonged duration of action of scoline will always be sedation and mechanical ventilation. Sedation and mechanical ventilation. Sedation and mechanical ventilation. Why bag and mask? Why, Varun? Why you always resort to the most difficult thing in the world? You think bag and mask is easy to do? Try it next time when you are in the theater. Tell an anesthesia resident to let you do bag and mask. 30 seconds of bag and mask and both your hands go into spasm. Bag and mask is one not very effective way of ventilating the patient. Secondly, it is a very labor intensive process. So bag and mask is always for emergency purposes, never for elective purposes. Remember this thing. And the answer is sedation and mechanical ventilation. Alright. So this is prolonged duration of action of scoline. It's a very, very important table. Let's look at adverse drug events. Again, succinylcholine is very unique in its adverse drug effects also. Many adverse drug effects. Let's start with cardiovascular. I told you it's a partial agonist at acetylcholine receptor. So it acts on both muscarinic as well as nicotinic. Muscarinic stimulation of SA node will lead to bradycardia. Muscarinic stimulation at SA node will lead to bradycardia. Fasciculations. Now fasciculations are because of partial agonistic action, right? you have studied that in physiology. See, CO2 is a respiratory stimulant. Of course, no. Of course, if there is buildup of CO2, your respiratory rate will increase so that you can wash out that CO2. So that is like a respiratory stimulant. But you never give CO2 to any patient for respiratory stimulation. You just decrease the rate of ventilation to promote ventilation. So there is natural CO2 buildup in the body. Like if I want to extubate a patient, I will allow them to have a permissive hypercapnia. I will let them accumulate some of the CO2 in the lungs so that it stimulates their respiratory drive. But we never give CO2 to a patient so that he starts breathing. Okay, that is not what we do, because we have an internal source of CO2, so we don't need to supplement CO2 from outside. Fasciculations. Now fasciculations are a byproduct of partial agonism, and partial agonism of acetylcholine receptor causes fasciculations. Now fasciculations cause lot of myalgia in the post-operative period. Therefore, we need to decrease the intensity of fasciculation. How can you decrease intensity of fasciculation? You can decrease the intensity of fasciculation by giving a defasciculating dose of rocuronium. So what we do is we give 1/10 dose of an NDMR before we give scoline. This will go and bind to some of the receptors, acetylcholine receptors, and that will make less number of receptors available for scoline, so less intensity of fasciculation. Similarly, myalgia, we will give analgesics. Myalgia, we will give analgesics. For myalgia, we will give analgesics. Apart from this, these are the side effects: increased ICP and IOP, masseter spasm, trigger for malignant hyperthermia, histamine release, and hyperkalemia. Just make a note of this thing. I'm coming in 2 minutes. Okay. Okay, so Varad, you are saying that first resort to apnea will be bag and mask followed by mechanical ventilation once available. No, but you have to understand the context here. You are giving scoline for the purpose of endotracheal intubation for surgery. So you already have a tube in place and now the patient is not breathing after that. So you will continue mechanical ventilation. Here there will be no question of bag and mask. You're understanding? It's not like somebody is walking on the road and you give them scoline and then wait for 10 minutes and then you again bag mask and then intubate the patient. Understood? The context is the patient is already on the table for a surgery. You gave scoline, you expected the action to be over in 10 minutes, but after 1 hour also the patient is not breathing. After 2 hours also the patient is not breathing. Now the surgery is over, still the patient is not breathing. So you will continue mechanical ventilation. Okay? Alright? So these are the complications, that is adverse drug effects. Now can you think of a reason why use of scoline should cause hyperkalemia? Can you think of a reason? Why use of scoline should cause hyperkalemia? Is there a reason why use of scoline should cause hyperkalemia? See, it's a depolarizing muscle relaxant. When you give scoline, what happens in all the NMJs of the body? There is depolarization. What do you mean by depolarization? Sodium goes in, potassium comes out. So, when you use scoline under normal conditions, there is always a rapid and transient rise of serum potassium by 0.5 milliequivalents per liter, because persistent depolarization in all the muscles of the body will lead to some amount of potassium coming out, and this can cause transient and rapid rise by 0.5 milliequivalents per liter. Not too much. It is rapid and transient rise by 0.5 milliequivalents per liter, which doesn't really create too much of trouble unless and until the patient is already pre-existing hyperkalemic. Under normal circumstance, it would not make a difference. But then there are certain conditions where there is chronic denervation injury. Chronic denervation injury. Now, what is this chronic denervation injury? So these are conditions where something has happened that has caused the nerves to denervate from the NMJ. So now nerves are no more on the muscle end plate. So what is muscle feeling? I am not contracting because I am not getting enough impulses. The reason the muscle feels that the impulses are less is because it has got less NMJ. So all conditions where there is chronic denervation injury, there is increased production of extrajunctional acetylcholine receptors, because you have only limited space at the junction. So the muscle starts producing extrajunctional acetylcholine receptors to compensate for this denervation. And a property of these extrajunctional acetylcholine receptors are that they are leaky by nature. That means they cause massive ion exchange. So in any chronic denervation injury, if you give succinylcholine, then there will be massive hyperkalemia that would be sudden, which can even lead to sudden death. So all these conditions where there is chronic denervation injury, use of scoline will be contraindicated. All the conditions where there is chronic denervation injury, use of scoline would be contraindicated. Use of scoline would be contraindicated. What are these conditions? What are these? So I'll give you a photograph to make you understand this thing. You can see. The upper one is a normal muscle. See, these are normal NMJs at the junction. So succinylcholine comes, there is some release of potassium. Now this is a de-innervated muscle. You can see the number of receptors have increased so much, and most of them are extra junctional, so they are leaky. So now there is massive release of potassium that can cause sudden hyperkalemia and death. What are these conditions? These are the conditions where there is chronic de-innervation injury, burns, massive trauma, spinal cord injury, stroke, GB syndrome, tetanus, prolonged total body immobilization, and certain myopathies like Duchenne muscular dystrophy. Certain myopathies like Duchenne muscular dystrophy. Certain myopathies like Duchenne muscular dystrophy. But this burns again presents to us with a unique problem. See, I told you it is chronic denervation. So it takes some time for the muscle to realize that there is denervation and then compensatory increase in production of receptors. So that doesn't happen immediately. But we get burns patient in acute phase also. So will you not give scoline? You can. Till what time can you give scoline? So after a burns injury, it is safe to use scoline in the first 24 hours after burns, and afterwards it is unsafe up to 2 years. So after you have crossed this first stage of 24 hours, then after up to 2 years, you should avoid the use of scoline, because this chronic denervation component can cause massive hyperkalemia. So therefore burns history is one of the very important histories that we ask to almost every patient. History of burns. And especially if we are in a plastic OT, most of the cases of post-burn contracture are difficult airways, but we cannot use scoline if they are within 2 years after their burns. Alright. So this is a list of all the places where chronic denervation injury can lead to sudden massive hyperkalemia and death. So all of these are potential contraindications for the use of scoline. Let me know when you are done writing this point. Okay. Now let's look at contraindications. So apart from all the chronic denervation states, you would avoid it: head injury because of raised ICP, malignant hyperthermia because it triggers it, open eye injury or glaucoma because increased IOP, hyperkalemia pre-existing is a contraindication, myotonica dystrophica again because of sudden massive hyperkalemia, and any pediatric patient below 8 years of age, you would avoid the use of scoline. Now somebody would ask, sir, why so? Because undiagnosed myopathy in a pediatric patient can lead to sudden hyperkalemia and death. See, myopathies go unnoticed in a child because everybody says that they might have stunted growth, so people don't really pay too much of attention. And it has been noted that if you take a child who is less than 8 years of age, then they have noted that sometimes after giving scoline there is sudden cardiac arrest, and later on autopsy it was found that the patient had a myopathy that led to this chronic denervation injury. So as a black box warning, black box means it's a suggestion that as a blanket thing, we avoid the use of scoline in all pediatric patients below 8 years of age for the fear of undiagnosed myopathy leading to sudden hyperkalemia. And anamika, why safe after 2 years? Because in 2 years this chronic denervation and causing and this effect of increased production of extrajunctional acetylcholine receptors would be negated. So it would be almost normal NMJs, and therefore choline will not have any undue risk of what you can say hyperkalemia, undue risk of hyperkalemia. So this is what I wanted to tell you about choline. This is what I wanted to tell you about choline. Now let's come to the easy part of the discussion, which is NDMR, and we'll try to finish NDMR in 15 minutes already. I think I got overboard in the morning with some motivation, and so we are lagging behind, say, half an hour. So we'll try to pick it up before lunch, because after lunch anyway there is a slumber in your sleep cycle, so you tend to get little slow. So let's pick it up. Non-depolarizing muscle relaxants are classified based on two things: chemical structure and duration of action. Chemical structure and see, it's patients in ICU, basically chronically ill patients. Don't go into the details of prolonged total body immobilization, because that is a completely different set of patients. There are chronic ICU patients who tend to develop a lot of myopathic features. Okay, its definitions, its criterias are all very detailed, and usually that are discussed in intensive care. So it is not something that will be asked to you. It's just one of the things that you have to remember, because it's a part of the whole paradigm of where all you can possibly get increased duration of action of or increased hyperkalemic action of choline. Now, based on chemical structure, NDMRs are classified into benzyl isoquinoleum derivatives that can be seen with the suffix urium, and steroidal derivatives with suffix onium, and you can divide them into long, intermediate and short acting muscle relaxants. Long, intermediate and short acting muscle relaxants. Guys, just a minute. Write this thing down. Sorry for that interruption. Okay. So a long-acting benzyl isoquinoleum derivative is doxycurium, DTC, that is D-tubocurarine. Intermediate is atra, cis-atra, and short-acting is gantacurium and mevacurium. A long-acting steroidal derivatives is pancuronium, pipecuronium. Pancuronium and pipecuronium. Intermediate acting is vecuronium, rockuronium. Vecuronium and rockuronium. And there are no short acting steroidal derivatives. There are no short acting steroidal derivatives. There are no short acting steroidal derivatives. Now, whenever we get a classification like this, a very common question that comes out of it is, which is the longest, which is the shortest, which is the fastest, which is the slowest. So actually slowest nobody asks, but fastest, longest and shortest. So longest is doxycurium. Mark it. Longest is doxycurium. Now in shortest there is a catch point. If gantacurium is in the options, then it becomes the shortest. But if it is not in the option, then mevacurium becomes the next choice. You will ask, sir, aisa kyun? First, second. See, gantacurium is still a research drug. It is still a research drug. So there are some examiners who want to ask you anything, whether it is practical or not practical. So they will give you gantacurium in the option. So if ganta is present, that means the examiner wants you to know that gantacurium is the shortest and therefore the question is being asked. So remember ganta. But if it is not present, then practically available what we use is mevacurium. So gantacurium is shortest and second shortest is mevacurium and fastest is rockuronium. Fastest is rockuronium. Fastest is rockuronium. Fastest is rockuronium. Alright. Now we'll come to pharmacokinetics. We know pharmacodynamics, it's a muscle relaxant. Pharmacokinetics will solve some 5-7 very easy questions that are asked to us from NDMR. And we will make a table and we'll finish them off in style. This table is very informative and doesn't take too much of space, so it will come in one paper. So let's start with the first column, that is relaxant, metabolized by which organ, excretion by which organ, onset, duration, ability to cause histamine release and vagolytic action. 7 columns. 7 columns. 7 columns. Now let's start with benzyl isoquinoleum derivatives, cis-atra, atra and mevacurium. Cis-atra, atra and mevacurium. Now very unique thing that we already know about cis-atra and atra is that it has organ independent metabolism in the name of Hoffman's elimination. organ independent metabolism in the name of Hoffman's elimination. So organ of metabolism excretion doesn't matter. Onset of both is intermediate, or rather moderately rapid. Moderately rapid means 3 to 5 minutes. 3 to 5 minutes. Duration is intermediate. Duration is intermediate. Cis-atra doesn't release histamine, while atracurium releases histamine, and they are non-vagolytic. They are both non-vagolytic. They are both non-vagolytic. They are both non-vagolytic. Mivacurium is the only NDMR that is metabolized by plasma choline esterase. Again, organ independent. It's a plasma based enzyme, so organ of excretion does not make a difference. Organ of excretion does not make a difference. Plasma choline esterase. Onset is same, moderately rapid. Duration is short. We know it is second shortest, short. And yes, it releases histamine but no vagolytic action. So it's similar to atracurium in releasing of histamine. So these are three commonly used benzyl isoquinoleum derivatives. The three steroidal derivatives are rocuronium, vecuronium, pancuronium. Roc, vec and pan. Now rocuronium has no metabolism. It is excreted unchanged in bile and urine. It is excreted unchanged in bile and urine. Onset is fast. How fast? 60 to 90 seconds. That is why it is considered to be fastest NDMR. Overall, which is the fastest agent? Overall, which is the fastest muscle relaxant? Tell me. Duration, again intermediate. No histamine release, slight vagolytic action. Slight vagolytic action. Vecuronium, metabolism in liver, excretion, renal, moderately rapid onset of action, intermediate duration of action, no histamine release, non-vagolytic. And pancuronium, again metabolism, liver, excretion, renal, slow onset of action, long duration of action, no histamine release but very potent vagolytic. Very potent vagolytic. Very good, Bhaskar. Succinyl choline is fastest overall. Very good. This table solves 5 to 6 very easy questions that come from pharmacokinetics of muscle relaxants, especially NDMRs. What kind of questions? Which of the following agents should be contraindicated in patients with asthma? The ones that release histamine. Kyun? Because they can precipitate an attack of bronchospasm. So atra and mivacurium. Which of the following agents are to be avoided in renal and or hepatic failure? So mivacurium, the ones that are metabolized or excreted. So rocuronium, vecuronium, pancuronium. Which of the following has highest vagolytic action? Pancuronium. Which of the following can replace choline as a drug of choice for intubation? Rocuronium, because similar fastest onset of action. Which of the following is only NDMR that is metabolized by plasma choline esterase? Mivacurium. Which of the following can be safely given in a patient with renal or hepatic failure? Cis-atra and atra, right? So these are some common questions that can be derived from this table of pharmacokinetics, right? So this is a very, very important table and it has to be read in this order. First benzyl isoquinoleum derivatives, then steroidal derivatives. Okay. Let's see at indications. So again, NDMRs are more widely used for muscle relaxation during surgery. They can be used for intubation, defasciculation or precurarization. Agent of choice for these two conditions is rocuronium. While for maintenance phase of relaxation, you want a drug with predictable offset of action. So it is atra or cis-atra. Atra or cis-atra. Bhaskar, I'll put the pharmacokinetic slide. Just write this slide. Okay, this is pharmacokinetic slide. Okay. See, it's not about that you can't give rocuronine for maintenance phase of the relaxation, but it's just that atrans etc. because of its virtue of a non-organ dependent metabolism has a very predictable offset of action. When the surgery is over, the patients will almost always come out of the effect of muscle relaxation on time. That is why you would prefer to give atrans etc. over other agents that have organ dependent metabolism. Okay. Why metabolism? अच्छा, metabolism नहीं होता है. There is no metabolism. It is exchanged unchanged in bile and urine. It is it is excreted unchanged in bile and urine. It has no metabolism. It has no metabolism. Okay. Chalo. Let's see some drug interactions. What are the effect of other drugs on the action of muscle relaxants? So there are drugs that can increase the potency of muscle relaxants and drugs that can decrease the potency. Increase potency, the most common thing is a drug called as dandrolin, which is a skeletal muscle relaxant, also agent of choice for treatment of malignant hyperthermia. Antibiotics can have prolonged duration of action of muscle relaxants. Example, streptomycin, aminoglycosides, amikacin, magnesium sulfate, furosemide, inhaled anesthetic agents are inherent muscle relaxants. Inhaled anesthetic agents are inherent muscle relaxants. The order of inhaled anesthetic agents causing muscle relaxation is maximum muscle relaxation is with desflurane, followed by sevoflurane, followed by isoflurane, followed by halothane. Des, sevo, iso, halo. Maximum muscle relaxation is shown with des, then sevo, iso and halo. All right. Now, decreased potency. So it is easy for decreased potency. Cholinesterase inhibitors, calcium, and anti-epileptics. This will decrease the potency of muscle relaxant and therefore make the duration shorter. Cholinesterase inhibitors, calcium, and anti-epileptics. Cholinesterase inhibitors, calcium, and anti-epileptics. Alright, so these are drug interactions of NDMR. Now we have done a general discussion of NDMR. Now we will reserve ourselves to only specific things about specific drugs. So we know everything about every drug. Now let's see something that we need to know extra. So let's start with atracurium. And we already know that atracurium is a benzyl isoquinoline derivative that has a moderately rapid onset of action and an intermediate duration of action that releases histamine. But let's talk about its metabolism. We know that it is metabolized by a non-organ dependent process called as Hoffman's elimination, but that is not the only process. There are two processes. One is metabolism by non-specific plasma esterases, again which are plasma based enzyme, and Hoffman's elimination. Now this is a plasma based enzyme. What is Hoffman's elimination? It is spontaneous degradation of the enzyme of the molecule under physiological pH and temperature. It is spontaneous degradation of the molecule under physiological pH and temperature. So both are non-organ dependent processes, and we thought we know enough about them. But then Ames asked us what is the percentage of metabolism by each process. So 2/3 of metabolism is by non-specific plasma esterases, while 1/3 of metabolism is by Hoffman's elimination. Now what happens is, when there is spontaneous degradation of atracurium by Hoffman's elimination, it forms a metabolite. The name of that metabolite is laudanosine. And this laudanosine is excreted renally. Now the problem is that in cases of renal failure, if there is accumulation of laudanosine, then this laudanosine has a seizure potential. And this is not something that has been reported in human beings. That has been reported in rats under controlled situation, but this makes a very good MCQ point for us. So remember, Hoffman's elimination is a spontaneous degradation of the molecule under physiological pH and temperature. When the molecule degrades, it forms a metabolite called as laudanosine, which under normal circumstances gets excreted renally, there is no problem. But suppose the patient is a renal failure patient, so the excretion of laudanosine will not happen properly and there will be accumulation of laudanosine, which can then lead to seizure potential because laudanocin can induce seizures in controlled scenarios. This is not something that should deter you from marking the answer that which of the following agents is preferred in renal and hepatic failure. The answer would still be atra and cis-atra. Why? Because this is a theoretical complication, has never been reported in human beings. But if at all they ask you about laudanocin toxicity, then you need to know that in cases of renal failure, it has a seizure inducing potential. It has a seizure inducing potential. Okay. It has a seizure inducing potential. This is about atracurium. Now atracurium's bigger brother is cis-atracurium, which is 100% pure cis isomer of atra. It is 100% pure cis isomer of atra. It is 100% pure cis isomer of atra. And there are 4 points of difference between atra and cis-atra. 4 times more potent than atra, no histamine release, no ester hydrolysis. That means 100% of metabolism is by Hoffman's elimination and no risk of laudanocin toxicity. 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 Right? So this is atra and cis-atra for you. Atra and cis-atra. Alright. Next is rocuronium, and if you look at the first 2 letters of rocuronium, then you will understand the most important point about rocuronium: rapid onset. That is 60 to 90 seconds, which is similar to scoline. So it is only NDMR that can replace scoline for intubation. Only NDMR that can replace choline for intubation. Only NDMR that causes pain on injection. And only NDMR that has no metabolism. 3 unique things about rocuronium. It is fastest NDMR. Just write here again, fastest NDMR. It is fastest NDMR. It is fastest NDMR. Alright. So this is about the commonly used non-depolarizing muscle relaxants that we talk about. Commonly used non-depolarizing muscle relaxants we talk about. Now for the sake of completion, we'll write few old NDMRs. Old NDMRs, that is just to complete the list. So like the first clinically used NDMR was DTC, D-tubocurorin. It has a property of maximum histamine release and it also blocks the autonomic ganglia. Galamine is most potent vagolytic with renal excretion, and mivacurium is shortest acting NDMR, releases histamine, only NDMR to be metabolized by pseudocholinesterase and therefore considered as agent of choice for daycare surgery. Therefore considered as agent of choice for daycare surgery. Complete this and let me know, give me a thumbs up, and then we'll proceed to neuromuscular recovery or reversal of neuromuscular blocking agents, and then I'll give you a quick 10-minute break for having a tea. Done? Are you guys done writing? Very good. Chalo. Now moving on to the next topic, which is a extension of this topic. That means how to reverse the effect of neuromuscular blocking agents. It's a very short, quick topic, and I told you, if you understand the mechanism of action, then everything else falls in place, right? So we have two types of muscle relaxants, that are DMRs and NDMRs, and most commonly used for maintenance phase of anesthesia are NDMRs. NDMRs are intermediate or long acting, and therefore reversal of neuromuscular block becomes very, very important. So we divide muscle relaxants into two categories. One that need drugs for reversal, and another that don't need drug for reversal. So which agents will not need any drug for reversal? Obviously the ones that have non-organ dependent metabolism. Example: atra, cis-atra, scoline, meva. These have non-organ dependent metabolism. So these four drugs should not require any other drug for their reversal of action. These four drugs should not require any other drug for the reversal of their action. Apart from that, what is remaining? All other NDMRs will need drugs for reversal. All NDMRs. All other NDMRs. So which drugs? So mechanism of action of NDMR is, it's a competitive antagonist at nicotinic acetylcholine receptor. So if you want to reverse the effect, what will you do? You will supply more acetylcholine. So there are two types of reversal agents. Common ones that are used is choline esterase inhibitors, that will increase acetylcholine concentration around receptor, isn't it? Examples: neostigmine, physostigmine, edrophonium. Neostigmine, physostigmine, edrophonium. But these choline esterase inhibitors are non-specific, so they will always be associated with muscarinic stimulation. So you always add an anticholinergic agent. Always add an anticholinergic agent to eliminate muscarinic side effects. In this also, glycopyrrolate is preferred over atropine. Again, the same reason. Glycopyrrolate is a quaternary ammonium compound, so no CNS action, and therefore it is preferred over atropine. It is preferred over atropine. So you always give a choline esterase inhibitor in combination with a anticholinergic. So it's neostigmine, glycopyrrolate, edrophonium, atropine, this like this. Always give it in combination to each other, so that you also eliminate the muscarinic side effects. This is the traditional reversal agent that we use. all the day, every day. Now a newer drug has come in the market called as Sugamadex, which is first relaxant specific reversal agent. Relaxant specific reversal agent. It is reserved for steroidal derivatives ROC and VEC, and this causes instant reversal. It is like an antidote. Instant reversal. It is like an antidote, causes instant reversal. Yes, it's a cyclodextrin molecule. Very good. Sugamadex is a cyclodextrin molecule. So it's like an instant reversal. It's like an antidote, and it is a newer agent. It is only reserved for steroidal derivatives like ROC and VEC and causes instant reversal. Right. So this is how you reverse the effect of neuromuscular blocking agent. This is how you reverse the effect of neuromuscular blocking agent. So let's take a break for 15 minutes. We'll join back at 11:35. Okay. And we'll resume with neuromuscular monitoring. Go back and come back again, then it would not be Black Prince. Can you all hear me? So let's start with a very important discussion of peripheral nerve stimulation and neuromuscular monitoring. Now this is a very practical topic. The questions that we get from this topic are very basic questions. We do not get too many advanced questions, but this is a very practical topic. So to understand this topic takes little while. I am going to deal this topic in the way that we do neuromuscular monitoring, but at any point of time, if you do not understand anything, then I'll give you few points that you have to remember, and most of the questions will come from those points. So do not sweat too much about this topic. This is one of those 10% extremely difficult topics that come. I don't expect too many questions from this. Whatever questions come, they are very basic questions. Okay. So what is neuromuscular monitoring? It is using a principle of peripheral nerve stimulation to assess the function of a neuromuscular junction. A peripheral nerve is stimulated electrically and the response of the muscle is assessed. To test the function of neuromuscular junction, a peripheral nerve is stimulated electrically and the response of the muscle is assessed. The response of the muscle is assessed. Okay, very simple. If you want to assess the function of an NMJ, then you will stimulate an N and record the response of a muscle. The bigger question is, why do we need neuromuscular monitoring? So we need neuromuscular monitoring just like we need any other form of monitoring, that is to improve the quality of intubation and reduce airway injury, to assess the depth of block during surgery, and to identify residual neuromuscular block. And this part is the most important part of neuromuscular monitoring. That is when you can safely extubate the patient, because if you extubate the patient who is still under the effect of muscle relaxant, then there are a lot of complications that happen because of residual neuromuscular block. Lot of complications that can happen because of residual neuromuscular block. Residual neuromuscular block. Okay, so these are the indications of neuromuscular monitoring. Why do we do neuromuscular monitoring? To improve the quality of intubation and reduce airway injury. That means to know whether the effect of muscle relaxants have come. To assess the depth of the block. That means during the surgery. Yes, I'll put up the previous slide. Just write this one. To assess the depth of block during the surgery, and to identify the residual neuromuscular block that is at extubation. So at intubation, during the surgery and extubation, all the three places you would require to do neuromuscular monitoring. You would be required to do neuromuscular monitoring. This is the principle of peripheral nerve stimulation. So you stimulate a nerve electrically and record the response of the muscle. Stimulate the nerve electrically and record the response of the muscle. Stimulate the nerve electrically and record the response of the muscle. Alright, so how we do it? We use a device called as peripheral nerve stimulator. We use a device called as peripheral nerve stimulator. So this is the device which is called as a peripheral nerve stimulator, PNS. We attach the electrodes through a peripheral nerve. We stimulate this nerve electrically and we record the response of the muscle, right? So for understanding the neuromuscular monitoring, we first need the technical aspects of neuromuscular monitoring. So we require three things. The first thing is the nerve and the muscle combination used. Nerve and muscle combination used. Second is method of recording of response. And third is patterns of stimulation. In how many ways can you stimulate the nerve? So let's see the nerve and muscle combination used. This is a very common question that is asked in the exam. The most common nerve that is used to do neuromuscular monitoring is ulnar nerve. And the muscle is adductor pollicis muscle. Second most common is facial nerve and orbicularis oculi muscle. Facial nerve and orbicularis oculi muscle. Facial nerve and orbicularis oculi. This is a NEET 2019 question and this is a potential question. Now the next time they want to create a question out of this topic, they can choose second most common nerve muscle combination used. Second most common nerve muscle combination used. How to record the response of the muscle? That means what modality, what technology you are going to use to record the response of the muscle. So there are three techniques: mechanomyography, acceleromyography, electromyography. Out of that, mechanomyography is considered to be gold standard and most common used is acceleromyography. Most common used is acceleromyography. Most common used is acceleromyography. Let me know when you're done writing this thing, give me a thumbs up, and then we'll move on to the next part of the discussion, that is patterns of stimulation, and this will decide how we are going to do actual neuromuscular monitoring. So we first take a peripheral motor nerve, ulnar nerve, and the muscle it supplies, adductor pollicis. We attach the electrode, we attach the method of recording of response, that can be mechanomyography, acceleromyography or electromyography. And then we stimulate this nerve through different patterns to elicit different responses based on which we can do a neuromuscular monitoring. So mechanomyography is considered to be gold standard, while acceleromyography is most commonly used. Acceleromyography is most commonly used. So let's look at the patterns of stimulation. So there are three basic patterns of stimulation that you need to know. Patterns of stimulation mean in how many ways can you stimulate this nerve. So the first and the most basic pattern is single twitch. Single twitch. As the name is only telling you, it is one stimulation at a time. So you stimulate the nerve once. You can see this is the stimulation This is the strength of muscle contraction that has been recorded and put on a graph. So one stimulation at a time. What is the frequency with which you stimulate this nerve? Either 1 hertz or 0.1 hertz. 1 hertz or 0.1 hertz. 1 hertz or 0.1. 1 hertz means a frequency of 1 per second. 0.1 hertz is frequency of 1 per 10 second. 1 per 10 second. One per second or 1 per 10 second. What is its use? Now single twitch is used to assess supramaximal strength of stimulation. It is used to assess supramaximal strength of stimulation. You guys are with me? Suddenly there is too much of quiet. Can I see some victories? Can I see some V's? Just so that you let me know that you guys are here. Supramaximal strength of stimulation. Now what is this supramaximal strength of stimulation? So see, this PNS is a dabba. It's a device that gives electrical currents to a nerve. It has intensities of different currents, 10, 20, 30, 40, 50, 60, 70, 80. Which one to give? So you have to assess the strength of stimulation that you can give. So let's start with the lowest, that is 10 milliampere. So you gave a 10 milliampere to this ulnar nerve, and obviously that is a sub-maximal strength of stimulation. So what will you get? You will get a sub-maximal response. You will get, say, this twitch. Can you see? Twitch. Increase it to 20, the intensity of contraction will increase. Increase to 30, the intensity will further increase. Increase to 40. Now tell me, can this adductor pollicis contract more than this? More than this? No. So this is 40 becomes a maximal strength of current. 40 becomes a maximal strength of current. Maximal. Now what we do is we add 25% current over it. We add 25% current over it so that all motor units are recruited. So 40, you add 10 more, so 50 milliampere becomes the supramaximal strength of stimulation, and this strength of stimulation is what you will use for all the further patterns of stimulation, right? So to assess what level of current that you can use, we use single twitch. Okay. Next is the most common pattern of stimulation used, that is strain of 4. Most common used pattern. Most common used pattern, that is strain of 4. What do? You give 4 stimulations to a nerve in 2 seconds. So how would you define the frequency of stimulation? 2 hertz, that is 2 per second. Therefore 4 in 2 seconds. So it is most common used pattern, and you give 4 stimulations in 2 seconds. See, 1, 2, 3 and 4. So if I ask you what is the duration between 2 stimulations in a TOF, your answer would be if I ask you what is the duration between 2 stimulations in a TOF, your answer would be 2 stimulations in a TOF. If I ask you what is the duration between 2 stimulations in a TOF, your answer would be obviously 0.5 seconds. 0.5 seconds. But if I ask you what was the duration between 2 TOF, what is the duration between 2 TOF? See, this is 1 TOF. After how much time can you give another TOF stimulation? Second TOF. This duration. Minimum 10 seconds. Minimum 10 seconds. minimum 10 seconds. These are two different questions, two stimulations in a TOEF and two TOEF, and they have been asked separately. So when you get a question like this, you have to specifically look for what they are asking. Specifically look for what they are asking. Two stimulations in a TOEF or two TOEF. Two stimulations in a TOEF or two TOEF. This is most common use pattern. Our further discussion will be based on TOEF only. Let's come to the third pattern, which is tetany, where you give a continuous stimulation to a muscle. No, sorry, now. Continuous stimulation to a nerve. Where you give continuous stimulation to a nerve. Frequency 50 to 100 hertz. 50 to 100 hertz. Sorry, 50 to 200 hertz. Anything between 50 to 200 hertz. Use of tetany is to assess deeper levels of block. To assess deeper levels of block. So we have three patterns of stimulation: single twitch, train of 4 and tetany. Single twitch, train of 4 and tetany. Single twitch, train of 4 and tetany. Alright, now let's start with the discussion of how we do neuromuscular monitoring using TOEF. TOEF forms the basis of neuromuscular monitoring. So let's first identify the type of the block. So what are the types of the block? Two types: block of NDMR and block of DMR, right? Now tell me, what is the mechanism of action of NDMR? What is the mechanism of action of NDMR? It is a competitive antagonist at nicotinic acetylcholine receptor, right? So there is competition and there is antagonism. Competition means the one that has more in concentration will act more, right? So now tell me that if you are using a NDMR molecule and you are injecting an NDMR, and if you stimulate the nerve with TOEF, train of 4, that means you are going to give 4 stimulations in 2 seconds. Now tell me, when you stimulate a nerve with TOEF, that means you are giving 4 stimulations in 2 seconds. In which stimulation you get highest release of quanta of acetylcholine? Highest release of quanta of acetylcholine, first or the last? Obviously first, because in first the nerve terminal is filled with acetylcholine. So subsequently the concentration of acetylcholine released decreases. And if you have a competitive blocker in the NMJ, then what will happen to strength of contraction subsequently? Will it increase or will it decrease? Will it increase or will it decrease? It will decrease. So this is how you identify a NDMR type of block. See, this is how a TOEF will look when no drug has been given. 4 stimulations will produce 4 muscle contraction, all maximum strength of contraction. But when you have given an NDMR, and now because with subsequent strength of stimulation, the release of acetylcholine will decrease, therefore you will start getting fade on TOEF, and fade on TOEF is a feature of NDMR. This is that one line that I told you, you have to remember. Even if you forget all the concepts and don't remember anything, just remember this one line, and still you will be able to mark all the questions from this topic correctly. That fade on TOEF is a feature of NDMR. So you'll start seeing fade. Every subsequent muscle contraction would be less than the previous contraction. You will start seeing fade. Fade on TOEF is a feature of NDMR. Fade on TOEF is a feature of NDMR. Fade on TOF is a feature of NDMR. Now tell me, what type of block is DMR? Is it a competitive block? No. It's actually a partial agonist. Choline is a partial agonist of acetylcholine. So tell me, will there be any competition between choline and acetylcholine? No. But all the receptors where choline has gone and attached, will acetylcholine be able to go and bind to that receptor? No. So when there is choline at the NMJ, will the strength of contraction because of acetylcholine be higher or lower than the original? Lesser. But will there any be fade? Will there be any fade? Will there be any fade? No. Why? Because there is no competition. So if you are using a depolarizing block phase 1, then there will be constant but diminished twitch height. There will be constant but diminished twitch height. See, there is normal full strength of contraction. There will be constant but diminished twitch height. Why? Because choline is a partial agonist. And what did we write about? What did we write about phase 2 block? When you use choline for a long time, then it causes some non-specific changes in the receptor, and now the block behaves like an NDMR type of block, and an NDMR behaves like fade on TOF. So you will start seeing fade in phase 2 block. You will start seeing fade in phase 2 block, isn't it? So this is how you identify the type of block using TOF. This is the crux of train of 4. Fade on TOF, NDMR, phase 1 block of choline, constant but diminished twitch height, phase 2 block of choline, fade. Phase 2 block of choline, fade. Forget about it. I am not teaching this ना. Forget about it. भूल जाओ अभी. जब बताऊंगा टॉफ रेशियो क्या होता है तब करेंगे. अभी जस्ट कॉन्सेंट्रेट ऑन आइडेंटिफाइंग द टाइप ऑफ द ब्लॉक. Identifying the type of the block, right? So now you have all the technical information with you. Let's use this information for doing neuromuscular monitoring, right? What are the 3 places where we do neuromuscular monitoring? At intubation, during the surgery, and at extubation, right? At intubation, you want the vocal cord to be relaxed. During the surgery, you just want that the patient's diaphragm should not move. And during extubation, you want that there should be complete neuromuscular recovery. For this, we use 2 concepts of TOF called as TOF count and TOF ratio. TOF count and TOF ratio. So let's do neuromuscular monitoring using TOF count and TOF ratio. So let's see what is TOF count. TOF count is number of twitches observed on TOF stimulation. Number of twitches observed on TOF stimulation. Number of twitches observed on TOF stimulation. Tell me what would be normal TOF count. What do you think should be normal TOF count? What do you think should be normal TOF count? When no muscle relaxant has been given and a TOF stimulation is done on a nerve, that means we have stimulated the nerve 4 times in 2 seconds. Then what should be the normal TOF count? How many muscle contractions should we see? Of course, 4. So normal TOF count is 4. Under muscle relaxation, what should happen to TOF count? Under muscle relaxation, what should happen to TOF count? Should it increase, decrease, or remain the same? Should it increase, decrease, or remain the same? Under muscle relaxation, what should be TOF count? Under muscle relaxation, what should be TOF count? It should decrease. It should decrease. Yes, I knew Bhaskar you will say the same. Everybody thinks the same. So let's see. This is why I introduce the concept first, then I try to explain. This is normal when no drug has been given. Now I've injected an NDMR, say atracurium, and what you start seeing on top, fade. So you'll see fade. Every 30 seconds you do a TOF stimulation, you will start seeing fade. Initially the fade will be like this. Then what will happen? As the muscle starts to get relaxed more and more, the intensity of response will also keep on decreasing, isn't it? The muscle is eventually relaxing, right? So your stimulation will not elicit a response because now more and more receptors at NMJ are getting occupied by the NDMR. So fade will keep on increasing, and what will happen after some time? The fourth twitch will be lost. Then the third and fourth twitch will be lost. Then the second, third, fourth twitch will be lost, and then eventually there will be no muscle contraction, so no twitches. So as the muscle relaxation deepens, what happens to the TOF count? It will keep on decreasing. See, TOF count 4, 3, 2, 1, 0. So as the muscle relaxes, the TOF count decreases, and we use this to decide when to intubate the patient. For intubation, we need a TOF count of 0 or 1. We need a TOF count of 0 or 1. And for maintenance phase of surgery, we need a TOF count of 1 or 2. We need a TOF count of 1 or 2. We need a TOF count of 1 or 2. Understood? Did you understand this concept of TOF count? Did you understand this concept of TOF count? As the TOF count decreases, so the strength of muscle contraction increases. At 0 or 1, you can safely intubate the patient, and while during the surgery, you will maintain the TOF count between 1 or 2. TOF count between 1 or 2. Next concept is TOF ratio, which is the ratio of intensity of fourth response to first response in a TOF stimulation. Ratio of intensity of fourth response to first response. Ratio of intensity of fourth response to first response. Tell me, what would be normal TOF ratio when no muscle relaxant has been given? Normal TOF ratio when no muscle relaxant has been given. What do you think should be normal TOF ratio when no muscle relaxant has been given? Normal TOF ratio 1, because the intensity of fourth response will always be equal to first response. So T4 by T1 would be 1. Tell me, under NDMR, what should happen to the TOF ratio? Should it increase, decrease, or remain the same? नहीं बेटा सारे Varun, in all the patterns of stimulation, you will use supramaximal strength of current. You assess the level of supramaximal strength of current using single twitch, but you use it in all the strength, all the patterns of stimulation. Yes, it will decrease. So always less than 1, because of the phenomena of fade, the fourth response will always be less than the first response, isn't it? You guys are simply brilliant, I'm telling you. I mean, you're understanding this concept so well. It is so, like, you guys are really very, very fresh right now, because otherwise it takes lot of time, because it's a very, very practical topic. Sometimes it becomes a nightmare to explain this topic at undergraduate level, but you guys are doing a superb job. Now we use this TOF ratio to decide when we can safely extubate the patient. So we will see that TOF ratio and then the action we do based on this ratio. So when the TOF ratio is between 0.3 to 0.7, then you wait and watch. Don't do anything. The muscle is still significantly blocked. At point 7, you administer reversal. You administer reversal at point 7. That means you give neostigmine glycopyrrolate. And at point 9, you can safely extubate the patient. So we use a combination of TOF count and TOF ratio to decide when we can intubate, what level should we maintain, and when we can extubate the patient. This is how we do neuromuscular monitoring. This is how we do neuromuscular monitoring. Is this clear? Is this clear? Now I have one more concept to tell you, which is not that important, but it is difficult. So if you tell me that you have completely understood this thing, then only I'll move on to tell you that particular topic. Perfect. Very good. Now look at this. Okay. And this is what happens during the surgery. All right. This is what happens during the surgery. So you have a patient on table and now we are about to start a surgery and we are using neuromuscular monitoring. All right. So we'll first assess the supramaximal strength of stimulation. Okay. And then we will do TOF stimulation. So this is TOF in a normal individual. Okay. So what is the TOF count here? 4. What is the TOF ratio? 1. Then I gave atracurium to the patient. And so I start seeing fade. So the TOF ratio starts getting less and less and TOF count is still 4. Then TOF count is 4, TOF ratio becomes even lesser. Then TOF count 3, 2, 1, 0. At this point, I will intubate the patient, isn't it? I will intubate the patient. Then I'm maintaining the surgery, keeping TOF count 1 or 2. But what if at TOF count 0, I give a bolus of atracurium? Is it possible that at TOF count 0, I can still give a bolus of atracurium? Yes. Will I be able to comment about the depth of muscle relaxant at this point of time? Will I be able to comment about the depth of muscle relaxant at this point of time? No. Why? Because TOF count is already 0. No, TOF has no effect on stimulation. So what to do at that level? So when TOF count is 0, then we resort to a concept called as PTC, post-tetanic count, which is number of twitches observed on single stimulation after a tetanic stimulation. This is for deeper levels of block. When TOF count is 0. TOF count is 0. This is at deeper levels of block when TOF count is 0. When TOF count is 0. TOF count is 0. Now the funda is very simple. What has happened here is that a routine TOF stimulation releases the number of acetylcholine that are not able to mount a response. We know NDMRs are competitive blockers. So what I will do is I will initially give a tetanic stimulation for 5 seconds. I will give a tetanic stimulation for 5 seconds. So what will happen? Tetanic stimulation is continuous muscle stimulation, nerve stimulation for 5 seconds. So what will happen to the presynaptic acetylcholine stores when I give a tetanic stimulation for 5 seconds? They will get exhausted. So presynaptic acetylcholine gets exhausted. Then I will wait for 3 seconds. What will happen in this time? When I wait for 3 seconds, what will happen? Will there be production of acetylcholine? Yes. So will there be normal production of acetylcholine, increased production of acetylcholine, or decreased production of acetylcholine after a tetanic stimulation? So the concept of positive feedback, because the requirement is more, so now the supply will be more. So there will be increased production of acetylcholine. Increased production of acetylcholine. And now I start giving single twitches every second. Now I start giving single twitch every second. So what happens? Now there will be increased quantity of acetylcholine that will get released in the NMJ. And if this doesn't elicit a response, then what would be your outcome? What would be your implication? Is the muscle deeply blocked or shallowly blocked? So intense muscle contraction. So now when you get a contraction that is called as PTC, which is post-tetanic count, which is inversely proportional to the intensity of the block. So higher the intensity of the block, lesser will be PTC. If at all you don't want to remember anything, just remember PTC 0 is equal to intense level of block. PTC 0 is intense level of block. Apart from this particular line, I don't think any question will ever come from this topic, because it's an extremely technically difficult topic to understand. Okay? So even if you want to forget everything, just remember that PTC 0 implies intense level of block. PTC 0 implies intense level of block. Alright. So this is about neuromuscular monitoring. This is about neuromuscular monitoring. There is no need. There is no need. The idea is to tell you that how can you assess the depth of block when TOF count is 0? At TOF count 0, you can have a very deep level of block, you can have very shallow level of block, but how would you come to know TOF count is 0? You don't know when the patient will start coming out in next 1 minute or 1 hour. So to assess that deeper level of block at TOF count 0, you use the concept of PTC. There is no need to give muscle relaxant at TOF count 0, but sometimes you need to know how deep is the block at TOF count 0. Alright. But have you seen, if you have been to theater at any point of time, have you seen somebody do these things? Have you seen somebody attach these electrodes and do stuff like that? No. But you have definitely seen people yelling at the head end of the patient, say open your mouth, show your tongue, raise your hand, raise your feet during extubation. Have you seen that? Why? Because those are clinical signs of recovery. So next topic is clinical signs of recovery, which are used more often in the theaters than neuromuscular monitoring. And the clinical signs of recovery are sustained head lift, sustained leg lift, sustained hand grip, a positive tongue depressor test, and an ability to generate a negative inspiratory pressure of -40 to -50 centimeters of water. Ability to generate a negative inspiratory pressure of -40 to -50 centimeters of water. These are clinical signs of recovery. And if at all in a question they have given you both clinical sign of recovery as well as objective TOF criteria, then remember that if in one question both are given, then TOF criteria will be preferred over clinical criteria. TOF criteria will be preferred over clinical criteria. Just make a note of this thing. I'm here only. All right, written. Hello. All right. So here we are at the end of our intubation. So now if you see, Acha, can you explain PTC with intensity of block again? Okay, you want me to explain it again? No. Just forget about it. Just forget about it. Pandian, your name is too long for me to. Okay, I'll try to pronounce your name first. Sabari Vinathan Sastha Pandian. Amazing name, man. Amazing. Yes, the class is running. I got a call. Sorry. Forget about it, Pandian. Just remember what I told you. PTC 0 means intense level of block. That's it. Okay. Don't use extra time on that. Just remember PTC is 0 is intense level of block. Can you do that for me? And love your name. Seriously. So now in the steps of general anesthesia, you can see we started with pre-operative assessment and preparation. We have done monitoring. We have induced the patient. We bag and masked the patient. We gave muscle relaxant and intubated the patient. We are maintaining the patient's muscle relaxation. At the end of the surgery, we reverse and then we extubate the patient. Now the only thing remain is the maintenance phase of anesthesia. And maintenance phase of anesthesia is again can be done by two techniques. Either you use an inhaled agent or you use a IV agent. Now most common maintenance is done by inhaled anesthetic agent, but sometimes you use IV agents for maintenance of anesthesia. When you use IV agents for maintenance of anesthesia, then it is called as total intravenous anesthesia or TIVA. Total intravenous anesthesia or TIVA. And the agent of choice for TIVA is propofol. But obviously when you are using TIVA, you need something for pain relieving, right? Because propofol doesn't have analgesic properties. So you always combined it with an opioid. And the order of opioid used for TIVA is remifentanil, L-fentanyl and fentanyl. Remifentanil, L-fentanyl and fentanyl. Remifentanil, L-fentanyl and fentanyl. All right. So this is the first thing, that TIVA is total intravenous anesthesia. That means when we use IV induction agents for not only induction but also maintenance of anesthesia, that type of anesthesia is called as TIVA. So we don't use any inhaled anesthetic agents, and the agent of choice for TIVA is propofol. You use it along with an opioid. The order of opioid is Remi is most preferred, followed by L-fentanyl, followed by fentanyl. Okay. Let's see the classification of inhaled anesthetic agents, and this is a very important classification because a lot of questions can be understood only when you understand this classification. So inhaled anesthetic agents are the agents that are given through lungs, okay. So inhaled anesthetic agents can be classified as pure gases and volatile liquids. See, volatile liquids are originally in a liquid form. You vaporize them and these vapors are then delivered to the patient in inhaled form. So either you can have pure gases, which is nitrous oxide and xenon, or volatile liquids, which are then divided into old and new. Old are the ones that we don't use anymore: ether, methoxyfluorine, ethylene oxide, chloroform, trilene, cyclopropane, and new ones are halothane, isoflurane, desflurane, sevoflurane. Halothane, isoflurane, desflurane, and sevoflurane. Halo, iso, des, and sevo. Halo, iso, des, and sevo. halo, iso, des and CO. Okay. You have to remember pure gases from volatile anesthetic agents. I'll come to that later on when we discuss the important questions that are being asked. Let me know when you are done writing this thing, give me a thumbs up, and then we'll move on to the most important part of the discussion of inhaled anesthetic agents, that is their pharmacokinetics. And if you understand the pharmacokinetics of inhaled anesthetic agents, then rest of the things become very, very easy. Rest of the things become very, very easy. Perfect. So let's start with the pharmacokinetic properties, but before that, let's trace the journey of inhaled anesthetic agent. Why are we tracing the journey? Because inhaled anesthetic agents are inherently most unique in their action, because the route of administration is via lungs, right? You are administering the drug via lungs. So let's start the journey of inhaled anesthetic agents. So these inhaled anesthetic agents are mostly, as volatile anesthetic agent, are in liquid form, kept at a device called as vaporizer on the anesthesia machine. And this liquid volatile anesthetic agents are vaporized and are taken up by carrier gases. They pick up the vapors of inhaled anesthetic agents and deliver it to the breathing circuit. Breathing circuit is the conduit between machine and the lungs. And this breathing circuit then delivers these inhaled anesthetic agents to the site of action, that is the lungs. Sorry, not the site of action, the site of administration, route of administration, that is lungs. Now these inhaled anesthetic agents will move from alveoli into blood, will taken up by blood, will reach the brain, will act on the brain, again come back via venous blood into the alveoli, and from alveoli it will be exhaled out. So there are few things that you need to know in this whole journey of inhaled anesthetic agent. The first thing is that the site of action is brain. So you need a certain level of these agents in the brain for it to act. Site of action is brain. Now your inhalation decides your onset of action and your exhalation decides offset of action, right? So it is not the metabolism and the excretion that decides the duration of action, but it is the inhalation that decides the onset and it is the exhalation that decides the offset of action. Now what drives these agents from the alveoli to blood and blood to brain? So the driver of anything that is dissolved in a liquid medium is partial pressure. So any agent will move from an area of high partial pressure, say in the alveoli, to low partial pressure in blood to even lower in brain, till the point that it is equal on all the sides. So partial pressure in blood equals partial pressure in alveoli equals partial pressure in brain. This state is called as steady state. And every inhaled anesthetic agent tries to achieve this steady state. Partial pressure in the alveoli equal to partial pressure in the blood equal to partial pressure in the brain. Have you understood till now? Is it clear? So every inhaled anesthetic agent tries to achieve the steady state. So tell me, which agent will be faster in onset? The one that achieves steady state faster or one that achieves steady state slower? Tell me, which agent would be fast in onset? The one that achieves steady state faster or the one that achieves steady state slower? One that achieves steady state faster or one that achieves steady state slower? Obviously one that faster. So steady state achievement is directly proportional to the onset of action, isn't it? So faster the steady state, faster the onset of action, slower the steady state, slower the onset of action. Now tell me, which agent will achieve steady state faster? One that is more soluble in blood or one that is less soluble in blood? Tell me which agent will achieve steady state faster, one that is more soluble in blood or one that is less soluble in blood? Logically, tell me, the one that is more soluble in blood will achieve steady state faster or one that is less soluble in blood? More soluble in blood, right? That is the logical answer. The one that is more soluble will be taken up in the blood more, and the more it is taken up in the blood, the faster will be the onset of action, isn't it? So let's take for an example agent A and B. A is more soluble in blood as compared to B, right? Say 100 times more soluble. So you gave 100 molecules of A and it is very soluble in blood. So what will happen? 100 molecules will go inside the blood. So you gave 100 molecules, 100 went inside. Again 100 molecules will come, it will go inside. Again 100 molecules will come, again go inside. Again 100 molecules will come, again go inside. Are you achieving steady state? Are you achieving steady state? No. As compared to that, an agent B that is less soluble in blood. So you gave 100 molecules, 50 went into blood, 50 remain in alveoli, and now the blood compartment is saturated. Have you achieved steady state? Yes. So tell me which agent will achieve steady state faster, one that is more soluble in blood or one that is less soluble in blood? One that is more soluble in blood or one that is less soluble in blood? Less soluble in blood. So onset of action is inversely proportional to blood solubility. This forms the basis of first pharmacokinetic property of inhaled anesthetic agent, that is blood gas partition coefficient, which is defined as the ratio of concentration of anesthetic agent in blood to alveolar gas at steady state. It is defined as the ratio of concentration of anesthetic agent in blood to alveolar gas at steady state. It is defined by an entity called as lambda Bg, that signifies the solubility of inhaled anesthetic agent, which is inversely proportional to speed of onset and recovery. And I told you, all the factor that will speed up the onset will speed up the recovery, and slow the onset will slow the recovery, because onset and offset is decided by the inhalation and exhalation of the agent. Inhalation and exhalation of the agent. Is there any doubt in understanding this part? This is the most tricky part of understanding inhaled anesthetic agent, that which agents will be faster in onset and which will be slower in onset. The one that is more soluble in blood will be slower in onset as compared to one that is less soluble in blood, because the more the solubility, the more time it takes to achieve steady state, and therefore slower onset and recovery. Done? Based on this, we have an order of increasing order of blood gas partition coefficient, that would be decreasing order of speed of onset and recovery. Increasing order of blood gas partition coefficient. So xenon with a blood gas partition coefficient of 0.15 is fastest inhaled anesthetic agent, followed by des, nitrous, CO, iso, halo. Maximum blood gas partition coefficient is seen with methoxyflurane, so it is slowest in onset and recovery. It is slowest in onset and recovery. Now I told you during the classification that you have to remember whether the question is asking you inhaled anesthetic agent or volatile anesthetic agent. See, inhaled anesthetic agents are all gases and volatile. But volatile anesthetic agents are specifically the ones that are liquid. So if somebody asks you which is the fastest volatile anesthetic agent, your answer would be desflurane, because xenon is a pure gas. Right? So this is a very, very important table. At least remember these three: xenon, desflurane and methoxyflurane. Xenon, desflurane and methoxyflurane. Alright, so this is the first pharmacokinetic property of inhaled anesthetic agent, that is the blood gas partition coefficient that decides the speed of onset and recovery. Now the second pharmacokinetic property is the potency of inhaled anesthetic agent, which is very, very easy to understand, and you can define the potency of inhaled anesthetic agent by an entity called as minimum alveolar concentration. Minimum alveolar concentration, or MAC. Minimum alveolar concentration, or MAC, which is defined as the minimum alveolar concentration of anesthetic at 1 atmosphere, which produces immobility in 50% of subjects exposed to a noxious stimuli, usually a skin incision. Now this is something that you might have heard before, especially Bhaskar. Have you heard of a definition that involves 50% of the subjects? Have you heard it somewhere, Bhaskar? Abhi recent times mein, have you heard this definition where 50% of subjects are involved? 50% of subjects are involved. It's usually seen in pharmacology. It is usually a pharmacological term where 50% of subjects are involved. You might have heard. Have you heard of the definition of effective dose in 50% of individuals, ED50? It says that it is the concentration of the agent that is required to produce effective dose in 50% of individuals. Now, if we talk about anesthetic agent, then what is effective dose? No response to a surgical skin incision. So does this look like ED50 of inhaled anesthetic agents? Yes. So MAC represents ED50 of inhaled anesthetic agent, which is inversely proportional to the potency of that agent. Obviously, more concentration if required for that particular action, that means the potency is less. So the value of MAC is inversely proportional to the potency. Value of MAC is inversely proportional to potency. Value of MAC is inversely proportional to its potency. Value of MAC is inversely proportional to its potency. And once again, we have an order of potency amongst inhaled anesthetic agents, which is increasing order of MAC or decreasing order of potency. Increasing order of MAC or decreasing order of potency, with isoflurane being most potent amongst modern inhaled anesthetic agent, followed by CO, des, xenon and nitrous oxide. So if somebody asks you which is the least potent inhaled anesthetic agent, your answer would be nitrous oxide. But if somebody asks you least potent volatile anesthetic agent, your answer would be desflurane. Understood the difference between a volatile anesthetic agent and a inhaled anesthetic agent? Inhaled anesthetic agent comprises both gases and volatile liquids, while volatile anesthetic agent excludes nitrous and xenon, which are the pure gases that are used in anesthesia. Now look at the value of nitrous oxide, 104. If you put it in the definition of MAC, this tells you that A concentration of 104% is required for nitrous oxide to be able to achieve the effect. So tell me, is it possible to achieve a concentration of 104% of nitrous oxide at alveoli? Is it possible to achieve 104%? Of course it is not possible. But is it possible to achieve 100%? That is almost near 104. Is it possible to achieve 100%? Is it possible to achieve 100%? Yes, it is possible to achieve 100%, but then what will happen to the patient? If you achieve 100% concentration of nitrous oxide at alveoli, then what will happen to the patient? Of course, the patient will die of hypoxia. So that means you can never give nitrous oxide more than 70%. That means you can never give an adequate dose. Therefore, it is considered as an incomplete anesthetic agent. And it is used as an adjuvant only. Incomplete agent and used as an adjuvant only. It is an incomplete anesthetic agent and used as an adjuvant only. Overall lowest MAC, highest potency is seen with methoxyfluorine. Overall lowest MAC and highest potency is seen with methoxyfluorine. Prince, nitrous oxide is not a noble gas. It is not a noble gas. It's a chemical compound. Noble gases are ones that are pure, like helium, argon, xenon. These are noble gases which are trace and are pure. Nitrous oxide is a chemical structure. It is nitrous oxide, N2O. Alright. Let's discuss about MAC. Factors affecting MAC. So there can be two types of factors affecting MAC. You can have factors that will decrease MAC, and then you can have factors that will increase MAC. And since we know that MAC and potency are opposites, so any factor that decreases MAC increases the potency, and any factor that increases MAC decreases the potency. It is important to note it here because in questions you might get a question on MAC, but the description or the option might say potency. So you have to understand the relationship between MAC and potency. So whenever you get a question of MAC, don't just jump onto the answer. Always read the question carefully. Whether the question says MAC, the option should not say potency, because the answer will that reverse. So the first factor that affects MAC is temperature. And both hypo and hyperthermia will decrease MAC, except if hyperthermia becomes more than 42 degrees Celsius. That is usually seen in cases of malignant hyperthermia, is when you will have decrease in MAC. That is when you will have decrease in MAC. Bhaskar, leave it. Write factors affecting MAC. We'll come back to that later. Okay. Second is age. So obviously tell me which age group of patients will require lesser dose of anesthetic agent for the same effect. Obviously old. Young will require more. So old have decreased MAC, while young have increased MAC. Maximum MAC for an individual is seen at 6 months of age. Maximum MAC is seen at 6 months of age. So if you plot an order of MAC for an individual throughout his lifetime, then the order would be that an infant will have highest MAC, followed by a neonate, followed by an adult. So actually a neonate's requirement of anesthetic agent is less as compared to an infant who is 6 months old. This is something that has been asked in AIIMS before. It is unique because it is not something that is varying from birth till death. Initially the requirement is less, then the requirement rises, and then there is a consistent fall in the requirement throughout the life. Consistent fall in the requirement throughout the life. Next is electrolytes. Next is electrolytes. So hyponatremia and hypercalcemia decreases MAC, while the opposite, hypernatremia and hypocalcemia, increases MAC. Now let's take two really related things, alcohol and amphetamine. Now you tell from your own experience, either on yourself or what you have seen. Tell me from your own experience, the requirement of anesthetic agent for an acute alcoholic would be higher than a non-alcoholic or lesser than a non-alcoholic? The requirement of anesthetic agent would be higher for an acute alcoholic or lesser? Obviously lesser. Why? You have seen an acute alcoholic, he is anyway half anesthetized. So acute alcoholism decreases MAC. While somebody who is a chronic alcoholic, daily 90 ml, 100 ml, 120 ml, then he requires a higher dose for the same effect or the lesser dose? Higher dose. So chronic alcoholic will increase MAC. This is based on the fact that alcohol is a CNS depressant, while amphetamine is a CNS stimulant. So an opposite will happen. Chronic amphetamine abuse will decrease MAC, while an acute amphetamine use will increase MAC. Isn't it? So this is very interesting. Next is all anesthetic agents. All local anesthetics and pregnancy all decrease MAC, except cocaine, which is an exception in local anesthetics, which increases MAC. Which is an exception in local anesthetic which increases MAC. These are the common factors that affect MAC. And if we know these, then intraoperatively we know in which condition we need to decrease the dose of inhaled anesthetic agent and in which condition we need to increase the dose. Now just make a box here and write a point about thyroid hormones. There is no effect of thyroid hormones on MAC. No effect of thyroid hormones on MAC. That means whether the patient is hypothyroid or hyperthyroid, doesn't matter, the MAC will remain the same. Although we might believe that a hyperthyroid will require more dose, hypothyroid will require less dose, but as such there is no effect of thyroid hormones on MAC. There is no effect of thyroid hormones on MAC. Bhaskar, there is nothing to understand. It's a fact. Both hypo and hyperthermia will increase the potency, that is decrease the MAC, unless and until you get a specific condition where the temperature increases more than 42 degrees Celsius, that is usually seen in either heat stroke or malignant hyperthermia, then the patient's requirement will increase. Till that time, both fever as well as cold will always decrease the requirement of anesthetic agent. Okay, done. So these are factors affecting MAC. Factors affecting MAC. Let's come to the third pharmacokinetic principle, that is metabolism. That is metabolism. Now, unlike other agents, other drugs, where metabolism plays a part in the offset of action, in inhaled anesthetic agent, metabolism has no role in offset of action. Offset of action is by exhalation. So you will say, sir, if there is no role of metabolism in offset of action, then why are we reading it? Because these are chlorofluorocarbon molecules. These are chlorofluorocarbon molecules. These are noxious substances. Noxious nahi, but these are chemical substances. So when they get metabolized in the body or anywhere else as well, they will always release toxic byproducts, and therefore metabolism is akin to toxicity of inhaled anesthetic agents. So when we talk about metabolism, we talk about toxicity. That is, more the metabolism, more is the toxicity. And this methoxyflurane is metabolized 70%, that is highest, and so causes vasopressin resistant high output renal failure and shows maximum nephrotoxicity. Maximum nephrotoxicity. Vasopressin resistant high output renal failure and shows maximum nephrotoxicity. Second most metabolized inhaled anesthetic agent is halothane, which is metabolized 25% and shows maximum hepatotoxicity. Maximum hepatotoxicity. Hepatotoxicity. Then is sevoflurane 5%, isoflurane 0.2, desflurane 0.02 and nitrous oxide nil. This is safest inhaled anesthetic agent. Safest inhaled anesthetic agent. No metabolic toxicity, metabolized toxicity. No toxicity from metabolism. Alright, so the things that you have to remember is methoxyflurane highest toxicity, and the reason is that when methoxyflurane breaks down, it releases inorganic fluoride, and methoxyflurane has maximum release of inorganic fluoride that causes this nephrotoxicity. Maximum release of inorganic fluoride that causes nephrotoxicity. Maximum release of inorganic fluoride that causes nephrotoxicity. Okay, so the third pharmacokinetic property that I wanted to tell you is metabolism. Metabolism is akin to toxicity. Next is environmental hazards. Just like how when they break down in the body, they always form something toxic. Similarly, when they are released in the atmosphere, they will always harm the atmosphere. And what does the harm that they do? Two effects: greenhouse effect and ozone depletion. Greenhouse effect is responsible for global warming, while ozone depletion causes harmful UVB radiation to enter inside the earth. Now there are two aspects. One is the potential of a molecule to cause this effect, and second is overall impact. The potential of desflurane to cause greenhouse effect is maximum, and halothane to cause ozone depletion is maximum. But overall, nitrous oxide contributes to maximum effect of greenhouse effect and ozone depletion. The reason is because nitrous oxide is used in high concentration. So because it is used in more quantity, although its potential per molecule is less, but because of the gross quantity, the overall impact is higher. The overall impact is higher. the overall impact is higher. All right. So these are pharmacokinetic properties of inhaled anesthetic agent. The best part about inhaled anesthetic agent is most of the things that you read are general. Specific things are very less. So if you cover the general pharmacokinetic properties, and now we'll discuss general pharmacodynamic properties, 90% of inhaled anesthetic agents are covered there only. You don't really need to put too much of effort. So let's move on to now pharmacodynamics, and the best part about pharmacodynamics is that most of the properties of inhaled anesthetic agents are general. That means that are across the different inhaled anesthetic agents the same. So let's start with effect on cardiovascular system. All inhaled anesthetic agents are myocardial depressants except nitrous oxide, which is a cardiostable agent. All inhaled anesthetic agents are myocardial depressants except nitrous oxide, which is cardiostable. In respiratory system, all inhaled anesthetic agents, they increase respiratory rate and decrease tidal volume. That means they cause short and fast respiration. All inhaled anesthetic agents increase respiratory rate and decrease tidal volume. That means they cause short and fast respiration. In central nervous system, all inhaled anesthetic agents are cerebral vasodilators, so they increase ICP. All decrease CMRO2 except nitrous. All cause muscle relaxation except nitrous. All trigger malignant hyperthermia except nitrous. Just make a note of this thing and then give me a thumbs up so that I can move ahead with the discussion of individual inhaled anesthetic agents. Individual inhaled anesthetic agents. I think we should cover inhaled anesthetic agents in half an hour and then take a lunch break. 1:30 lunch break is fine. Perfect. So let's start with the discussion of individual inhaled anesthetic agent, and we'll start with the first one, which is the easiest one and the most unique, as you can see from the pharmacodynamics, that is nitrous oxide. Nitrous oxide is also called as laughing gas because its consumption causes incessant laughter. It is also called as laughing gas. Let's look at the physical properties of nitrous oxide. It is a colorless and a odorless gas. This is gas at room temperature. Nitrous oxide is present as gas at room temperature, but when compressed, it converts into liquid. So liquid in a cylinder. Apart from nitrous oxide, the two other gases that are liquid in a cylinder and used in anesthesia is CO2 and cyclopropane. CO2 and cyclopropane. Gas at room temperature but liquid in a cylinder. Other two agents are CO2 and cyclopropane. Now nitrous oxide is a supporter of combustion, but it is non-inflammable in nature. It's a supporter of combustion, but it is non-inflammable in nature. Doesn't burn itself, but just like oxygen, it supports combustion. Just like oxygen, it supports combustion. Alright. Next is pharmacodynamics, and we already know the general properties, and we know nitrous oxide is notably the exception in most of the places. So let's start with CVS. All inhaled anesthetic agents are myocardial depressant except nitrous oxide, which is a cardiostable agent. So cardiostability means no change in cardiac output, so no change in heart rate and BP. But use of nitrous oxide is associated with increase in pulmonary artery pressure. So therefore you avoid the use of nitrous oxide in patients with pulmonary hypertension. Avoid the use of nitrous oxide in patients with pulmonary hypertension. Next is respiratory system, and all inhaled anesthetic agents increase respiratory rate, decrease tidal volume. So even nitrous oxide does that. In central nervous system, all inhaled anesthetic agents, they are cerebral vasodilators, so it increases ICP. All inhaled anesthetic agents decrease CMRO2 except nitrous, so it also increases CMRO2. Not something that you want in a neurosurgery, so contraindicated in neurosurgery patients. Contraindicated in neurosurgery patients. Contraindicated in neurosurgery patients. It also causes CTZ stimulation, and therefore it is associated with high incidence of post-operative nausea and vomiting. Increased post-operative nausea and vomiting, PONV. It has got analgesic action, which is rare amongst inhaled anesthetic agents. Most inhaled anesthetic agents have no analgesic action, but nitrous oxide has, and it has got no muscle relaxation. It has got no muscle relaxation. So these are pharmacodynamic properties of nitrous oxide. Pharmacodynamic properties of nitrous oxide. Pharmacodynamic properties of nitrous oxide. Next is toxicity. Next is toxicity. toxicity. So again, because there is no metabolism of nitrous oxide in the body, so there is no metabolized toxicity. But long-term exposure of nitrous oxide causes inhibition of vitamin B12 dependent enzymes. It causes inhibition of vitamin B12 dependent enzymes. Strictly speaking, they are not same, Prince. When we say avoid, it's more of a advice, like avoid choline in pediatric patients less than 8 years of age. But contraindicated, don't use at all, no matter what. So it's like absolute and relative contraindication. When I say contraindication, that means I'm stopping you to use that thing. But avoid means just a suggestion. It is better to not use it because it causes some complication. But yes, for practical purposes, you can consider both as same. Which enzymes? Thymidylate synthetase and methionine synthetase. Thymidylate synthetase is involved in DNA formation, while methionine synthetase is involved in myelin formation. So when you use nitrous oxide in long term, then it can lead to following things. Long term exposure of nitrous oxide can lead to following things: peripheral neuropathy, megaloblastic anemia, subacute combined degeneration of the cord, which is SACD of the cord, and teratogenicity. These are the problems that long term exposure of nitrous oxide will face. Done? Perfect. Now tell me which group of patients will have this complication. Which group of patients will have this complication? In which patients do you see long-term exposure of nitrous oxide? None. Because patients gets exposed to nitrous oxide only during the surgery. But who gets exposed to nitrous oxide every single day? for 7 to 8 hours till the time they are in the theater. So it is anesthetist and OT staff. So this is actually a occupational hazard. And whenever there is an occupational hazard, then there are certain guidelines for maximum permissible level of these agents. So let's see the maximum permissible level. If you are using only nitrous oxide, then the maximum permissible level should not be beyond 25 ppm. It should not be beyond 25 ppm. But if you are using volatile anesthetic agent, then if you are using without nitrous oxide or with nitrous oxide, without nitrous oxide should not go beyond 2 ppm. With nitrous oxide should not go beyond 0.5 ppm. This is OSHA guidelines, Occupational Safety and Health Hazard Guidelines, OSHA guidelines of maximum permissible level of these agents in the theater. Maximum permissible levels of these agents in the theater. Maximum permissible levels of these agents in the theater. Okay. Next is two effects of nitrous oxide that we are going to discuss. Rohan, are you here or you have left? Rohan, are you here? If you are here, this is the part that you want to listen to carefully because you had a problem yesterday when we were discussing pre-oxygenation. So the two effects of nitrous oxide that we want to discuss is second gas effect and diffusion hypoxia, and both of them are based on the fact that nitrous oxide is 35 times more diffusible than nitrogen. 35 times more diffusible across membranes than nitrogen. So the first effect is called as a second gas effect. First effect is called as a second gas effect, whereby it is seen at induction. And what happens is, because of large volume diffusion of first gas, that is nitrous oxide, in the blood at induction causes faster induction with a concomitantly administered second gas, that is halothane. Because of large diffusion of nitrous oxide in the blood from the alveoli, the alveolar volume collapses, and when the alveolar volume collapses, the effective concentration or effective partial pressure of other gases increases. And we know the higher we achieve, the earlier we achieve steady state, the faster is the onset. So suppose you are using halothane for induction and it used to take 10 minutes for induction. If you piggyback it with nitrous oxide, the patient will get induced in 5 minutes. So second gas effect is seen at induction, where large volume diffusion of first gas in the blood at induction causes faster induction with concomitantly administered second gas. Concomitantly administered second gas. I think Rohan is not here today. Otherwise, he would have been happy to see the second effect, that is diffusion hypoxia or Fink effect. See, this is how it happens. See, there is large volume diffusion. You know, the pretext is that and nitrous oxide is 35 times more diffusible than nitrogen, isn't it? So as compared to nitrogen, nitrous oxide will cross the membranes faster. How much? 35 times. So suppose you use this combination for inducing anesthesia that contains 70% nitrous, 29% oxygen, 1% isoflurane. Okay. Now what will happen? A large amount of nitrous oxide will get diffused in the blood. So what will happen? The effective volume of the alveoli will become lesser, right? And the effective concentration of inhaled anesthetic agent will increase. So faster you achieve the steady state of an inhaled anesthetic agent, faster will be onset, because a large amount of gas will go inside the blood. Therefore, there will be alveolar contraction that will increase the concentration of concomitantly administered inhaled anesthetic agent, and therefore you will have faster onset of action. Therefore, you will have faster onset of action. You will have faster onset of action. Okay, this is second gas effect. This is seen at induction. Second gas effect is seen at induction. Okay. A similar effect when seen at recovery is called as diffusion hypoxia or Fink effect, where a large volume diffusion of nitrous oxide in the alveoli at the end of anesthesia will cause alveolar expansion and dilution of alveolar gases. This is seen at recovery. This is seen at recovery. What will happen if you see? This is your alveoli. This is blood. Now you were giving a mixture of 70% nitrous oxide, 29% O2 and say 1% CO. Now at the end of surgery, now you started giving air to the patient. So air contains 79% nitrogen and 21% oxygen. Now where would nitrogen want to go? Nitrogen would want to go inside the blood. And where would nitrous oxide want to come? Nitrous oxide would want to come in the alveoli. As compared to nitrogen, how much nitrous oxide will come in the alveoli? Too high. 35 times more. So what will it do to the alveolar volume? Expand. If alveolar volume expands, what happens to the partial pressure of gases in the alveoli? It will fall. So decreased partial pressure of O2, decreased partial pressure of CO2. Decreased partial pressure of O2 is called as hypoxia. Decreased partial pressure of O2 is called as hypoxia, while decreased partial pressure of CO2 is called as hypocapnia. And we know CO2 drives ventilation. So hypocapnia will further depress ventilatory drive. It will further depress ventilatory drive. A combination of hypoxia with depressed ventilation will cause hypoxemia. So if you are using a nitrous oxide based anesthesia during the surgery, then there is a possibility that because of diffusion hypoxia towards the end, your patient will become hypoxic and will stop breathing. Can you do anything to avoid this? Can you do anything to avoid this problem? Can you do anything to avoid this problem? Yes. Instead of giving air to the patient at the end of anesthesia, why not to give 100% oxygen? And why not to give it for several minutes before you stop the anesthesia. So how can you prevent this problem? Prevention. Giving 100% oxygen for several minutes before the end of anesthesia. Giving 100% oxygen for several minutes before the end of anesthesia. Right? And just like how Soumya pointed out, this will be called as pre-oxygenation. Isn't it? है ना? We will call it pre-oxygenation. We will call it pre-oxygenation. Isn't it? Because we are giving 100% oxygen, so we'll call it pre-oxygenation. Yes or no? Because we are giving 100% oxygen, so we'll call it pre-oxygenation. Yes or no? Can you call this pre-oxygenation? What did you understand by the word pre in pre-oxygenation? Before induction. Is this happening before induction? Is your patient awake, spontaneously breathing? No. This is happening actually just before end of anesthesia, that is just before recovery. So your patient is completely anesthetized. So will you call it pre-oxygenation? No, not pre-oxygenation. Remember this point. That is why I've been ranting since yesterday about pre. Soumya, this is not pre-oxygenation. Okay. This is simply giving 100% oxygen before the end of anesthesia. Before the end of anesthesia. That is not pre-oxygenation. Understood? So these are the two effects of nitrous oxide which bear significance. That is diffusion hypoxia and Fink effect. And if Rohan would have been attending the class today, his doubt of pre-oxygenation and diffusion hypoxia would have been clear, but I think he left. Anyway, let's look at indications of nitrous oxide. So nitrous oxide cannot be used as a sole anesthetic agent because it can never be used in 1 max. So it is used as an adjuvant, that is a carrier gas. Also, it is used as Entonox, which is a combination of 50% nitrous oxide and 50% oxygen in a cylinder, and it is used for dental anesthesia and labor analgesia. Dental anesthesia and labor analgesia. Dental anesthesia and labor analgesia. Okay, so nitrous oxide is used as a carrier gas and it is used as Entonox, which is a combination of 50% nitrous oxide and 50% oxygen, used for dental anesthesia and labor analgesia. Let's look at contraindications, and again for contraindications you need to remember 35 times more diffusible than nitrogen. "35 times more diffusible than nitrogen." So imagine if there is an air-filled cavity in the body. If there is an air-filled cavity in the body, something like this. This is an air-filled cavity. So what will happen? Nitrous oxide would want to go inside this cavity. Nitrogen would want to come out, but obviously nitrogen would come out less as compared to nitrous. So what will happen? There will be expansion of this cavity. So any place where you have a closed air-filled cavity, it will expand. And this expansion of closed air-filled cavity will cause pressure. And all these places would avoid the use of nitrous oxide. Pneumothorax, pulmonary air cyst, pneumocephalus, air embolism, tympanic membrane grafts, intraocular air bubble. Bhaskar, what do you want to use Entonox in ambulance for? What do you want to use Entonox in ambulance? So if it is pneumothorax, it will become tension pneumothorax. If it is pulmonary air cyst, it can burst. Pneumocephalus, air under dura, it can expand, cause increase in ICP, air embolism, increase the size of embolus, more complications, tympanic membrane grafts, intraocular air bubble. All of these places you would avoid the use of nitrous oxide because it will expand the air filled cavity and will cause pressure symptoms. All right, done. Now we'll just write down why xenon is a ideal anesthetic and why it is not used, and then we'll move to lunch. So just a 5-minute topic on xenon. So xenon is closest to being an ideal anesthetic agent. It is closest to being an ideal anesthetic agent. Why? Fastest onset and recovery, blood gas partition coefficient 0.15, inert, analgesic, neuro and cardioprotective, no metabolism, no malignant hyperthermia, no environmental pollution. But still it is not used. Why? High cost, low potency. Not only that the cost is high, but it is required in higher amounts, low potency. Alright, so this is about xenon. Now we'll take a lunch break. How much time you want? 40 minutes should be fine. We'll come back at 2:15 and we'll resume with rest of the inhaled anesthetic agents and then anesthesia machine, and then we'll discuss complications of anesthesia. Okay, so we'll take a lunch break till 2:15 and we'll come back, right? So see you all at 2:15. Bye bye. Everybody here, you had some things that you didn't complete, but by the time you said something I had already stopped the streaming, so I thought I'll put it up now. So if I can see some thumbs up, then I'll resume with the discussion of individual inhaled anesthetic agents. So we started with the discussion of inhaled anesthetic agents. We divided them into pure gases and volatile liquids. Pure gases were nitrous oxide and xenon. We discussed nitrous oxide in detail and xenon. And now we'll go on to volatile anesthetic agents, which is halothane, desflurane, isoflurane, sevoflurane. Perfect. So let's start with the first one, halothane. So what we are going to do is we are going to discuss halothane separately, and then we are going to compare des-iso-cevo because they are more or less similar, and at the end we'll write uses of all of them together. Okay. So let's start with halothane. Halothane is a sweet smelling liquid. It is stored in an amber colored bottle with thymol as preservative. Halothane is a sweet smelling liquid. There are only two sweet smelling inhaled anesthetic agents, sevoflurane and halothane. right? Now we already know the basic pharmacodynamic properties of all inhaled anesthetic agents. So let's start with CVS. All inhaled anesthetic agents are myocardial depressants. So they will decrease cardiac output, halothane, which will in turn decrease blood pressure. Normally, when the blood pressure decreases, there is tachycardia, but here there will be bradycardia, and it is only inhaled anesthetic agent to cause bradycardia. You can have agents that will not change heart rate, you will have agents that will increase heart rate, but there is only one agent that causes bradycardia, and that is halothane. It also increases the arrhythmogenicity of adrenaline. So if you are using halothane and if suppose you use adrenaline, there are higher chances of getting arrhythmia because of adrenaline. Therefore, if you are using halothane, you do not use adrenaline more than 1.5 microgram per kg dose. You do not use adrenaline more than 1.5 microgram per kg dose. You do not use adrenaline more than 1.5 microgram per kg dose. Also, it has got minimum decrease in SVR, systemic vascular resistance. Minimum decrease in SVR, systemic vascular resistance. So whatever cardiac output is decreasing, it is because of the myocardial depression, that is decrease in left ventricular function. Minimum decrease in SVR, systemic vascular resistance, doesn't cause peripheral vasodilatation. Doesn't cause peripheral vasodilatation. Doesn't cause peripheral vasodilatation. In respiratory system, same increase in respiratory rate, decrease in tidal volume, but with an added advantage of maximum bronchodilation. Maximum bronchodilation. Increase in respiratory rate, decrease in tidal volume with an added advantage of maximum bronchodilation. Maximum bronchodilation. In CNS, predictable effect, increase in ICP, decrease in CMRO2. Increase in ICP, decrease in CMRO2. Increase in ICP, decrease in CMRO2. What is unique is its action on uterus. It has got maximum tocolytic action. Maximum tocolytic action. It has got maximum tocolytic action. Maximum tocolytic action. And hepatic. This is the most important part of halothane, that is its effect on the hepatic system, and we know because it is second most metabolized inhaled anesthetic agent, therefore it shows lot of hepatotoxicity. The reasons are hepatic artery vasospasm, maximum decrease in hepatic blood flow, and halothane hepatitis. Hepatic artery vasospasm, maximum decrease in hepatic blood flow, and halothane hepatitis. Out of which halothane hepatitis is a very unique thing, which is an autoimmune destruction of hepatocytes. It is an autoimmune destruction of hepatocytes, which happens because of antibodies against protein adducts which are formed by metabolism of halothane. So when halothane metabolizes, it forms certain protein adducts. These protein adducts cross-react with hepatocytes, and this antibodies, they destroy the hepatocytes. Risk factor for development of halothane hepatitis is multiple exposure. Most important is multiple exposures. Because it's an autoimmune phenomena, we know all autoimmune phenomena have a risk factor in multiple exposure. Second is middle-aged obese women. Middle-aged obese women. Middle-aged obese women. And somebody who has history of autoimmune diseases. History of autoimmune diseases. History of autoimmune diseases. Now, if somebody is a known case of halothane hepatitis, then agent of choice for a patient with known case of halothane hepatitis would be sevoflurane, because no protein adduct formation with sevoflurane. No protein adduct formation with sevoflurane. No protein adduct formation with sevoflurane. Alright, so this was about halothane hepatitis and most importantly halothane. Let's now compare the three remaining inhaled anesthetic agents, and because they are very similar to each other, so we'll do that in a comparative way. Iso, des, sevo. Let's start with physical and chemical properties. Let's start with physical and chemical properties. Physical and chemical properties. So isoflurane is an isomer of N-fluorine. And we have stopped using N-fluorine because of its seizure inducing potential. We have stopped using N-fluorine because of seizure inducing potential. Isoflurane is also pungent in odor. Isoflurane is also pungent in odor. Pungent in odor. Desflurane has max pungency. Lowest blood gas partition coefficient. And unique physical property. It has got unique physical property of high vapor pressure and low boiling point. High vapor pressure and low boiling point. How much? 660 mmHg is the vapor pressure and low boiling point of 23.5 degrees Celsius. So at room temperature, desflurane will not be in liquid state. It will be actually in a gaseous state. So it is very difficult to contain the vapors of desflurane. Therefore, we use a special vaporizer. The name of this vaporizer is Tech 6. and it is a gas vapor blender. It is a gas vapor blender. These are the things that you have to remember. Unique physical property of high vapor pressure and low boiling point. Therefore, special vaporizer Tech 6, which is a gas vapor blender. These are the things that you have to remember. Sevoflurane is simple, it is sweet smelling. It is sweet smelling. Which previous slide, Subankar? Halothane? Why? We have been discussing this since 5-7 minutes. Why do you want now previous slide? Alright. Next is pharmacodynamics. Let's look at CVS. All inhaled anesthetics are myocardial depressants. So they will all decrease cardiac output. In turn, they will all decrease blood pressure. But isoflurane and desflurane increase heart rate, while sevoflurane maintains heart rate. Isoflurane also is associated with minimum LV depression. So this decrease in cardiac output is because of peripheral vasodilatation, max decrease in SVR, and it is also associated with a theoretical complication of coronary steal phenomena. Coronary steal phenomena. Coronary steal phenomena. Desflurane, apart from myocardial depression, has an indirect sympathomimetic action. So when we use it, there is a transient tachycardia hypertension. There is a transient tachycardia hypertension. While sevoflurane maintains heart rate. Sevoflurane maintains heart rate, no change in heart rate. Sevoflurane maintains heart rate. Alright. Next is respiratory system. All of them increase respiratory rate, decrease tidal volume. Increase respiratory rate, decrease tidal volume. Desflurane has max incidence of airway complications because of its pungency. It leads to coughing, breath holding, bronchospasm. So ISO and DES not used for induction. ISO and DES not used for induction. Sevoflurane is on the other hand sweet smelling, so agent of choice for induction, inhalational induction of anesthesia. CNS, all of them increase ICP, decrease CMRO2, but minimum increase in ICP, maximum decrease in CMRO2 is seen with sevoflurane. Minimum increase in ICP, maximum decrease in CMRO2 is seen with isoflurane. Let's look at the uses. Let's look at the uses. So let's look at uses. Halothane is agent of choice for bronchial asthma. It is agent of choice for bronchial asthma. Isoflurane for cardiac patients. Liver transplant and hypotensive anesthesia. Desflurane for elderly, bariatric surgery, and sevoflurane for daycare surgery, pediatric inductions, known case of halothane hepatitis, neurosurgery, raised ICP surgery. Neurosurgery, raised ICP surgery. Let me know when you are done writing. This ends our discussion of inhaled anesthetic agents. Inhaled anesthetic agents. Halothane hepatitis. I think I've made this thing clear before only. You only use a inhaled anesthetic agent for induction when it has one very specific property. What is that property? We have discussed that while we were discussing induction agents only. When we were discussing induction agents, turn your page, go to induction agents, the first page of induction agents, and see what I have written, what I have made you write there. Now, is isoflurane pungent in odor or sweet smelling? Is isoflurane pungent in odor or sweet smelling? Bhaskar. So should it be used for induction of anesthesia? Would you want to be induced with isoflurane? Would you want yourself to be induced with isoflurane? No, na? Anything that is pungent in an awake patient will cause discomfort. Our idea is to not give discomfort to the patient. Okay. Let's move on to a very small and interesting topic of anesthesia delivery systems or anesthesia machine. Now this is the part where we will discuss all the practical aspect of things, and therefore there are going to be a lot of saltatory things that we are going to discuss, because we don't want to discuss everything that is there in anesthesia delivery systems. It's a too vast a topic. We'll only discuss things that are being asked in the exam, right? So what is anesthesia delivery system is the journey of carrier gases right from the time that they are stored source to the patient. Source to the patient. So there are essentially two types of sources of carrier gases. You can either find it through pipeline or a cylinder. Both of these sources of carrier gases culminate into the gas inlet on the anesthesia machine. They terminate into the gas inlet on the anesthesia machine, which after relevant pressure reduction goes through flow meter that will measure the flow of these carrier gases, and which will go to the vaporizers and will pick up the vapors of inhaled anesthetic agents and deliver it to common gas outlet CGO, which is the exit from the anesthesia machine. From there, the breathing circuit will pick up these vapors along with carrier gas and deliver it to the patient's airway and to the patient. Now we know everything below patient's airway. Now we'll discuss few things above it, right? So let's start with the anesthesia machine. Let's start with anesthesia machine. Let's start with anesthesia machine. So this is how a typical anesthesia machine looks like. This is an old machine. You might be seeing it in government medical colleges still, which is the Boyle's apparatus. Well, this is what you will see in most places, which is anesthesia workstation. All the things that we are going to discuss are common for both. The structure is different, but the functioning is same. It's just anesthesia workstation. Everything is automated, electronic, while everything in anesthesia machine is mechanical. Let's divide this anesthesia machine, any anesthesia machine, into three parts based on the pressure at which it works, into high pressure, intermediate pressure and low pressure systems. High pressure, intermediate pressure and low pressure systems. High pressure is all the parts of anesthesia machine that receives gases at cylinder pressure, which is 750 to 2000 psi. The the parts are hanger yoke assembly, Borden's gauge, pressure reducing device. Hanger yoke assembly, Borden's gauge and pressure reducing device. Bhaskar, the previous slide was a photograph of anesthesia machine and Boyle's apparatus. You want to draw that? You want to draw that? Right, intermediate pressure system is all the parts of machine that receive the gases at pipeline pressure. Which is 45 to 60 psi. 45 to 60 psi. And finally, low pressure system, that is just supra-atmospheric, so that it flows to the patient. Supra-atmospheric, that is 14 to 28 psi. 14 to 28 psi. Just note this thing down, Bhaskar, what is in front of you. Later on we'll go and write that also, है ना? Just complete this. Intermediate pressure system includes pipeline inlet, oxygen flush, and oxygen pressure failure devices. Oxygen pressure failure devices, OPFD. While low pressure system consists of flow meters, vaporizers, and common gas outlet. 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 Right? Now we'll discuss individual things first. Bhaskar, fadafat complete this so that I can move on. Done? Okay, sure. Let's start with the first part of our discussion, that is anesthesia cylinders. This is how a cylinder looks like. This is how a cylinder looks like. These are mounted on the back of anesthesia machine. These are small cylinders. Cylinders are high pressure storage of gases. Cylinders are high pressure storage of gases. The material from which it is made up of is molybdenum steel. It's an alloy. Molybdenum steel. The material from which cylinder is made up of is molybdenum steel, which is an alloy. While MRI compatible cylinders are made up of aluminium. MRI compatible cylinders are made up of aluminium. The sizes of cylinders are from A to H. A to H. A being smallest, H being largest. Most common used size is E, that stands for emergency gas supply. Emergency gas supply. Most common used size is E, that stands for emergency gas supply. Emergency gas supply. Okay. Now what we are going to do is we are going to write some features of a cylinder and then we'll discuss about them in some time. Okay. So just write down features of a cylinder. Features of a cylinder. First note this table down and then we'll discuss about it. Features of a cylinder. So in one column write gas, color of the cylinder, pin index. Gas, color of the cylinder, pin index. So gas, air, color of the cylinder, black body with black and white shoulder, pin index 15. Black body with black and white shoulder, pin index 15. Black body with black and white shoulder, pin index 15. Oxygen, black body with white shoulder, pin index 25. Nitrous oxide, blue cylinder, pin index 35. CO2, gray cylinder, depends on the percentage of the gas. More than 7.5%, 16. Less than 7.5%, 26. Cyclopropane, orange cylinder, pin index 36. Antonox, blue body with blue and white shoulder, pin index 7. Pin index 7. First write this thing and then we will discuss about the importance of color and pin index. Everybody done? Okay. Now we can all understand color as a safety feature. Color is for both identification and safety, isn't it? you can identify the cylinder easily, and it is a safety feature so that you don't by mistake put a wrong cylinder in the wrong port. But this is not enough, because color can fade, color can have different interpretations, people can forget the color. So an added layer of safety has been added called as pin index system. What is this pin index system? So it's a set of pins on the anesthesia machine and indexes on the neck of the cylinder. And for every gas, there is a specific set of a central hole and two peripheral holes. Each gas has a very specific pin index number, and therefore the pins would be in that specific order, both in the port where the cylinder is fitted on the anesthesia machine as well as the neck of the cylinder. Okay. So as you can see that O2 has ports at 2 and 5 while nitrous has 3 and 5. So you cannot put nitrous oxide in the port for an O2 cylinder because the pins would be at the arrangement of 2 and 5. This will prevent wrong attachment of anesthesia cylinder to the machine. So let's look at two safety features in anesthesia: pin index safety system and diameter index safety system. Pin index safety system prevents wrong attachment of cylinder to machine. And a similar system that is made for pipeline is a diameter index safety system that prevents wrong attachment of pipeline to machine. Prevents wrong attachment of pipeline to machine. Wrong attachment of pipeline to machine. Right? So pin index safety system prevents wrong attachment of cylinder to machine. Diameter index safety system prevents wrong attachment of pipeline to machine. Pipeline to machine. Next is an entity called as O2 flush, which is a part of intermediate pressure system. O2 flush, which is a part of intermediate pressure system. See, this is a valve that is in the front of the machine that looks like this, O2 plus. When you press this valve, there is flow of 100% oxygen from the common gas outlet at high flows, 35 to 75 liters per minute. So it's a part of intermediate pressure system. Remember, the flows are high, not the pressure is high. Pressure is intermediate. So it's a part of intermediate pressure system. This is a valve which when pressed gives 100% oxygen from common gas outlet. What is the use? Its use is emergency O2 supply. Its use is emergency O2 supply. So high flow of oxygen, whenever required, the bellows are collapsing or the patient is becoming hypoxic, you are not able to ventilate, there you will use O2 flush. But it has certain disadvantages. Because there is such high flow of gas, therefore it can cause barotrauma. Such high flow of gas when moves towards the patient, it can cause barotrauma. Also, these are non-anesthetic. This is 100% oxygen, is devoid of any anesthetic gases. So it can cause intraoperative awareness. Because suddenly all the inhaled anesthetic agents that is there in the system will wash out and a large amount of pure 100% oxygen will reach the patient. So it can cause intraoperative awareness. Intraoperative awareness. Yes, there is color specification in pipeline like cylinder, although that is not very important for us, therefore we are not discussing. Cylinder color is something that has been asked multiple times. Just remember that even in pipeline, the color for nitrous oxide pipeline is always blue. Nitrous oxide pipeline is always blue. Rest, according to standards, it can change. In American standard, oxygen is green. In Indian standard, oxygen is yellow, white. American standard, suction is black. In India, suction is yellow. So it can change. But nitrous oxide is always blue. Next is flow meter. Next is flow meter. Flow meter. What does flow meter do? Measures the flow of carrier gases. Measures the flow of carrier gases. Now, how many carrier gases are there in anesthesia? How many carrier gases can we use? Can you name the most important carrier gas? Can you name the most important carrier gas? Most important carrier gas. Very good. Nitrous oxide. Because nitrous oxide is required for living, right? Nitrous oxide is required for living. Without nitrous oxide, we all will die, isn't it? Without nitrous oxide, we all will die. है ना? Just because I have made you write that nitrous oxide is a carrier gas, does that make it the most important carrier gas? Which according to you should be the most important carrier gas? Which according to you should be most important carrier gas? Oxygen. So there are three carrier gases in anesthesia: O2, nitrous and medical air. Medical air. O2, nitrous and medical air. Why nitrogen? Why nitrogen? Nitrogen doesn't give any particular advantage. It's not nitrogen, it's medical air. You don't use pure nitrogen. You will always use it with oxygen. That is called as medical air. It is just normal air, 79% nitrogen, 21% oxygen. It is devoid of any impurities. Okay. So since there are three carrier gases, therefore there has to be three flow meters that are there in anesthesia. Three flow meters. All right. Let's discuss flow meter. So every flow meter has two parts: a Thorpe's tube, and inside that Thorpe's tube is a bobbin or a float. Inside that Thorpe's tube is a bobbin or a float. This Thorpe's tube is a conical glass structure. Conical structure made up of Pyrex glass, while this bobbin or float is made up of aluminium. Bobbin or flow meter is made up of aluminium. Bobbin or flow meter is made up of aluminium. Bobbin or flow meter is made up of aluminium. What is the most important question that they ask us in flow meter is, what is the principle of working? What is the principle of working? The principle of working of a flow meter is this: variable orifice constant pressure. Principle of working is this funda called as variable orifice constant pressure. You can see there's a Thorpe's tube. Inside the Thorpe's tube is a bobbin or a float. When you open this flow control valve, it's like a valve, it's like a chakri. So when you open it, gas flows from below and pushes this bobbin up. Till what point will this bobbin go up? Till the push of the air equals to the weight of the gravity, the pull of the gravity. So at any point of time, what is the pressure across this bobbin? Always zero, that is constant. While as the flows increase, what happens to the area around the bobbin? It will keep on changing. So more gas will flow. At lower flows, because it's a conical shape, at lower flows, less area around the bobbin. So less gas will skip. At higher flows, more area. So constant pressure, variable orifice. Constant pressure, variable orifice. This is the principle of working of a flow meter. Principle of working of a flow meter. This line is what they ask. Constant pressure, variable orifice. Constant pressure and variable orifice. Constant pressure and variable orifice. How to read this flow meter? So it depends on the shape of the bobbin. If the bobbin is cylindrical in shape, you read it from the top. If the bobbin is spherical in shape, you read it from the equator. So if the bobbin is cylindrical in shape, you read it from the top. If the bobbin is spherical in shape, you read it from the equator. Okay. Coming back to, this is principle of working of flow meter. How does flow meter work? What is the function of flow meter? It is to measure the flow of gases. It is to measure the flow of gases, right? So if you are, whether you are giving 1 liter per minute, 2 liter, 3 liter, 4 liter, 5 liter, what is the flow of gases that you are giving to the patient? So what you will do, you will open this flow control valve and the gas will start flowing up. What will it do? It will push the bobbin up. So now tell me, at what point will this bobbin stop? At the point at which the pull of the gravity, that is the weight of the bobbin, equals to the push of the flow of gases. That level will be read as the flow of that particular gas. So at 1 liter per minute, it will be at 1. Now you increase the flow. What will happen? More gases will push. Now this bobbin will get pushed higher. Larger orifice will be open up. So large amount of gas will skip and it will say come to 10. So now you are pushing 10 liters per minute of fluid of the gas, right? So as the flows increases, the bobbin goes up and up. The more the bobbin goes up, more gas flows out and more will be the reading. So your flow meter will adequately tell you the reading of the flow of the gases, right? So it is variable orifice. The orifice keeps on changing because it's a conical tube. So the orifice around the bobbin keeps on changing, but at any point of time, when it is suspended in the air, the pressure across the bobbin will always be the same. Why? Because the push of the gases will equate to the pull of the gravity, right? That is the principle of working of flow meter. Principle of working of flow meter. Preeti, Bhaskar, is it clear now? Is it clear now? I told you there are 3 flow meters that are possible on anesthesia machine. How to arrange them? Don't draw the diagram. That is just for understanding. Relative arrangement of flow meters. See, if you keep any other gas apart from oxygen as the most downstream means towards the patient, then in case there is a breach in the continuity of any other flow meter, the patient will receive hypoxic mixture. The patient will receive hypoxic mixture. But if you keep O2 as the most downstream gas, then irrespective of what happens to other flow meters, the patient will always receive oxygen. So will not become hypoxic. So just write one line. Oxygen should be most downstream of all gases. In the relative arrangement of flow meter, just write one line that oxygen should be most downstream of all gases. Oxygen should be most downstream of all gases. Oxygen should be most downstream of all gases. In the relative arrangement of flow meters, oxygen should be most downstream of all gases. Alright. Next is vaporizer. This is how a vaporizer looks like. It is a mountable structure which is there on the front of anesthesia machine. You fill the volatile anesthetic agent here and the carrier gases pick up the vapors and deliver it through the common gas outlet. Now vaporizers work on the principle of vapor pressure. Principle of working is based on vapor pressure of a gas. And since vapor pressure of each agent is unique, therefore all vaporizers are agent specific. That means you cannot use one vaporizer to deliver another vapor. Agent specific. All vaporizers are agent specific. They are also color coded for ease of identification. They are also color coded for ease of identification. Purple, isoflurane. Blue, desflurane. Yellow, sevoflurane, and red, halothane. Purple, blue, yellow and red. These are color coded for ease of identification. Right? So this was the part about anesthesia machine. Let's come to breathing circuits. Now, how do you see a breathing circuit as? This is the patient's airway, this is the anesthesia machine. Something that joins the two is a breathing circuit. Breathing circuits are traditionally classified as semi-closed and closed. Semi-closed breathing circuits are partial rebreathing circuits. Example, Mapleson type of circuits. The advantage of using partial rebreathing circuits like Mapleson type of circuits is because they are cheap, easy to use, handy, that is lightweight. Closed circuits are complete rebreathing circuits. Complete rebreathing circuits. Complete rebreathing. That means the patient rebreathes all of their expired gases. Complete rebreathing circuits. Example, circle system. Example, circle system. What are the advantages of a complete rebreathing circuit? The most important is economical, because you will save lot of anesthetic gases. Economical. Second, less OT pollution. Less OT pollution. Third, less chances of airway fire or OT fire. And heat and humidity is maintained. Heat and humidity is maintained. Right? Let's discuss Mapleson circuits. These are easiest circuits to learn and understand. Mapleson circuits. There are 6 types of Mapleson circuits. There are 6 types of Mapleson circuits: A, B, C, D, E and F. 6 types of Mapleson circuits. Out of that, B and C are obsolete, not used anymore. We only have to know another name for C, which is Waters to and fro canister. Waters to and fro canister. Waters to and fro canister. Out of this, A and D are adult circuits, while E and F are pediatric circuits. That means weight of the baby less than 20 kgs. Weight of the baby less than 20 kgs. A is also called as McGill's circuit. McGill's circuit. And A has a coaxial variant which is called as lax modification. It has a coaxial variant which is called as lax modification. You guys with me? Is the video okay? My video got hanged. Everybody okay? You are here or your BIS has dropped to 20 to 40? What is your BIS? What is your BIS? Post-lunch sessions are always amazing, right? You never realize only how time has passed. है ना? Never realize how time has passed. Now, Mapleson A is used for spontaneous ventilation. A spontaneously breathing patient, Mapleson A is the choice. Pooja, if you are getting blurred, that means it's internet problem, because I'm not getting any blurring in the video. क्या बात है अनुराग कुमार, more than 100. The fresh gas flow on the flow meter that is required to maintain a proper ventilation using Mapleson A or McGill circuit equals to minute ventilation. What is minute ventilation? Respiratory rate into tidal volume. That is minute ventilation. Respiratory rate into tidal volume. Mapleson D is also called as Bain's circuit. It is circuit of choice for controlled ventilation. And the fresh gas flow required is 1 to 2 times the minute ventilation. Bain circuit is also most common used Mapleson circuit. Yeah, Prince, I was about to ask you, how are you feeling? But your body should not be tired, no? It's just 6 hours of today. Right? It should start getting tired after 7 p.m. That is when real problem happens. You are attending from home or you are in a VSET center. If you are at home, you are actually most comfortable. Sometimes these classes in the centers in hot weather, sometimes the power used to go and so much of sweating and everything and uncomfortable chairs. That is when real problem used to happen. That is nice to know. Even I am enjoying. Even I am enjoying. It's a very interactive batch. In an online class, the interaction that happens on the chat box is the only thing that that keeps us going. In a live class, interaction can be made. You know, I can pick somebody and tell them, okay, ye batao, wo batao. But in an online class, if you guys don't interact, then it becomes very boring. I took last year a batch. I think very few students were there. It was near exam time. And for almost like 3.5 hours, there was nothing on the chat box. Like absolutely no activity on the chat box. I felt like it's just me and the camera. In the end, I asked how many students are there. I think there were 4 or 5 students who were present till the end. I don't know how many were there in the class. Water's to and fro canister. To and fro, आगे पीछे, to and fro canister. Water's to and fro canister. A and D are adult circuits. A and D are adult circuits. E and F are pediatric circuits. Shreyasi. Now E and F are both pediatric circuits. Names are very important. E is called as Ayer's TPs, while F is called as Jackson and Rees modification of Ayer's TPs. Jackson and Rees modification of Ayer's TPs. They're equally good for spontaneous ventilation and controlled ventilation. And the fresh gas flow required is 2 to 3 times the minute ventilation. If you have to choose between E and F, which one will you choose for any given patient? If both are given in the option and they're asking you to pick the best one, which one will you choose? Which one will you choose between E and F? For a pediatric patient, which one will you choose? Obviously, you will choose F over E because F is a modification. So modification means it is better than E. Right? So this was about Mapleson circuit, which are semi-closed circuit. Let's come to circle system. This is a circle system. And while we were discussing capnogram, somebody asked, sir, what is inspiratory valve? What is expiratory valve? So now pay attention. Circle system is called circle because of this entity called as CO2 absorber. So what happens is whatever is the expiratory gases, they pass through a chemical that will absorb the CO2 from the expired gases and deliver it back to the patient. That is why they are complete rebreathing circuit. Rebreathing means inspiration of expired gases. Bhaskar, spontaneous ventilation and controlled ventilation. So the expiratory part of the circuit contains expiratory unidirectional valve, which will only allow gas to go out, not come in, and inspiratory unidirectional valve will only allow gas to come in and not go out. These are inspiratory and expiratory valves in the circuit, right? And the most important part of a circle system is this CO2 absorber. CO2 absorber. So let's discuss CO2 absorber. It looks like this, a canister which is mounted on the anesthesia machine that contains granules. These granules are made up of chemicals that absorb CO2. Traditionally, there are two types of CO2 absorbers based on the chemical structure, soda lime and bara-lime. Soda lime contains calcium hydroxide 80%, sodium hydroxide 3%, potassium hydroxide 2% and water 16%, while bara-lime contains calcium hydroxide 73%, barium hydroxide 11%, potassium hydroxide 5% and water 11 to 16%. Absorptive capacity of soda lime is 14 to 23 liters of CO2 per 100 gram of absorber, while bara-lime is 9 to 18 liters of CO2 per 100 gram of absorber. 9 to 18 liters of CO2 per 100 gram of absorber. Now, how would you come to know? It's a chemical, right? It's a chemical. So at some point of time, this chemical is going to get exhausted, isn't it? At some point of time, this chemical is going to get exhausted. How would you come to know that the chemical has got exhausted? So if you look at capnography, you might find graph of rebreathing where the graph is not touching the baseline, but we always don't wait till that time. So what we do, we add an indicator that changes color on exhaustion. Most common used indicator is ethyl violet. Most common used indicator is ethyl violet. Most common used indicator is ethyl violet. Sadly, yes. In the past, they have asked questions on percentage of what is what. Now they don't ask it anymore, but if it is possible for you, then please remember. Interactions. Again, inhaled anesthetic agents are chlorofluorocarbon molecules. Chlorofluorocarbon molecules, right? Chlorofluorocarbon molecules. So when they are constantly passed through agents that have highly caustic substances in them, sodium hydroxide, potassium hydroxide are highly caustic substances. So they will obviously break down the molecules of inhaled anesthetic agents, and what comes out is always toxic. So let's see. Soda lime on interaction with trilene forms two things: phosgene gas and dichloroacetylene molecule. Phosgene gas and dichloroacetylene molecule. Phosgene gas causes ARDS, while dichloroacetylene molecule dichloroacetylene molecule is a neurotoxic substance. Is a neurotoxic substance. Soda lime on interaction with sevoflurane forms a compound called as compound A, and this compound A is nephrotoxic. Compound A is nephrotoxic. Bara-lime on interaction with carbon monoxide forms substantial amounts of bara-lime on interaction with desflurane forms carbon monoxide. Sometimes this is so high that it can cause carboxyhemoglobinemia. It can cause carboxyhemoglobinemia. Right? All of this is happening because of highly caustic substances that are present in the CO2 absorber. That is why they are splitting the molecules of inhaled anesthetic agents. Splitting the molecules of inhaled anesthetic agents. So what do? You take a newer absorber that doesn't contain any caustic substance. So no drug interaction, absorb. No drug interactions, absorb. What are the contents? Calcium hydroxide 75%, calcium chloride and sulfate less than 1%, and water 14.5%. And water 14.5%. Water 14.5%. Water 14.5%. All right. Now I know we have just started an hour and 15 minutes back, but we are done with the conduct of general anesthesia. Now we'll discuss a topic of complications in anesthesia. So you want a 10-minute break, you want to go freshen up, have a cup of tea and come back, or you want me to start this and then give you a break, say around 1.5 hours from now? What do you want to do? I'll leave up to you guys. Sometimes in the post lunch session you need a quicker break for tea, so that's why I'm asking. You tell me, what do you want? You want me to continue or you want me to take a quick 10-minute break, not more than 10 minutes? Okay, so most of the students are saying to continue, है ना? Alright, so what we'll do is we'll continue, and whenever you guys feel very sleepy or you feel you want a break, because this is a 1.5 hour topic, okay? So either we finish it at 5:15 and then take a break, or if you guys want, then we can take a break at any point of time in between this topic as well. Okay. Let's start with the first. And most common complication. Just write it down. I'm coming in a minute. No, Soumya. I don't think it is important to know the diagrams of Mapleson circuit. Risk factors for post-operative nausea and vomiting are described as Apfel criteria, that includes female gender, non-smoker, history of motion sickness or PONV, use of opioids and nitrous oxide. Use of opioids and nitrous oxide. Then there are surgery related risk factors like gynec, opthal, ENT, thyroid surgeries are increased risk of PONV. This is important. Strabismus surgery is identified as a independent risk factor for POV. POV, which is post-operative vomiting. Nausea is a complaint, something not feeling good, feeling of not feeling good, or vomiting feeling. Children below 5 years of age cannot tell you this thing, therefore it is always POV. It is always POV. POV. Okay. Now, management of every complication will involve always two things: prevention and treatment. And remember, prevention is always taking care of the risk factors. So what are the risk factors? Female gender, non-smoker. So it's not like you will not operate on female, or you will give a cigarette smoke to somebody to decrease the risk of post-operative nausea, vomiting, right? So what you can do is you can avoid using inhaled anesthetic agents. So give a TIVA based anesthesia. TIVA means you do not use any inhaled anesthetic agent. Agent of choice for TIVA is propofol. And propofol has added antiemetic properties, right? Ondansetron and dexamethasone. And in treatment, obviously agent of choice is the first line that we use for ourselves as well. 5-HT3 receptor antagonist, that is ondansetron. You can use anticholinergics like scopolamine, hyoscine. D2 antagonist like droperidol. Steroids like dexamethasone. And a newer agent in the form of neurokinin receptor antagonist by the name aprepitant. Neurokinin receptor antagonist by the name aprepitant. Yes, this is management of post-operative nausea and vomiting. Deepak, this is management of post-operative nausea and vomiting, PONV. Post-operative nausea and vomiting. Management of post-operative nausea and vomiting. All right. So guys, let's take a break for 10 minutes. It will be a quick break. Actually, I'm getting call for that patient in ICU. I need to instruct them regarding the management. So it's going to take anyway 5-7 minutes. So better you guys also take a break. We'll meet in 10 minutes, right? So it's 3:45. So see you at 3:55 PM. Is it okay? Just a quick 10-minute break. We'll take a break around 6:30 again. 6:30, 6:45, don't worry. Okay. So let's quickly take a break and come back in 10 minutes and then resume with complications in anesthesia. So the first complication that we discussed was PONV, post-operative nausea and vomiting. Now let's discuss the second complication, that is temperature related complication. Okay. So temperature related complication can be hypothermia or hyperthermia, out of which common is hypothermia. Before we define hypothermia, you guys are here? Just give me some thumbs up so that I can start the class. Perfect. So before we define hypothermia, we should first ask us what is normal body temperature. And when we ask normal body temperature, we should first ask this question: what are sites of temperature monitoring? What are sites of temperature monitoring? So traditionally there are two types of sites: core body temperature and peripheral temperature. Core body temperature and peripheral temperature. Core body temperature is temperature of deep body organs. Example: heart, brain, liver. And the sites where you can monitor them, gold standard is considered to be pulmonary artery catheter or pulmonary artery temperature, while the most common used site is lower end of esophagus. Most common use site is lower end of esophagus. Lower end of esophagus. Apart from that, you can use tympanic membrane, nasopharynx. Tympanic membrane, nasopharynx. Peripheral temperature is all the sites that you can monitor as an intern, like skin, oral, rectal, axilla. What do you mean by open slide? Prince, what do you mean by open slide? So when we talk about normal body temperature, we talk about core body temperature, and we say that it is always a range of 36.5 to 37.5 degrees Celsius. It is always a range of 36.5 to 37.5 degrees Celsius. Based on this normal temperature, we can define hypothermia as core body temperature less than 36 degrees Celsius. Core body temperature hypothermia is less than 36 degrees Celsius. Now Any patient who is in the operation theater for more than 30 minutes is bound to get hypothermic. Why? Because of the roots of loss of heat. The order of root of loss of heat for intraoperative hypothermia is radiation contributes maximum, followed by convection, followed by conduction, followed by evaporation. Radiation, convection, conduction and evaporation. Radiation, conduction, convection and evaporation. All right. So this is hypothermia. Hypothermia. Now, what are the implications of perioperative hypothermia? So let's see effects of perioperative hypothermia. The first and the most important effect is post-anesthesia shivering. First and most important effect is post-anesthesia shivering. Now, what happens in the post-anesthetic period? Shivering will increase myocardial oxygen demand and increase metabolic work. But because the oxygen supply is less, there is decreased supply of oxygen. So that is why shivering is not recommended. Shivering is not recommended in the post-operative period. So what do? We treat it with agent of choice as pethidine or meperidine. Pethidine or meperidine. This is a weak opioid considered to be agent of choice for post-anesthesia shivering. Yes, Bhaskar, very good. Apart from that, we can use tramadol, magnesium sulfate, even clonidine. Post-anesthesia shivering. Now, post-anesthesia shivering is seen maximum with use of halothane. And when it happens with halothane, it is called as halothane shakes. When it happens with halothane, it is called as halothane shakes. Maximum with the use of halothane called as halothane shakes. All right. Another effect is impaired coagulation and delayed recovery from anesthesia. We have read it that hypothermia decreases metabolism of almost all drugs. So recovery from anesthesia will be delayed, and impaired coagulation. Impaired coagulation. Because coagulation factors require normal body temperature. If the temperature decreases, then the coagulation factors, they fail to work. Next, temperature related complication. Okay, Abhishek, you want sites of core body temperature. Okay, I'll put it for a minute. Just finish it. Isn't it something that we have already discussed in hypothermia? The metabolism of almost all drugs get impaired. So if the metabolism is impaired, all the drugs will have prolonged action, so there will be delayed recovery from anesthesia. Okay. Let's come to a very important complication called as malignant hyperthermia. Malignant hyperthermia. Now this is actually a syndrome. It's a clinical condition. It's a rare genetic hypermetabolic muscle disorder. Rare genetic hypermetabolic muscle disorder. Rare genetic hypermetabolic muscle disorder. This malignant hyperthermia happens because of mutation in the gene coding for ryanodin receptor. This gene is present on chromosome 19 and causes dysfunction of this ryanodin receptor, which is responsible for calcium homeostasis. So calcium homeostasis gets affected and there is massive release of calcium from sarcoplasmic reticulum that causes massive muscle contraction and eventually increase in temperature. This is pathophysiology of malignant hyperthermia. But what is important to know is that it's a trigger based event, and that is why we read it under anesthesia, because the triggers are anesthetic triggers, which is scoline and all volatile anesthetic agents. Scoline and all volatile anesthetic agents. So tell me, if I'm writing all volatile anesthetic agents, then which agents are excluded? Which agents are excluded? If I'm writing all volatile anesthetic agents, then which agents are excluded? Nitrous and xenon. Wonderful. So that is why it is very important to remember. Very important to remember the difference between inhaled anesthetic agents and volatile anesthetic agents. All right. So because it's a trigger based events and trigger are anesthetic, therefore most of the time we are the ones who see this syndrome, and that is why we discuss it under complications in anesthesia. Now we will divide the clinical manifestation based on the pathophysiological changes that happen with malignant hyperthermia. The first and the most important thing that happens is sudden and massive increase in metabolism, increased metabolism. This leads to sympathetic stimulation, massive muscle contraction leads to muscle damage, and finally hyperthermia. Finally hyperthermia. Finally hyperthermia. Increased metabolism will always present with sudden and abrupt rise of EtCO2. Sudden and abrupt rise of EtCO2, because metabolism means increased CO2 production. That will appear as sudden and abrupt rise of EtCO2 and tidal CO2. Also, the patient will have decreased oxygen now, so hypoxia, sometimes so much that even it can lead to cyanosis. Now there will be increased production of CO2 that will not get excreted, so it will cause respiratory acidosis, as well as hypoxia will cause anaerobic metabolism that will lead to metabolic acidosis. So mixed respiratory and metabolic acidosis, mixed respiratory and metabolic acidosis, mixed respiratory and metabolic acidosis. Sympathetic stimulation will lead to increase in heart rate, increase in BP and arrhythmias. Increase in heart rate, increase in BP and arrhythmias. After hypoxia and cyanosis, it can lead to respiratory and metabolic acidosis. Respiratory acidosis because there will be accumulation of CO2 in the lungs. Metabolic because hypoxia will cause anaerobic respiration. Hypoxia will cause anaerobic respiration. Sympathetic stimulation will lead to increase in heart rate, increase in blood pressure, arrhythmias, and muscle damage. Muscle damage. Muscle damage. Now, muscle damage presents as masseter spasm, increased serum creatinine kinase, hyperkalemia, and sometimes even rhabdomyolysis. And finally, hyperthermia that presents as fever, sweating, and sometimes even seizures. Fever, sweating, and sometimes even seizures. Alright. These are the plethora of clinical manifestations with which a patient will present with malignant hyperthermia. How do we diagnose and what are the differential diagnoses? So diagnosis can be either pre-operative diagnosis or intraoperative. Pre-operative diagnosis is done when there is a suspicion that the patient might be a case of malignant hyperthermia. So in this case, we do a gold standard investigation in the form of caffeine, halothane, contracture test. caffeine halothane contracture test, which is gold standard. Yes, serum creatinine kinase. When the muscle breakdowns, then the creatinine kinase rises. Caffeine halothane contracture test is the gold standard test for pre-operative diagnosis of malignant hyperthermia. Pre-operative diagnosis of malignant hyperthermia. Intraoperatively, the earliest and most sensitive indicator is sudden and abrupt rise of EtCO2. Earliest and most sensitive indicator is sudden and abrupt rise of EtCO2. Sudden and abrupt rise of EtCO2. And actually hyperthermia is a late sign. It appears late. Hyperthermia is a late sign. It appears late. It appears late. Let's look at differential diagnosis. So conditions that will mimic malignant hyperthermia, so that means that are sudden and will cause massive hemodynamic change. Something like thyroid storm, pheochromocytoma, and a drug-induced condition like neuroleptic malignant syndrome, NMS. Neuroleptic malignant syndrome. Neuroleptic malignant syndrome. Neuroleptic malignant syndrome. Alright, this is how you diagnose, and these are the differentials of malignant hyperthermia. Differentials of malignant hyperthermia. Now comes the most important part, that is management. And management will again involve prevention and treatment. In prevention, the first thing to do is to remove the offending agent, right? So you will give a TIVA based anesthesia. Suppose somebody is a known case of malignant hyperthermia. So you will give a TIVA based anesthesia. That means you will not use any of the trigger factors. This is also called as trigger free anesthesia. So apart from the triggering agent, you will use everything else. So you will not use choline, you will not use inhaled anesthetic agents. So that will be a TIVA based anesthesia. Second thing will be to remove the vaporizer from the machine. To remove the vaporizer from the machine. Remove the vaporizer from the machine. Because vaporizer contains vapors of volatile anesthetic agent, and if they are around, by mistake somebody who is not supposed to get it, they will come and switch it on and they might get inhaled anesthetic agent. So it's better to remove the vaporizer from the machine. It is always better to remove the vaporizer from the machine. But once it happens, then it is a die-hard emergency condition. Once it happens, it is a die-hard emergency condition. So how would you treat it? The first step would be to inform the surgeon and call for help. First step would be to inform the surgeon and call for help. Inform the surgeon and call for help. Because you will require many people to manage such a multi-system disorder. Then you will start by giving the drug of choice for the treatment of malignant hyperthermia, that is IV dandrolin. Dandrolin is a skeletal muscle relaxant that will push the calcium back into the sarcoplasmic reticulum, thereby terminating the event of malignant hyperthermia. It is given in the bolus dose of 2.5 mg per kg every 5 minutes, maximum 10 mg per kg. That means you can give up to 4 boluses, followed by an infusion of 1 mg per kg given over 6 hours for 24 to 48 hours. 1 mg per kg given over 6 hours for 24 to 48 hours. This is the initial management to terminate the event of malignant hyperthermia. Inform the surgeon, call for help, start dandrulan. After that, you will take care of the symptoms. So whatever symptoms that the patient is having, whatever problems the patient is having, you will start treating them one by one. So there is respiratory acidosis. So you will intubate, hyperventilate with 100% oxygen. So you will take care of hypoxia and hypercapnia. For metabolic acidosis, you will give soda bicarb. For hyperkalemia, you will give glucose plus insulin infusion. For arrhythmias, you can give all antiarrhythmics except verapamil, because verapamil is a CCB and it will increase the serum potassium. It will increase the serum potassium, and this is something that has been asked in AIMS in the past. This has been asked in AIMS in the past. So complete this management of malignant hyperthermia and then let me know. Done? Any doubts in the management of malignant hyperthermia? Okay, Bhaskar, glucose insulin infusion is a treatment modality for severe hyperkalemia. You will read details about it in medicine. For right now, just write glucose plus insulin infusion. That is one of the established mechanisms because insulin drives potassium inside the cell and insulin will cause hypoglycemia. So for management of severe hyperkalemia, you use glucose plus insulin infusion. Okay. Clinical manifestation slide I'll put up. बच्चे वेरापामिल इज अ CCB, कैल्शियम चैनल ब्लॉकर, है ना. इट्स एन एंटी एरिथमिक एजेंट which is also a CCB, and CCBs have a complication of increasing serum potassium. Already there is pre-existing hyperkalemia, so you would avoid the use of CCB as an antiarrhythmic agent. You would avoid the use of CCB. Amongst calcium channel blockers, verapamil is used as an antiarrhythmic, so therefore specifically verapamil. Bhaskar, calcium channel blocker doesn't really mean that it will block calcium channels at the muscle, sarcoplasmic reticulum, right? The site of action of verapamil as a calcium channel blocker causing vasodilatation is in the vessels, not in the muscles, है ना. इसीलिए verapamil नहीं dandrolin किया जाता है, which is a skeletal muscle relaxant, which is doing the same thing, but it is doing at the muscle. The problem in malignant hyperthermia is happening at the muscle, not at the level of vessels. CCB is a antihypertensive. Why? Because it causes calcium channel blockage at the vessels, therefore causes vasodilatation. समझ गए? तो you go and read about CCB in antihypertensives and you will know the reason why it cannot be used in the treatment of malignant hyperthermia. ऐसा नहीं है कि बॉडी के हर जगह पे कैल्शियम चैनल ब्लॉक करेगा, है ना. Now masseter spasm, this is something that we have written at two places. What are the two places where we have written masseter spasm? Yeah, one, we have written it as a complication side effect of scoline. Secondly, we have written in malignant hyperthermia. So what is masseter spasm? Masseter spasm is trismus, which is a forceful contraction of jaw musculature that prevents full mouth opening. It is forceful contraction of jaw musculature that prevents full mouth opening. Forceful contraction of jaw musculature that prevents full mouth opening. This is a direct effect of use of scoline. When you give scoline, then you can see masseter spasm. So this is seen after giving scoline. And when you see masseter spasm after giving scoline, then always check the dose of scoline given. Check the dose of scoline given. What is normal dose of scoline? 1.5 to 2 mg per kg. 1.5 to 2 mg per kg. So either you have given a inadequate dose or you have given an adequate dose. Only two conditions can happen. Inadequate dose means you have given less than normal dose. So this masseter spasm can simply be because of the tonic contraction of masseter muscles. See, masseter has highest number of NMJs in the body. If you have given a less dose, the tonic contraction phase will prolong and the muscle relaxation phase will not happen. So partial action, so it will keep on contracting, but the relaxation will not happen. In this condition, the next step would be to supplement more relaxant. In this condition, the next step would be to supplement more relaxant. While A rare condition is when you have given an adequate dose of choline and yet you see masseter spasm, and this is an ominous sign. Ominous sign means something bad is about to happen. Ominous sign of malignant hyperthermia. So this is premonitory sign of malignant hyperthermia. The next step would be to go for trigger-free anesthesia. Next step would be to go for trigger-free anesthesia. Trigger-free anesthesia, right? So that is why remembering the dose of choline is so important, because in the exam we have got two questions. One where a 5-year-old child was taken up for surgery and given 0.5 mg per kg choline. Immediately after giving choline, the mouth opening of child was severely restricted. What is the next step that you will do? Supplement more choline. Next question was, one 5-year-old child taken up for surgery was given 2 mg per kg choline. Immediately after giving choline, the mouth opening became restricted. The mouth was not opening. What is the next step you will do? Give atracurium. Just by changing that 0.5 to 2, your answer will change. Okay. Next is nerve injuries under anesthesia, and this is more of an enumeration thing. So just write this thing down. Most common nerve injured under anesthesia is ulnar nerve. Ulnar nerve. Most common lower limb injured nerve is common peroneal nerve. In ophthalmic complications, most common ophthalmic complication under anesthesia, corneal abrasion. Most common cause of post-operative vision loss is ischemic optic neuropathy. Ischemic optic neuropathy, ION. Okay, now let's see a unique thing. Cause of post-operative vision loss. It is not a common complication. It's a rare complication under anesthesia, and the entity that is described here is ischemic optic neuropathy, which is seen with prone position surgeries. Example, spine surgery or neurosurgery. In prone position, sometimes there is pressure on the eye because the patient is prone, so the eye is under pressure. And if the surgery is associated with lot of blood loss, then there is a possibility that severe decrease in blood supply to optic nerve happens, which can lead to transient, sometimes even permanent blindness in post-operative period. So prone position surgeries, specifically spine surgeries. Okay. ION, ischemic optic neuropathy. Ischemic optic neuropathy. Okay. Next we'll go to another very important complication associated with anesthesia, that is air embolism. Very important complication associated with anesthesia, that is air embolism. What do you mean by air embolism? Air in vasculature. Air in vasculature. How many types of vessels do you know? 2. Artery and vein. Venous air embolism is most common intraoperative air embolism. Most common intraoperative air embolism. Venous air embolism is most common intraoperative air embolism. Most common intraoperative air embolism. Yes, all the complications can be prevented, Vinay. If you're talking about POVL, we take care that the eyes do not get compressed in the pillow. We make sure that we maintain the mean arterial pressure above 60 so that the critical perfusion does not get affected. So it is definitely preventable. None of my cases, spine cases, have ever gone into post-operative vision loss. So air embolism is air in vasculature. It can be arterial or venous. Arterial or venous. Venous air embolism is most common intraoperative air embolism. Most common intraoperative air embolism. Let's look at risk factors for development of VAE. The most important risk factor is posterior fossa surgery in sitting position. Most important factor is posterior fossa surgery in sitting position. Second is head and neck surgeries. And third is central venous cannulation. Central venous cannulation. Posterior fossa surgery in sitting position, head and neck surgeries, and central venous cannulation. Okay, now let's try and understand venous air embolism. It is something that is very conceptual. Tell me, normally, do you have air in your vessels? Do you have air in your circulatory system? Yes or no? Normally, do you have air in your circulatory system? Yes or no? Normally, do you have air in your circulatory system? Yes or no? No. Why? What is the reason why there is no air in your circulatory system? Why is there no air in your circulatory system? Is there a reason or is it just by default? Yes, Ipsita, there is air in your circulatory system? Yeah, I'm not talking about dissolved. If it is dissolved, then it is not air, right? I'm talking about bubbles. I'm talking about bubbles. Back pressure of fluid on what? Back pressure of fluid on what? Very simple. Why does your circulatory system does not contain air bubbles? Because it's an intact system. It's completely intact. Is there any opening to the outside world? It's a completely intact system. Am I right? So if at all you have to cause air embolism, then what is the first thing that you need to do? You need to create a breach in the vessel. Then only air can get entrapped, right? You need to create breach in the vessel. So what if I take your radial artery and cut it? What if I take your radial artery and I cut it? Will you die of embolism? Will you die of embolism? No, you will die of bleeding. Why? Because the pressure inside the vessel is higher than the outside pressure. So if you really want air embolism to happen, then what are the two things that you need? One, you need a breach in the vessel. Second is you need a subatmospheric pressure in that vessel. Then only it will entrap air from outside. Based on this is the pathophysiology of venous air embolism. What are the two things that you need for air embolism? One is a breach in the vessel, and second is subatmospheric pressure in the vessel. Subatmospheric pressure in the vessel. Now, when this is how a sitting craniotomy is done, you can see this is sitting position under anesthesia for surgery. The surgery is this posterior fossa surgery. It is usually done for posterior fossa tumors or aneurysms. So you position the patient in sitting position and then you do a craniotomy. So the moment you do a craniotomy, occipital craniotomy, what gets exposed? Dural venous sinuses. Dural venous sinuses which are open. So you got your breach in the vessel. And as compared to the right heart, which forms the pressure for the venous, central venous pressure, what would be the pressure in the vessel in the head? It would be less. So sitting position is responsible for subatmospheric pressure in the vessel. Subatmospheric pressure in the vessel. A combination of these two will cause air embolism. Combination of these two will cause air embolism. Air will get entrapped. Now this air has been entrapped in the peripheral dural vein, and from there it will travel towards the heart, because venous system drains in the heart. Which side of the heart? Right side of the heart. So this air will travel all the way to right atrium. From right atrium it will go to right ventricle. From right ventricle it will go to a pulmonary artery. And now what is so unique about pulmonary artery is pulmonary artery keeps on dividing and becomes smaller and smaller and smaller and smaller, right? So at one point of time the air bubble will become bigger than the vessel caliber, so it will block the pulmonary artery. It will block the pulmonary artery. At this point of time a large dead space will be created, part of the lung that is ventilated but not perfused, and because of the block in the pulmonary artery, what will happen? Decreased in left ventricular preload. Now blood will not go to the left side of the heart, left ventricular preload. This will decrease cardiac output and can cause cardiovascular collapse. So a small amount of air that gets embolized in a peripheral dural vein can lead to cardiovascular collapse. This is the pathophysiology of venous air embolism. That is why it is such a dreaded complication. Suppose the patient has a patent foramen ovale, PFO. This air bubble can move from RA to LA and from LA to LV, and from LV it can go into systemic circulation. What type of embolism is this? An embolus that is initiated in the right side of the system goes on to the systemic circulation. This is called as paradoxical air embolism. This is called as paradoxical air embolism. This is called as paradoxical air embolism. Subatmospheric pressure means less than the atmospheric pressure. That means there is a suction pressure in the vessel. See, if the pressure inside the vessel is higher than the outside pressure, this outside pressure is the atmospheric pressure. है ना? So if the pressure inside the vessel is higher than the outside pressure, you will call it supraatmospheric pressure. So that will push the blood out. But if the pressure in the vessel is less than the outside pressure, that is the atmospheric pressure, so subatmospheric pressure, so it will pull the air in. Right? So this is the pathophysiology of venous air embolism, and based on this pathophysiology we have the clinical manifestations or clinical features. So the clinical features can be very easily understood if you trace the journey of this air bubble from the site of entry till the last moment. So when it gets entered in the dural vein, will it cause any problem to the patient? No, because the vessel keeps on getting bigger and bigger as it approaches the heart, right? As it approaches the heart. But the moment it reaches the heart, will it cause any problems there? Yes, heart is not used to having air around it. And if it is not used to having air around it and it gets air, what will it show? It will show irritation. And how does heart show irritation? So there will be arrhythmias. Premature ventricular contractions. PVCs are the most common arrhythmias seen with venous air embolism. Then this air bubble will move ahead and go and block a pulmonary artery. So increased pulmonary artery pressure. The moment it blocks a pulmonary artery, it will create a large dead space. So it will cause hypoxia and sudden hypocapnia. It will cause hypoxia and sudden hypocapnia, right? Because it will create a large dead space. So suddenly the EtCO2 will drop. Suddenly the EtCO2 will drop. Sitting position doesn't cause subatmospheric pressures. In sitting position, in an open dural vein which is present in the head as compared to the central venous pressure, the pressure would be lower. As you go up, the pressure falls or rises. In a mountain, the air pressure is less or more than at sea level. It is less. So similarly, as compared to the central venous pressure, a pressure in a neck vein or a head vein in sitting position would be lower because it is at a higher level. So that is causing the pressure in the vessel which is there in the head which is open to be less than the outside pressure. Now at the same time the CO2 is not getting exchanged, so it is not coming out, but doesn't mean it is not getting produced. So what you will get is hypercarbia. That means increased PaCO2. Increased PaCO2. So the gap between EtCO2 and PaCO2 will rise and you will get hypotension, tachycardia, and a murmur called as mill-wheel murmur. A murmur called as mill-wheel murmur. That is a continuous precordial murmur because of the gushing of blood around the air bubble. All right. Next, come to diagnosis. Again, you need a high degree of suspicion that a particular position during surgery will cause venous air embolism. So you need to keep certain diagnostic modalities in place. So if somebody asks you what is the most sensitive invasive modality that can detect venous air embolism intraoperatively, the answer would be transesophageal echocardiography, TEE, because it will directly look at the heart and see if there are any air bubbles. Transesophageal echocardiography, TEE. But it is not always feasible to put a TEE probe. So most sensitive non-invasive modality would be precordial Doppler. Precordial Doppler. Most sensitive non-invasive modality is precordial Doppler. Precordial Doppler. Then sudden and abrupt fall of EtCO2. Sudden and abrupt fall of EtCO2. Sudden and abrupt fall of EtCO2. Then hemodynamic parameters. Hemodynamic changes. All these can help in the diagnosis of venous air embolism, but most questions are from these first three modalities. Most questions are from these first three modalities. Okay. Next is treatment. So again, treatment will involve two parts. Treatment will involve two parts. First is prevention of further entrapment of air. Prevention of further entrapment of air. बेटा और किस चीज का ना दीपक, टॉपिक तो वही चल रहा है, एयर एम्बोलिज्म. सो डायग्नोसिस भी एयर एम्बोलिज्म का ही होगा ना. टॉपिक कहाँ चेंज किया हमने? वी आर स्टिल डिस्कसिंग एयर एम्बोलिज्म. प्रिवेंशन ऑफ फर्दर एंट्रैपमेंट ऑफ एयर एंड देन ट्रीटमेंट ऑफ ऑलरेडी एंट्रैप्ड एयर. Treatment of already entrapped air. How will you prevent further entrapment of air? See, in this, again, in a complication, it's always a teamwork. So the complication is happening because there is an open dural vein that is causing air to get sucked in. That is happening at the surgeon's end. So the moment I diagnose a venous air embolism, I will immediately shout embolism, embolism, embolism. So immediately inform the surgeon. And in anticipation, in such a cases, he will always keep a saline filled syringe filled with him, and he will start irrigating the area, flood the field. So what will happen? There was an open vein, open to air, that was entrapping air. The moment he creates a saline filled field over the vein, the air entrapment will stop, and in the meantime he will identify the vessel and will ligate it. So the first thing is to inform the surgeon and flood the field. Second thing I would do is bilateral jugular compression. So what will happen? The venous return from the neck veins will stop and the neck venous pressure will rise. So instead of air getting entrapped in, the blood will go out. And finally, I can lower the head end of the patient. Lower the head end of the patient. Although this is not preferable because it takes a lot of effort to give a sitting position during the surgery. So this is usually reserved for condition where cardiac arrest has happened because of massive pulmonary embolism and now we need to do CPR. Otherwise, we try not to change the position of the patient. Okay. This is the first thing that we will do, that is to prevent the further entrapment of air. ठीक? What is the next thing that we will do? We'll treat already entrapped air. So we will aspirate the air through a CVC. Usually we do put a central venous catheter when there is a sitting craniotomy. So the moment we diagnose venous air embolism, we'll start aspirating the central venous catheter. There's a possibility that the air bubble in RA will get sucked in and thereby decreasing the air that goes into the pulmonary circulation. Second is to stop nitrous oxide and give 100% oxygen. Stop nitrous oxide and give 100% oxygen, and then vasopressors and fluids as symptomatic management. Vasopressors and fluids as symptomatic management. Just write this down. I'm coming in 2 minutes. Okay, everybody done with this? Let's start with two airway complications that are very commonly seen under anesthesia, that is bronchospasm and laryngospasm. Okay, they are very easy. Let's quickly finish them off. Bronchospasm is reflex bronchoconstriction. This leads to difficulty in ventilation. Difficulty in ventilation. Something that is seen in asthma. Something that is seen in asthma. Reflex bronchoconstriction. So whenever you think of bronchospasm, always think of asthma. Laryngospasm, on another hand, is reflex glottic closure. You can see in the image, this is normal. This is when laryngospasm has happened. See, reflex glottic closure. Reflex glottic closure. Reflex glottic closure. This is due to stimulation of superior laryngeal nerve. Superior laryngeal nerve. This is due to stimulation of superior laryngeal nerve. This leads to inability to ventilate. This leads to inability to ventilate. This leads to inability to ventilate. Reflex glottic closure. They both are trigger based events. So whenever you think of laryngospasm, think of foreign body obstruction. Whatever you see in foreign body obstruction is what you will see with laryngospasm. So this is just a cue to you how to remember. Think of asthma when there is a question of bronchospasm. Think of foreign body obstruction when there is a question of laryngospasm. Both are trigger based event and they have a common trigger in something to do with the light planes of anesthesia. So most common bronchospasm occurs due to stimulation in light planes of anesthesia. Stimulation in light planes of anesthesia or certain histamine releasing drugs like thiopentone, atracurium, scoline, mivacurium, morphine, meperidine. These are drugs that are used in anesthesia that release histamine. All of these can cause bronchospasm. Pungent agents like desflurane. Laryngospasm is unique. It happens after extubation. So if you extubate the patient in a lighter plane, then you most common get light plane, means something that is not complete general anesthesia, complete deep plane of anesthesia, nor completely awake, is a lighter plane, something in between. So when the patient is coming out of the effect of anesthesia, he is in the deep anesthesia, then he comes in the lighter planes and then he becomes awake. So most of the time in lighter planes, the reflexes, they behave abnormally, and that is why both the airway complications are common to lighter planes of anesthesia. Extubation in lighter plane. Airway secretions. And itself, the cuff, the endotracheal tube, not cuff, endotracheal tube itself can serve as a trigger for, Laryngospasm. Alright. So it's a trigger based event. How do you diagnose it? Diagnosis is actually very easy. How do you diagnose asthma? Clinically, you see wheeze. So intraoperatively, the patient will suddenly have wheeze. Also, there will be increased peak airway pressures. Why? Because there is bronchoconstriction. So now more pressure is required to ventilate the patient. So on the ventilator, there will be increased peak airway pressures. And obviously you will see a shark fin appearance on capnogram. You see a shark fin appearance on capnogram. You will see a shark fin appearance on capnogram. Laryngospasm, just like how you diagnose foreign body obstruction, the patient will present with stridor, absent breath sounds, stridor, absent breath sounds, because the larynx is closed. So it's just like upper airway obstruction. How would you treat it? Since lighter plane of anesthesia is a common, stridor means it's a typical sound that comes when the patient is not able to breathe. That is stridor, noisy respiration. That is typically seen in the upper airway obstruction, foreign body obstruction. Not able to breathe is stridor. Since both of these are something to do with the lighter planes of anesthesia, therefore the first step in the management would be to deepen the plane of anesthesia using either propofol or sevoflurane. Deepen the plane of anesthesia using propofol or sevoflurane. You can also use IV lignocaine 1 to 1.5 mg per kg, that helps to prevent reflex spasms. Then in bronchospasm, you can try bronchodilators like salbutamol. You can give ketamine, that will not only cause deepening the plane of anesthesia but also bronchodilation, and you can use adrenaline for bronchodilation. In laryngospasm, if these two things doesn't prevent, then most of the time gentle positive pressure ventilation with bag and mask usually breaks the spasm. Physically breaking the spasm. So the moment you diagnose that there's a laryngospasm, you will hold the mask of the face mask on the face and you will give a gentle positive pressure ventilation using the bag. So that gush of air that is going towards the larynx will break the spasm. If that doesn't work, then what will you do? Give IV scoline and reintubate. IV scoline and reintubate. IV scoline and reintubate. So these are the two very common airway complications associated with anesthesia. Very common airway complications associated with anesthesia. airway complications associated with anesthesia. All right. Moving on to intraoperative anaphylaxis, and this intraoperative anaphylaxis, the order has been changed in the 9th edition of Miller. So this is the updated order. If at all you get an old question where I have described some other order, then don't get confused. This is the final order. Antibiotics are again now the most common cause of intraoperative anaphylaxis, followed by muscle relaxants, followed by chlorhexidine. Most common cause of intraoperative air embolism is antibiotics, muscle relaxants, and chlorhexidine. Okay, Pandian, you wanted this slide, diagnosis and treatment. Okay, I'll put it for a minute, finish it off, diagnosis and then treatment. Okay, trigger वाला भी चाहिए. Okay, putting trigger. Okay, done. This is treatment slide. All right. Okay. Chalo. Moving on to the last complication, and this is something that we discuss a lot. We talk about it a lot. Let's devour this topic. Mendelssohn syndrome, also called as aspiration pneumonitis. Aspiration pneumonitis. Aspiration pneumonitis. This is aspiration of gastric contents in the lungs. Aspiration of gastric contents in the lungs. The traditional risk factors that have been defined by Mendelssohn are gastric volume and gastric pH. Gastric volume and gastric pH. A gastric volume of more than 25 ml for an adult or 0.4 ml per kg for a pediatric patient is considered to be a risk factor for Mendelssohn syndrome. Similarly, a low gastric pH of less than 2.5, that means acidic contents, would be considered as a risk factor. Low gastric pH of less than 2.5 is considered as a risk factor. So high gastric volume and low gastric pH are the risk factors for Mendelssohn syndrome, which is aspiration pneumonitis. What is it? It is basically a chemical aspiration. So the gastric contents, they get regurgitated into the lungs, and when it reaches the lungs, they will initiate a intense inflammatory response. They will initiate a intense inflammatory response. They will, initiate a intense inflammatory response. That is why the clinical features are basically features that are seen in ARDS, like tachypnea, bronchospasm, wheeze, cyanosis, respiratory insufficiency. This can lead to acute pulmonary edema, which can then lead to right heart failure. Which can then lead to right heart failure. Yes, of course. It's ml per kg, right? So it would be for babies. These are the clinical features of Mendelssohn syndrome. Clinical features of Mendelssohn syndrome. Mendelssohn syndrome. Mendelssohn syndrome. That is aspiration pneumonitis. You're asking me whether it is a too small volume, or you're telling me that it's a too small volume. See, it's a risk factor. Any volume higher than 25 ml will keep the patient at a risk of aspiration if there is regurgitation in the event of an unconscious patient. You're getting my point? Higher the volume of the stomach, more are the chances of getting aspiration. So when I say more than 25 ml, that means anything above 25 ml will put a patient at a higher risk of aspiration. More and more the volume, higher the risk of aspiration. Okay. Management. Now management is the most important part. The most important part of management is prevention of aspiration. That is what we always target and we try to do. We try to prevent the development of aspiration. So obviously the risk factor is gastric volume. So what will we try to do? We'll try to decrease gastric volume. What is the most effective way of decreasing gastric volume? Yes, not to take anything from above. So fasting. Pre-operative fasting. But how much to fast? Overnight, 12 hour, 10 hour, according to whims and fancies of the intern? No. It is based on the type of food that the patient has consumed. So let's look at ASA fasting guidelines. ASA fasting guidelines. It depends on the type of food. So if it is clear liquid, 2 hours. Breast milk, 4 hours. Infant formula feed, non-human milk or light meal, 6 hours. Heavy meal that contains fat and meat, 8 hours. Heavy meal that contains fat and meat, 8 hours. So the more you will eat, the more difficult food to digest that you are eating, the more you will have to wait for it to be cleared from the stomach. So 2, 4, 6, 8. So it entirely depends on the type of food that the patient is taking. Type of food that the patient is taking. Type of food that the patient is taking. Okay, so the first thing is fasting. These are standard ASA fasting guidelines. Anybody who tells you anything apart from that, new guideline, this, that, all of this is rubbish. These are the standard ASA fasting guidelines which have been published in a textbook. Textbook reference is what we follow as our standard reference. Okay, textbook reference is what we follow as our standard reference. Next is, so one, that you don't take from above. Second is prokinetic agents like metoclopramide. Prokinetic agents like metoclopramide. Second is increasing gastric pH. Increasing gastric pH. That means making the contents alkaline. So you can do that by taking drugs like PPIs, H2 blockers, but they will decrease acid secretion. What about the acid that is already present? So for that you can use antacids, and we use non-particulate antacid. We use non-particulate antacid in the form of sodium citrate. This will neutralize the acid but will not form solids. Otherwise acid and base, they combine and form salt. So if you use normal antacids like Gelusil, Digene, then they will form curd like thing, salt. And finally, good anesthetic technique. Just right in front of it, RSI, good anesthetic technique, RSI. We'll discuss it in 2 minutes. Let's first discuss the management of Mendelssohn syndrome. If it happens, then what is that you will do? Management of Mendelssohn syndrome. Management of Mendelssohn syndrome. Management of Mendelssohn syndrome. So treatment, the first thing that you are supposed to do is you have to lower the head end of the patient. Once you lower so the aspiration is happening in front of you, that means regurgitation is happening. So what you do is you lower the head end of the patient so that there is gravity dependent pooling of secretion. Then you will immediately suction the secretions in the oral cavity and intubate and ventilate with 100% oxygen. If you have the facility available, then you will do a check bronchoscopy. Obviously, you will increase gastric pH, no? You will not decrease gastric pH. Have I written decrease? No. Increase gastric pH. Obviously. Acidic contents are at increased risk of aspiration. I just told you. So you obviously make it alkaline, no? Increase pH. Why would you decrease pH? And most importantly, can you decrease the pH of anything like gastric contents and all? Is there a acidifying agent that is available in the market? No, no. So always alkalizing agent. You do a check bronchoscopy if it is available and see for any particles that can be removed, and then follow intensive care management protocol based on ARDS. ARDS based protocol. ARDS based protocol. So whatever you do in management of ARDS is what you will do here. One thing that I would like to point out is that there is no role of antibiotics and steroids in the management of No role of antibiotics and steroids in the management of Mendelssohn syndrome. No role of antibiotics and steroids in the management of Mendelssohn syndrome. No role of antibiotics and steroids in the management of Mendelssohn syndrome. One would think that since it's an inflammatory condition, so steroids should be useful, and antibiotics in India, as we know, we can give it to any patient, but there is no role of antibiotics and steroids. No, non-particulate antacids will simply neutralize the base, but they will not combine and form salt. Non-particulate, as the name is only telling you, there are no particles in it. So therefore they will neutralize the acid, but they will not form a salt. Yes, acute respiratory distress syndrome, ARDS. Which last slide that you want? Say, don't say last slide, no. Okay, I think management slide, prevention slide. Okay, guys, you have to step up because I want to finish by 9. We have local anesthetics and regional anesthesia, whole of which is remaining, and then CPR. CPR also takes at least 35-40 minutes, and local anesthetics and regional anesthesia will also take somewhere around 2.5 hours. So we really need to step up our game now in writing. Okay, we need to just try and write fast because I'm talking and writing together. So if I can write, you can write at my same speed, है ना? कर सकते हैं? Is it possible? How's the Josh? You guys are tired? What is happening? Talk to me. This is first class for how many of you? First ever class for how many of you? Very good. That's how it has to be. अनुराग यार तू बढ़िया आदमी है. Always best more than 100. Very good. See, थोड़ा सा पंप अप करो. शाम का टाइम है. The post lunch slumber has gone, है ना? And now we can probably put some water on our face, sit tight, and in the next 3 hours we'll try to cover up everything that is remaining, है ना? We have done very good till now. We have understood concepts. We have written notes. You might be very proud if you look at your notes and see that you have almost written what, 60 pages? Must be 60 pages. You started with absolutely no knowledge of anesthesia, the conduct of anesthesia, and now you have covered almost 80% of anesthesia in terms of management of general anesthesia. Right? Now, what about this good anesthetic technique, RSI? So, in patients where you cannot do fasting, there you modify your technique of anesthesia to decrease the risk of aspiration. So what is rapid sequence induction or intubation? It can be used interchangeably, called as RSI, is a method of achieving rapid control of airway while minimizing the risk of regurgitation and aspiration of gastric contents. It is a method of rapid control of airway while minimizing the risk of regurgitation and aspiration of gastric contents. This is RSI. This is RSI, rapid sequence induction or intubation. It is done for patients with emergency surgery, full stomach, pregnancy, where you cannot think of keeping them fasting to decrease the gastric volume. So what you do, you change your technique of giving general anesthesia. There are 4 P's of RSI. 4 P's of RSI, and we have already done everything. It's just a different way of doing the same thing. So the first P is pre-oxygenation. First P is pre-oxygenation. What is the purpose of pre-oxygenation? Increasing in safe apnea time. Increasing safe apnea time. The first P is pre-oxygenation. It increases safe apnea time. Doesn't prevent the risk of aspiration, just increases safe apnea time. Second is paralysis. So normally we give a titrated induction and muscle relaxation, right? Titrated. So slowly, desired, doing only what is desired. Here you give a fixed dose of induction agent, usually thiopentone 200 milligram plus muscle relaxant, that is scoline 100 milligram simultaneously. without bag and mask ventilation. So you don't do bag and mask ventilation in between. Why? Because bag and mask ventilation anyway increases the risk of aspiration by gastric inflation, right? So what you do here is you don't wait, you give both the drugs simultaneously without interposed bag and mask ventilation. And then third is the most important part, third P is the most important part, that is cricoid pressure or Sellick's maneuver, which is posterior pressure on cricoid cartilage and we know what is unique about cricoid cartilage. It is a complete ring as compared to other tracheal rings. And what is present posterior to trachea? Esophagus. So it blocks the upper end of esophagus. And this is the step that prevents aspiration. This is the step that prevents aspiration. And then final P is placement of cuffed endotracheal tube. Cuffed endotracheal tube. Placement of cuffed endotracheal tube. Cuffed endotracheal tube. Okay. So this is how you modify your technique of giving anesthesia to prevent the risk of aspiration. You might modify the technique of giving anesthesia to prevent the risk of aspiration. To prevent the risk of aspiration. Modify the technique of giving anesthesia to prevent the risk of aspiration. Okay, this is RSI, rapid sequence induction or intubation, but this is fixed. Everything in RSI is fixed. Fixed dose of drug, fixed way of giving it. But now what we do is, depending on the clinical condition of the patient, we can modify this technique. So should I go to modified RSI? Should I go to modified RSI? Full stomach patients, patients who have had full meal, full stomach patients, right? So what is modified? See, this is Sellick's maneuver or cricoid pressure. You can see this is the cricoid cartilage. You put a posterior pressure with two finger and it will block the upper end of esophagus. It will block the upper end of esophagus. It will block the upper end of esophagus. You know? Now what we do in modified RSI is we can change certain things according to the clinical condition of the patient. Like pre-oxygenation is a must, it is done in every patient. But for paralysis, you can use any induction agent depending on the type of patient. Cardiac hai to etomidate, propofol, ketamine you can use for shock patient. Muscle relaxant you can use rocuronium instead of scoline. Pressure you will still maintain cricoid pressure, and placement may you will still use cuffed endotracheal tube. But you can change the drugs that you are giving depending on the clinical condition of the patient. This modified RSI is also called as drug assisted intubation, DAI. Drug assisted intubation, DAI. Drug assisted intubation. And when emergency medicine guys will teach you RSI, they'll say that RSI is out, we don't practice it anymore. Now we practice drug assisted intubation, which is essentially the same as modified RSI, All right. So this finishes our discussion of general anesthesia in total. The conduct of general anesthesia, technical details about airway management, anesthesia machine, breathing circuits, and the complications associated with anesthesia. This covers our almost 80% of what we wanted to know under anesthesia, general anesthesia. Now we'll move on to the next part of the discussion, that is local anesthetics and regional anesthesia. So if you guys are okay, I'll give you 2-3 minutes to review and see if you want me to go to any page, tell anything. Otherwise, we'll start with local anesthetics and regional anesthesia. Rocuronium. There is only one muscle relaxant and amica that can replace choline for intubation, that is rocuronium. Yes, of course, it is the same thing. It's just modified RSI mein you can use different drugs for induction and muscle relaxation. Rest all the things remain the same. Rest all the things remain the same. Same curved endotracheal tube. You guys want a break? We can take a 10-minute break, but not more than that. Do you guys want a break? Okay, let's take a 10-minute break. Strictly 10-minute. Okay, so break till 6:10 p.m. and we'll come back, and then there'll be no breaks till 9 o'clock. Okay? कोई बात नहीं. Let's take a break for 10 minutes. Not a problem. Perfect. So everybody okay? Refreshed? Had a cup of tea? All right. So let's start with local anesthetic, and it is very easy to understand local anesthetics. You might also be remembering a local anesthetic from your pharmacology days. So what I'm going to do is I'm going to summarize local anesthetic, and most importantly will emphasize on the regional anesthesia part. Okay. So local anesthetic, as the name is suggesting, acts on the site of administration and blocks the transmission of nerve impulse from a nociceptor towards spinal cord. Okay, from a nociceptor, that is a pain receptor, towards spinal cord. So wherever you inject the local anesthetic, it will block the transmission of nerve impulse. And the most important question that they ask us in local anesthetic is its mechanism of action. So any agent that is a sodium channel blocker will be called a local anesthetic. Any agent. Sodium channels are the mainstay of transmission of nerve impulse through the nerve membrane, right? So if you block the sodium channels, then the nerve impulse will be severed, and that particular sensation will not be perceived at spinal cord and brain. So essentially all local anesthetics are sodium channel blockers, and all sodium channel blockers are local anesthetic. That means any other drug that has a sodium channel blocking property will also have a local anesthetic property. The site of action is intracellular surface of sodium channel. Intracellular surface of sodium channel, and every sodium channel has an extracellular surface and an intracellular surface. Intracellular surface has a gate called as inactivation gate, and the site of action is this inactivation gate of the sodium channel. Inactivation gate of sodium channel. Inactivation gate of sodium channel. Inactivation gate of sodium channel. the form that is required for onset of action. Now the site is intracellular surface of sodium channel. So the drug has to go inside the cell and then act. So the form that is required for onset of action is the unionized form. Unionized form. Because ionized form cannot cross the plasma membrane. So unionized form is the form required for onset of action, but after it reaches inside, again splits into ionic form, and it is the ionic or rather cationic form that is required. That is the active form of local anesthetic. Active form of local anesthetic. And you can see that local anesthetic molecule is blocking only sodium channels. Sodium channels are involved in the transmission of nerve impulse. Is there anything related to the sodium potassium ATPase pump here? No, that is an active channel that causes the inside of a cell negative as compared to outside. That causes the resting membrane potential. That is why use of local anesthetic does not affect the RMP of the nerve. Use of local anesthetic does not affect the RMP of the nerve, resting membrane potential of the nerve. And all these 5 points are extremely important. Last year FMG question, FMG 2021 gave a question on mechanism of action of local anesthetic, and 4 options out of that question were from 5 of these statements, right? So it is one of the most important things that you have to remember, that the mechanism of action is sodium channel blocker, site is intracellular surface of sodium channel called as inactivation gate, form required for onset of action is the unionized form of local anesthetic, while the active form of local anesthetic is the cationic form, and use of local anesthetic does not affect the resting membrane potential of the nerve. Use of local anesthetic does not affect the resting membrane potential of the nerve. Resting membrane potential of the nerve. Resting membrane potential of the nerve. Alright, this is mechanism of action of local anesthetic. Now let me ask you a question. How many types of nerve fibers do you know of? How many types of nerve fibers do you know of? You must have remembered the physiology class where they teach you different types of nerve fibers. This is classified based on the myelination and the thickness of the fiber. They are divided into 3 categories, A, B and C, A being thickest and most myelinated and C being thinnest and most unmyelinated, right? So tell me from your logic that between A, B and C, which nerve fiber should be most sensitive to the action of local anesthetic? Thick and insulated nerve fibers or thin or bare nerve fibers? You have the mechanism of action in front of you. Tell me between different types of nerve fibers, which nerve fiber should be most easily blocked, thick and insulated or thin and bare? Thin and bare? Absolutely correct. So if you have to write the order of individual nerve fibers to the sensitivity of local anesthetic, the answer should be C, B and A, isn't it? Yes or no? C, B and A? Yes or no? Yes or no? Yes. And this is what we always were being taught and we also thought. And let's come to the next topic, susceptibility of nerve fibers to local anesthetic, and write the order A, B and C. Specifically A, gamma, delta, alpha is equal to beta, B and C. Gamma, delta, alpha is equal to beta, B and C. A, B and C. Gamma, delta, alpha is equal to beta, B and C. So you will say, sir, how is this happening? So see, what happened is that what we thought is what we presumed, but at the end of the day, everything has to be proved by a experiment. So they took out rat's sciatic nerve and they split the fibers, all the 6 fibers, and then they poured different concentration of local anesthetic to see which gets blocked first. And to their surprise, read the last line. This is from Miller's textbook of anesthesia. Last line. The widespread notion that the local anesthetic blocks the smallest fibers first or most is thus clearly wrong. So even they thought that, okay, we'll get CBA, but what you got was A, gamma, delta, alpha, beta, B and C, and this is the biggest controversy that was created in anesthesia. Many people will tell you that the order has changed, some recent order has come and it will be BCA or CBA or ACB. Nothing. Now it has been proven via a experiment that the final order is A, gamma, delta, alpha, beta, B and C. Gamma, delta, alpha, beta, B and C. Gamma, delta, alpha, beta, B and C, right? So this question should never come to your mind, sir. What is the final order? Sir, can you please tell once again? Some coaching institute, some mock test, some other teacher has said it is BCA. Is it true? Nothing. Anybody says anything to you, just don't accept it unless until I change it, and it is not going to change because it has been proven now. So A, gamma, delta, alpha, beta, B and C. Let's come to the pharmacology of local anesthetics. And pharmacology of local anesthetic is based on the chemical structure, and every local anesthetic molecule has a tertiary amine and a aromatic benzene ring. It has a tertiary amine and an aromatic benzene ring, and we are not concerned with either of the two. What we are concerned with is the intermediate chain that binds the two. Intermediate chain that binds the two. Intermediate chain that binds the two. Based on the structure of this intermediate chain, you can divide local anesthetics into two types: amino esters and aminoamides. And this is world's easiest classification. This is world's easiest classification. All La with one I in spelling are amino esters, while all La with two I in their spelling are aminoamides. Example: procane, chloroprocane. Examples here: lignocane, bupivacaine. Right? So all local anesthetics with one I in their spelling are amino esters, while all local anesthetics with two I in their spelling are aminoamides. Let's look at some general properties. Duration of action. So amino esters have a short duration of action, while aminoamides have a longer duration of action. Metabolism. Metabolism of amino esters is by plasma cholinesterase, while aminoamides is by liver. There is a notable exception to this rule. An amino ester by the name cocaine is metabolized by liver, and aminoamide by the name articane is metabolized by plasma cholinesterase. Metabolized by plasma cholinesterase. Let's look at the allergic potential. Allergic potential of amino esters is high, while aminoamides is low. Allergic potential of amino esters is high, while aminoamides is low. These are some general points about amino esters and aminoamides. Amino esters and aminoamides. Amino esters and aminoamides. Done? Done. Let's look at the pharmacokinetic properties of local anesthetic, and let's start with the potency. Let's start with potency. So in local anesthetic, potency is a function of their lipid solubility. So more the lipid solubility, more will be the duration of action, more will be the potency. Obviously, if you want to compare between different local anesthetics, क्या हुआ एक्सेप्शन में क्या प्रॉब्लम है? कोकेन इज एन एमिनो ईस्टर वाली कैटेगरी में है 1I विच इज मेटाबोलाइज्ड बाय लिवर. एक्सेप्शन है ना. आर्टिकेन इज एन एमिनो अमाइड विच इज मेटाबोलाइज्ड बाय प्लाज्मा कोलिनेस्टरेज. So when you talk about lipid solubility, you cannot always compare the solubility with plasma membrane because it is difficult to find plasma membrane for experiments. So you take a solution which has a similar lipid profile, lipid content as compared to plasma membrane, and that solution is called as octanol. So you compare the solubility of local anesthetic in octanol solution, therefore can also say that it is proportional to octanol solubility. And this also decides the duration of action, and based on the duration of action you can divide local anesthetics into long, intermediate and short acting local anesthetics. Long, intermediate and short acting local anesthetics. Long are dibucaine, bupivacaine, levobupivacaine. Intermediate are lignocaine, mepivacaine, prilocaine. Short acting are procaine, chloroprocaine. Short acting are procaine, chloroprocaine. Alright. Now whenever you get a question like this, the question always comes which is the longest. So dibucaine is longest, procaine is shortest. Longest and shortest. Dibucaine is longest, procaine is shortest. While chloroprocaine is fastest, procaine is shortest, and dibucaine is longest. Alright. Next is onset of action. Second pharmacokinetic property is onset of action. And for onset of action, there are multiple factors that are at work. We'll consider two factors. One is the pKa of the local anesthetic, and another is the concentration that is used. Concentration used. So pKa is the pH at which 50% of drug is unionized. It is the pH at which 50% of drug is unionized. So what happens to the other 50%? Obviously it is ionized. But for the onset of action, what is important? The unionized fraction of the drug. So let's consider this fact that any drug, any LA with its pKa near physiological pH will be faster in onset. Why? Because if it is near physiological pH, then a higher fraction of that drug would be in unionized form, and we know it is the unionized form of the drug that is responsible for onset of action, so obviously faster in onset. Let's look at an example. Lignocaine with a pKa of 7.8 is faster than bupivacaine with a pKa of 8.1, lignocaine with a pKa of 7.8 is faster in onset as compared to bupivacaine with a pKa of 8.1, right? But then again there is an exception to this rule. What is the exception? The exception is of the drug chloroprocaine. Now chloroprocaine has highest pKa. How much? 9.1, and still it is fastest in onset. It has highest pKa, still it is fastest in onset. So you will say, sir, just now you told us a factor pKa, and now you are telling that the fastest onset agent is actually a exception to this factor. Then how is it possible? Because there are multiple factors involved. Chloroprocaine as a local anesthetic is a low potency local anesthetic. So when it is low potency, it is used in higher concentrations, and higher concentrations means more number of molecules. More number of molecules means faster in onset. So it's a complex interplay. One factor is not the only factor that is responsible, right? That is why I told you there are multiple factors, pK and concentration, both play an important role. Okay. So just try and understand this concept of pKa and concentration in deciding the onset of action of local anesthetic. So now we have got two pharmacokinetic property. One is the onset of action, another is the duration of action. So let's try and play with both of them. So what do you want to do? Given the option of a faster onset or a slower onset, what would you choose? Suppose I give you the option that I can do something for you and your local anesthetic will start its action even faster than what it originally is. So that is acceptable to you, or I will say it is slower, so that is acceptable to you. What do you want? Obviously faster in onset. So let's look at the pharmacokinetic properties and let's try to change them according to our need. Why would you want slower, Bhaskar? You don't want the action to happen faster so that you can proceed with the surgery. So you want you yourself and surgeon to wait more before you can start the surgery? Huh? So let's increase the speed of onset. Let's increase the speed of onset. So the speed of onset is dependent on the fraction of unionized local anesthetic. Fraction of unionized local anesthetic. We know all local anesthetics are weak bases. All local anesthetics are weak bases, and we know that a weak base is unionized in basic medium. A weak base is unionized in a basic medium. So what do? We will add soda bicarb to the solution of local anesthetic. You will add soda bicarb to the solution of local anesthetic. You will add soda bicarb to the solution of local anesthetic. This is called as carbonization of the drug. This is called as carbonization of the drug. Carbonization of the drug. You add soda bicarb to the solution of local anesthetic called as carbonization of the drug. What will happen? Increased fraction of unionized drug. This will lead to three things: faster onset, less pain on injection, and dense block. These are the three things that happens with carbonization of the drug: faster onset, less pain on injection, dense block. First pharmacokinetic property that you changed was speed of onset, and you wanted to increase the speed of onset. Second pharmacokinetic property is duration of action. So you want increased duration of action. Obviously here also you would want increased duration of action, so that once you give local, you do not have to worry for a long time. The action will be there. Increased duration of action. Now duration of action is it's a byproduct of what? It's a byproduct of lipid solubility. You obviously cannot change the lipid solubility. So what can you do to increase the duration of action? So the concept is simple: decrease metabolism. So how can you decrease metabolism? By decreasing systemic absorption, because the metabolism happens in the systemic circulation while you are depositing the local anesthetic locally. So if you can find a way to decrease systemic absorption of the local anesthetic, then you can obviously decrease the metabolism and eventually increase the duration of action, isn't it? So how can you do that? Add vasoconstrictor. Add a vasoconstrictor. Any vasoconstrictor like adrenaline or phenylephrine. When adrenaline is added, it is added in the concentration of 1 in 2 lakh, or also called as 5 microgram per ml. 5 microgram per ml. So when you add adrenaline, then what happens? There is decreased systemic absorption of the local anesthetic. This will lead to increase in duration of action. It will also increase the maximum safe dose that you can give of a local anesthetic, because now you can give more local anesthetic without the fear of toxicity. And it also serves as a marker for accidental IV injection. Marker for accidental IV injection. You might have seen people giving local anesthetic. How do they give? They will, suppose for skin infiltration, so they will put the needle, always aspirate and then give. Why are we aspirating? So that if the needle is in a vessel, you will get the blood and you will not inject it, because you don't want to deposit the local anesthetic systemically. You want to deposit it locally. Another way of doing it is to use adrenalized local anesthetic. So what will happen? The moment it gets absorbed in the vessel, I mean if it is in the vessel, then you will see hypertension tachycardia. So that serves as a marker for accidental IV injection. Now there are certain places where use of adrenalized local anesthetic will be contraindicated. All places where there is end arterial supply. End arterial supply. Example: penis, pinna, tip of nose, toes, digits, all these places you would not use adrenalized local anesthetic. Why? End arterial supply, sudden intense vasoconstriction in end arteries can cause critical decrease in blood supply and ischemia and gangrene, right? So wherever there is end arterial supply, you would not use local anesthetic with adrenaline. You will not use local anesthetic with adrenaline. Yes, of course, you have to dilute it in 1 in 2 lakh, but the adrenalized local anesthetic that comes in the market comes with a 1 in 2 lakh concentration. Okay. Okay. So these are the two things that you can do with the pharmacokinetics. Let's come to the absorption part. And absorption depends on the site of administration of local anesthetic. So let's write the decreasing order of absorption from the site of administration will also be increasing order of risk of systemic toxicity, because the faster local anesthetic gets absorbed, the more is the risk of systemic toxicity. I just explained, Soumya, were you not listening? Marker for accidental IV injection. You don't want to deposit local anesthetic systemically, right? You want to deposit it locally. So you have to make sure that you are not depositing in a vessel. So if you use an adrenalized local anesthetic, and in case your needle is in the vessel, immediately because of adrenaline in the systemic circulation, there will be hypertension, tachycardia, and you will know and you will stop giving the local anesthetic. So it serves as a marker of inadvertent or accidental IV injection. Okay, you don't want to inject local anesthetic IV. Why? We'll come to that in some time. So you can remember this by a mnemonic called as biceps, which is the order of local anesthetic absorption. First is blood, just to tell you that intravascular means direct. You have deposited the drug intravascularly, followed by bronchial, that is intratracheal administration, followed by intercostal nerve block, followed by intrapleural nerve block, followed by caudal epidural technique, paracervical nerve block, epidural, that is lumbar, brachial plexus block, sciatic nerve block, and subcutaneous infiltration. Just make a note of this. Let me know when you are done writing this thing. Then we'll move on to the next topic. Done? Okay, Div, thank you so much for pointing it out. I have mistaken one thing. This is decreasing order of absorption and decreasing order of risk of systemic toxicity. Sorry, decreasing order of risk of systemic toxicity, not increasing. Maximum risk of systemic toxicity is when you directly deposit the drug systemically, that is in blood, followed by when you are giving intratracheal drug administration, then intercostal nerve block, intrapleural, caudal, epidural, paracervical, and so on. Max absorption in blood, so most side effect, yes. नहीं भास्कर, it's not like that. Hypertension tachycardia नहीं होता है. This is not about adrenalized local anesthetic. This is about when you deposit the local anesthetic for the purpose of regional anesthetic technique, then which regional anesthetic technique will carry more risk of systemic toxicity? Which technique will carry more risk of systemic toxicity? Very good, Div. Very good observation. Let's move on to the interesting part. The part from which maximum questions come these days is the toxicity of local anesthetic. That is two types of toxicity. One is metabolic form of toxicity, that is methemoglobinemia, which is seen with only two local anesthetics, prilocaine and benzocaine. What happens is metabolism of prilocaine and benzocaine forms a compound called as O-toluidine, which then converts hemoglobin into methemoglobin. Converts hemoglobin into methemoglobin. If you have used sufficiently large quantities of prilocaine or benzocaine, then it can cause clinically significant methemoglobinemia. It can cause clinically significant methemoglobinemia. It can cause clinically significant methemoglobinemia. Another toxicity is called as LAST, which is local anesthetic systemic toxicity. That means when the local anesthetic concentration in the systemic circulation, yes, that was decreasing order of systemic toxicity, Vinay. That is local anesthetic concentration in the systemic circulation goes beyond a level, then it presents to you in the form of LAST, local anesthetic systemic toxicity. There are only two ways in which LAST can happen. Either you have given a toxic dose of local anesthetic. That means you have given such high doses that are considered to be toxic, or you have accidentally IV placement of the drug. So you were wanting to give the drug locally, but instead of giving locally, you have deposited the drug systemically. So accidental IV placement of the drug. 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 Only two ways, right? Now, why do you think that local anesthetics will cause toxicity when they achieve a certain concentration in the systemic circulation? Why do you think? Because they're essentially sodium channel blockers, and sodium channels are involved in nerve transmission, and where in the body you have highest concentration of nerves? Where in the body you have highest concentration of nerves? Brain. Any other system that is heavily dependent on electrical system for its activity? Yes, heart. So when you achieve higher concentrations in the blood, then you start affecting brain and heart. So remember, local anesthetic systemic toxicity is always CNS toxicity and CVS toxicity. CNS toxicity and CVS toxicity, either brain or heart. CNS toxicity is early and mild form of toxicity. CNS toxicity is early and mild form of toxicity. Early and mild form of toxicity. In CNS also, you will first see excitatory symptoms followed by depressive symptoms. Why? Because local anesthetics will block inhibitory neurons first. So you will see excitatory symptoms and then you will see depressive symptoms. And then you will see depressive symptoms when the excitatory neurons are also blocked. So initially you will see excitatory symptoms followed by depressive symptoms. So let's look at the signs and symptoms of CNS toxicity. First thing is, what is a premonitory sign of CNS toxicity? A sign that develops before the first sign. So that is circumoral numbness. Circumoral numbness. First sign of CNS toxicity is circumoral numbness. First symptom is lightheadedness and dizziness. First symptom is lightheadedness and dizziness, followed by auditory and visual disturbances, that is tinnitus, followed by disorientation and drowsiness. Followed by disorientation and drowsiness. First symptoms are lightheadedness and dizziness, followed by auditory and visual disturbances like tinnitus, followed by disorientation and drowsiness. These are symptoms. These are symptoms. If you look at the signs, then the first sign is muscular twitching, tremors and nystagmus. This is followed by generalized tonic-clonic seizures, followed by respiratory depression and death. Respiratory depression and death. These are signs and symptoms of CNS toxicity of local anesthetic. These are signs and symptoms of CNS toxicity of local anesthetic. Extremely important topic. These days we get question from mechanism of action and local anesthetic systemic toxicity. In the last 3 years we have got at least 4 times question from these two topics. So if you are getting a question in LA, it is mostly coming from this topic only. Done? Have you finished writing this? Okay, Vinay. Premonitory sign means a sign that develops before the actual first sign. See, when we say first symptom, before that only, it's like in Hindi we say बाईं आंख फड़कना, so something is going to be wrong. That is premonitory sign. Confused between first signs in CNS toxicity. What is so confusing? First sign is muscular twitching and tremors. First sign is muscular twitching, tremors, nystagmus. This comes first, followed by GTCS, generalized tonic-clonic seizures, and then respiratory depression and death. Respiratory depression and death. I told you, first sign में सामने क्या लिखा हुआ है? Muscular twitching, tremors, nystagmus. And यहाँ पे क्या लिखा हुआ है? Premonitory sign. So how can you ask that first sign is perioral numbness or muscle twitching? I'm telling you first sign is muscular twitching. Circumoral numbness is premonitory sign. A sign that develops before the actual first sign and symptom. Alright. Next, how to manage CNS toxicity. How to manage CNS toxicity. अरे यार क्या हो रहा है ये? How to manage CNS toxicity. Management. See, CNS toxicity is an early and milder form of toxicity. That means the local anesthetic is going and fuzzing around with the neurons in the brain, right? So what you do is, your idea is to just prevent seizure, because that is what creates problem for the patient. So you will avoid seizures by giving benzodiazepines or barbiturates. Also, you will avoid three things: hypoxia, hypercarbia, and acidosis. Hypoxia, hypercarbia, and acidosis. So basically it is conservative management. The moment you find out that okay, this is CNS toxicity, you make sure that there is no seizure activity and there is no hypoxia, hypercarbia, acidosis. This is how you manage CNS toxicity. That is why it is considered to be early and mild form of toxicity. That is why it is considered to be early and mild form of toxicity. Early and mild form of toxicity. The problem which happens is with CVS toxicity. Problem which happens is CVS toxicity. That is a late and a grave form of toxicity. It's a late and a grave form of toxicity. Late and a grave form of toxicity. Most cardiotoxic local anesthetic is bupivacaine, and when bupivacaine causes cardiotoxicity, it can present as anything. Initially there is prolonged interval, then wide QRS complex, and then any type of arrhythmia is possible. Any type of arrhythmia is possible. Any type of arrhythmia is possible. So it's a late and a grave form of toxicity. Why is it grave form of toxicity? Because bupivacaine is a lipid soluble local anesthetic, highly lipid soluble, while myocardium also contains high amount of lipid. So this bupivacaine doesn't dissociate easily. Bupivacaine doesn't dissociate from the receptor easily, And that is why there is a prolonged form of toxicity with CVS toxicity. And that is why the management also becomes little different. And this is the most important part of this discussion. In the last two exams that you have got a question in both the exam from this thing, which is the agent of choice or drug of choice for bupivacaine induced cardiotoxicity. The answer is a 20% intralipid solution, 20% intralipid solution, which is given as a bolus dose of 1.5 ml per kg followed by an infusion of 0.25 ml per kg per minute. It is basically a lipid solution that you infuse in a patient. Why? Simple pharmacokinetic principle. Any agent, any drug, any molecule always moves from an area of high concentration to low concentration. Now, bupivacaine being a highly lipid soluble agent bound to a lipid component of myocardium is not dissociating and going into blood. So what I did, I created a lipid reservoir in the blood. Now what will happen? Bupivacaine will start dissociating from the cardiac myocytes and start going into systemic circulation. So it increases the rate of recovery of blocked sodium channels by decreasing cardiac bupivacaine concentration. It will increase the rate of recovery of blocked sodium channels by decreasing cardiac bupivacaine concentration. Apart from this, nothing is helpful in the treatment of bupivacaine induced cardiotoxicity. No antiarrhythmics. Do not use lignocaine. If the patient suffers cardiac arrest, then only two drugs, adrenaline and amiodarone, can be used as per ACLS protocol, and later you can use extracorporeal membrane oxygenation as an artificial life support. So it's an extremely difficult condition to treat, and only thing that you can get help from is intralipid. Just note this thing down. All right, done. So this is about local anesthetic systemic toxicity. All right, moving on, let's write some basic things about commonly used amino amides. Lignocaine and bupivacaine. Lignocaine is also known as xylocaine or xylocard, although they are brand names, but sometimes in exam we do get questions based on xylocaine and xylocard. Bupivacaine is also called as marcaine or sensorcaine. Now lignocaine is most commonly used LA overall, but bupivacaine is most commonly used LA in spinal or epidural. Most commonly used LA in spinal or epidural. Most commonly used LA in spinal or epidural? In spinal epidural. Okay. Let's look at the dosing. So lignocaine plus adrenaline, bupivacaine plus adrenaline. If you consider the dose in mg per kg, then lignocaine can be given 3 to 5 mg per kg, while with adrenaline you can give 5 to 7 mg per kg. Bupivacaine 2 mg per kg, adrenaline 3 mg per kg. If you consider cumulative dose for an adult, then lignocaine can be given 300 milligrams, with adrenaline 500 milligrams, bupivacaine 175 milligrams, and with adrenaline 225 milligrams. Very rarely we get questions from this dosing, very rarely, but there is no harm in writing. Okay, chalo, let's move on. What do you want, Medha? First slide of CVS toxicity. You are still stuck there. Sure, ठीक. Finish it up. What do you mean by most common used in pregnancy? Is pregnancy a condition where you want to use local anesthetic? See, local anesthetic is used for getting anesthesia. Anesthesia is done for surgery. So bupivacaine is most common used in pregnancy is not a correct question itself. Okay. So moving on. Let's come to regional anesthesia. Let's come to regional anesthesia. Now we will use these local anesthetics into the application of achieving anesthesia for the purpose of surgery, that is regional anesthesia. And we divide regional anesthesia into two broad categories: central neuralgial block and peripheral nerve block. Central neuralgial block and peripheral nerve block. Central neuraxis of the body is spine. So a type of anesthesia that is achieved through spine is called a central neuralgial block, and there are two types: subarachnoid block or spinal anesthesia. Subarachnoid block or spinal anesthesia, and epidural anesthesia, while peripheral nerve blocks can be head and neck, upper limb, thorax and abdomen, anything. Head and neck, upper limb, thorax and abdomen, anything, depending on where you want to do the surgery. Right? Let's start the discussion of central neuralgial block. Central neuralgial block. This is the most important part of the discussion, and this will cover almost 90% of what we want to discuss in regional anesthesia, because in regional anesthesia we most commonly perform central neuralgial block. Now central neuralgial block can be understood based on the three layers of meninges from inside to outside: pia, arachnoid and dura. Between pia and arachnoid is CSF, and when you deposit local anesthetic in CSF, it is called as subarachnoid block, or fondly called as spinal anesthesia. Spinal anesthesia. When you deposit the drug outside the dura, then this type of regional anesthetic technique is called as epidural anesthesia. This is called as epidural anesthesia. This type of regional anesthetic technique is called as epidural anesthesia, when you deposit the drug outside the dura. Let's try and see some things about the central neuralgial block. So first try and understand where we are depositing the drug and what we are doing. So to get a visual impression of what we are, this is the cut section of a spinal cord along with vertebral column. Okay? So let's talk about spinal. Where are we depositing the drug? Subarachnoid space between pia and arachnoid. What is present between pia and arachnoid? CSF. So we approach from the dorsal side, not ventral, not from front, from back. We reach the subarachnoid space, the CSF starts to flow out, and we deposit the local anesthetic here. The local anesthetic will spread all across the subarachnoid space, in which the spinal cord and the spinal nerves, the nerves coming out of the spinal cord, are bathing, and so it will immediately block the dorsal root ganglia and the spinal nerve roots, and all the structures that are supplied by these nerves will be blocked. This is the site of action of spinal anesthesia. What do we do in epidural anesthesia? We deposit the drug outside the dura. So you deposit the drug here in the epidural space, and eventually the drug diffuses from the epidural space, goes inside and blocks the same thing. So the site of action is the same, but the site of deposition of drug is different. Second point of difference is that subarachnoid block is a single time block, single shot block. You put the needle, CSF will start to flow out, you deposit the drug, take the needle out, one time block. While in epidural you can put a catheter because it's a potential space, and then you can give a controlled drug delivery, continuous drug delivery through the catheter. So epidural is a continuous block. Epidural is a continuous block. Bhaskar, now I am not going to go back to the slide for you to complete. You will have to step up your speed 1. If at all you are missing anything, then you wait. At the end of the class, now I am going to go back and tell you the slides. Okay. Now I really want to finish in next 1.5 hours, and I have only 45 minutes to finish regional anesthesia because I'll require at least half an hour, 40 minutes for CPR as well. Okay. So now no more going back in anything. You step up your speed, all of you step up your speed. If you're missing something, just wait for it. At the end of the class, I'll show you all the slides and you can complete it. Okay. So these are the two things that you want to know beforehand. We discuss spinal and epidural. Let's look at anatomy. So let's look at the extent of spinal cord. It has a cranial extent and a caudal extent. Cranially, it starts from medulla oblongata. Cranially, it starts from medulla oblongata. And caudally depends on the age of the patient. See, spinal cord is always fixed length to begin with, right? But the vertebral column enlarges as we grow up. So in a pediatric patient, as compared to an adult, the spinal cord ends at a lower level, L3 as compared to L1 in an adult. Spinal cord ends at a lower level, L3. But it is not so easy. In pediatric patients, it is upper border of L3, while in adults, it is lower border of L1. Lower border of L1. So an ideal space to put spinal anesthesia would always be below L3. Ideal space below L3. Why? Because if you put a spinal needle above L3, there's a possibility that your needle might injure spinal cord. There is a possibility that your needle might injure spinal cord. So how to identify this space below L3? There has to be some anatomical landmark. So let's see the anatomical landmark for putting spinal needle, called as Tuffier's line, which is a line joining highest points of iliac crest. Line joining highest points of iliac crest corresponds to the intervertebral level between L4, L5 or body of L4. It corresponds to intervertebral level between L4, L5 or body of L4. Intervertebral level between L4, L5 or body of L4. Body of L4. Body of L4. This is the ideal position where you can place local spinal needle for spinal anesthesia. Let's see some general consideration. Site of action, I told you this is common between both spinal and epidural, which is dorsal root ganglia, DRG, and spinal nerve roots. Dorsal root ganglia and spinal nerve roots. The site of action is common between the two, dorsal root ganglia and spinal nerve roots. Spinal nerve roots. So when we put local anesthetic in spinal and epidural, what happens systemically? What are the systemic manifestations of giving spinal or epidural? So let's look at systemic manifestations. Systemic manifestation. Let's start with CVS. Let's start with CVS. First of all, let's decide what we are blocking. We block spinal nerves in both spinal and epidural. Spinal nerves. Spinal nerves are mixed nerves, right? Mixed nerves are sensory, motor, autonomic. Sensory motor autonomic. Spinal nerves are mixed nerves. Sensory motor autonomic. Sensory motor autonomic. Sepsis. What sepsis? How do you define the level of block? How do you define the level of block in spinal and epidural? The level of block will always have a cranial component and a caudal component. See, caudal is always up till S5. S5, that is completely down, पूरा जाता है. Sacral segments are gone. Cranial depends on the volume of drug that you have used in spinal. So normal cranial level is up to T4. Up to T4. You call it high spinal when it is above T4. And you call it total spinal when it is up to midbrain. Up to midbrain. ठीक? So normal spinal level is T4 to S5. Everything below T4. What is blocked? Mixed nerves that are coming out of the spine. Sensory motor autonomic. Sensory motor autonomic. Let's look at the CVS manifestations of spinal and epidural. CVS manifestations. So what will happen? When you have blocked normal spinal, that is T4 to S5, then what you are essentially doing is you are causing thoracolumbar sympathectomy, isn't it? Because you are blocking all the autonomic nerves below T4. So it is causing thoracolumbar sympathectomy. And thoracolumbar sympathetics supply the sympathetics to the vessel. So there will be loss of vessel tone in lower limb. This will cause peripheral pooling of blood. Peripheral pooling of blood, which will cause decrease in venous return, which will cause hypotension. So the first manifestation that you have to understand with spinal and epidural is that it causes hypotension because of thoracolumbar sympathectomy. Because of thoracolumbar sympathectomy. How does this hypotension presents? It presents as nausea and vomiting. Because sudden hypotension will decrease cerebral blood flow, which will present as hypotension, nausea and vomiting. So if you put spinal in a patient and you came and suddenly patient says, okay, I'm not feeling well, I feel like puking, then we don't give actually ondansetron. We give a vasopressor or we give fluids so that the BP comes up, because almost always this feeling is because of sudden hypotension. How would you manage this condition? How would you manage? So again, management will involve prevention and treatment. Prevention is to preload the patient with a colloid solution. So what will happen? If you preload a patient with colloid solution, the intravascular volume would be full, and therefore the chances of hypotension and the blood not returning back would be lesser, not completely gone, but lesser. So you can prevent the development of hypotension by preloading the patient, but most of the time that doesn't work. And in treatment, the first step that you do is you give a head load to the patient. How much? 15 degrees. So it will cause the fluid to return back by gravity. Second, if it is a pregnant patient, Then along with head low, you also give a left uterine deviation. You also give a left uterine deviation. If it is a pregnant female, also give left uterine deviation. So that will put the pressure from the IVC away and the returning fluid will come. Then you can give a bolus of crystalloid. Always remember, in hypotension you give bolus fluid. And finally you can try some vasopressors. Which vasopressor to prefer? Again depends on the type of patient. Non-pregnant and pregnant. In a non-pregnant patient, your vasopressor of choice is a indirectly acting agent that is ephedrine. Indirectly acting agent ephedrine will not only increase BP but will also increase heart rate. It will not only increase BP but also increase heart rate. But in a pregnant patient, there are other considerations like considering fetus. So you will use a directly acting agent like phenylephrine. That will increase BP but will cause reflex bradycardia. But phenylephrine is associated with least risk of fetal acidosis. Phenylephrine is associated with least risk of fetal acidosis. 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 Alright, this is the first manifestation of spinal and epidural. Second is bradycardia. Now when will we see bradycardia? See, when it is normal spinal, that is between T4 to S5, hypotension is associated with tachycardia. Because there will be a reflex response, hypotension will cause tachycardia. But when the level is high spinal, I told you what is high spinal. When the level is above T4, and above T4 what happens? There is block of cardio accelerator fibers. Which supplies sympathetics to heart, T1 to T4. So when they get blocked, they will cause bradycardia. So along with severe hypotension, you will also get bradycardia. Therefore, treatment would be atropine. Atropine. ठीक है? So समझ गए? If it is normal spinal, hypotension, tachycardia. If it is high spinal, hypotension, bradycardia. Hypotension, bradycardia. Hypotension, bradycardia. ठीक है? These are cardiovascular manifestations of spinal. Let's see what will happen in respiratory. So the main muscle of respiration is diaphragm, which is supplied by phrenic nerve. Are we anywhere near phrenic nerve under normal spinal? High spinal? No. So will there be respiratory embarrassment? No. Max to max, accessory muscles of respiration will not be working that much. But what if there is an entity called as total spinal anesthesia? Total spinal anesthesia. That is, the level goes so high that it reaches midbrain. So what will happen? It will present as a triad of profound hypotension because of complete sympathectomy, profound hypotension, apnea, of course, because the respiratory center will also get blocked, and aphonia. The patient will stop talking because of profound hypotension. Aphonia. How would you manage? We know we manage any apnea by mechanical ventilation. Eventually, the drug will get metabolized and the level will come down and the patient will start breathing again. Till the time, you just have to keep the patient alive. So you manage via mechanical ventilation, vasopressor, fluids, inotropes, just to maintain the hemodynamics of the patient. This is total spinal anesthesia. Total spinal anesthesia. Total spinal anesthesia. Total spinal anesthesia. Okay. Next is gastrointestinal and urinary. So obviously, because of parasympathetic dominance, you will get a small contracted hyperperistaltic bowel. You will get small contracted hyperperistaltic bowel. Small contracted hyperperistaltic bowel. In urinary, because both sympathetics and parasympathetics will be gone, because even sacral fibers are gone, so you get a atonic bladder. You get a atonic bladder. Atonic bladder. Atonic bladder. Atonic bladder. Right? Next is contraindications. So this is a list. Just note down this list. Contraindications to spinal. Absolute contraindications, obviously patient refusal, raised ICP because it can cause coning, infection at the site of administration. Relative contraindications are neurological, cardiovascular and hematological. Neurological like spinal canal stenosis, multiple sclerosis, previous history of spine surgery. Cardiovascular like hypovolemia, mitral stenosis, aortic stenosis, and hematological like coagulopathy and thromboprophylaxis. Let me know when you are done writing this thing. Yes, Bhaskar, what is parasympathetic supply? It is craniosacral, right? It is craniosacral, while sympathetics is thoracolumbar. So when I am blocking normal spinal, then all the sacral segments are gone. Sacral segments supply parasympathetics to the lower urinary tract, while gastrointestinal parasympathetic supply comes from the cranial segments, mostly vagus, है ना? So their parasympathetic dominance will cause small contracted bowel, but here because sympathetics and parasympathetics both have gone, therefore there will be atonic bladder. Okay. Let's look at the technique of spinal anesthesia. So first is position. So you give spinal anesthesia in basically 3 positions. Most common is sitting. You can give it in lateral and rarely in prone. Puncture below L3. So most common used spaces are L3, L4, L5 or L5, S1. L4, L5 or L5, S1. L4, L5 or L5, S1. What are the structures pierced in spinal anesthesia? So if you look at the structures pierced from outside to inside, they are skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum, dura, arachnoid, and then subarachnoid space that contains CSF. that contains CSF. Now, whenever we cross these structures, there is a typical feel of the structure. So when you cross ligamentum flavum, there is a snap. While when you cross dura, the feeling is a click or a pop. These feelings are used to describe, because it's a blind procedure. So your needle is going through these structures. You get a typical feeling while you are crossing them. You get a typical feeling while you are crossing them. Okay. What right side of the slide? You mean to say left side of the slide? This one? Okay. Let's look at a complication of spinal anesthesia, specifically called as post-dural puncture headache, PDPH. Post-dural puncture headache, PDPH. Let's look at the pathophysiology of post-dural puncture headache. A hole in the dura that can happen while you are trying to give spinal anesthesia will cause leak of CSF. This leak of CSF will cause traction on the meninges. Traction on the meninges. That will present as pain. That will present as pain. That will present as pain because your spinal cord is bathing in CSF. It is bathing in the CSF, right? Also, leak of CSF will cause intracerebral vasodilatation. Why? To increase the CSF production. And intracerebral vasodilatation causing headache is the mechanism for a certain pathological condition. Do you know the name of that condition? Yes, migraine. So intracerebral vasodilatation causes migraine. Intracerebral vasodilatation causes migraine. Intracerebral vasodilatation causes migraine. What are the clinical features? Clinical features. It is a headache, typical headache, that is either frontal or occipital. Frontal or occipital. Onset is usually 12 to 72 hours after dural puncture, because that is the time it takes for the leak of CSF to be significant, so that it causes traction on the meninges. 12 to 72 hours after dural puncture. If you don't do anything, it resolves within a week. But the problem is that it is positional, so aggravated by sitting, standing, straining. So it leaves the patient good for nothing. So even a week is very long. You can't not treat it. And it is relieved by lying down. It's a positional type of headache. So it is aggravated by sitting, standing, straining, and it is relieved by lying down. Aggravated by sitting, standing, straining, and relieved by lying down. Right? Let's see what are the risk factors, and this is a very important point. Risk factors. Age, more common in young than old. More common in young than old. Gender, more common in females than males. Pregnancy and multiple punctures are independent risk factors. More number of punctures, more the leak of CSF, more the risk of PDPH. Pregnancy, intra-abdominal pressure is high, so more forcefully the pressure of CSF, so more leak, more PDPH. Type of needle makes a huge difference. Size of the needle. So a large needle will have more PDPH as compared to a small needle. Size of the needle. I'm not going to even answer that question, Bhaskar, because I have specifically made you write that thing when we write regional anesthesia and its division. So I'm not going to answer that. You flip your pages back and then see what I have made you write. Size of the needle, large, small. There is another way of giving notation to the size of the needle, that is a gauge. You might have seen 10 gauge, 20 gauge, 24 gauge. And gauge is inversely proportional to the diameter. So a higher gauge needle is usually a thinner needle as compared to a smaller gauge needle. So a small gauge needle will have more PDPH as compared to a large gauge needle. A small gauge needle will have more PDPH as compared to a small gauge needle. Then the type of the needle, dura cutting needles will have more PDPH as compared to dura splitting needles. Dura cutting needle will have more PDPH as compared to dura splitting needles. Now what is this dura cutting and dura splitting? So there are two types of needles, dura cutting and dura splitting. Dura splitting are also called as pencil tipped needles. So as the name is only telling you, dura cutting needles, they cut the fibers of dura when they are passing through them, while dura splitting needle simply splits the fibers. Examples: Quinkes and Pitkins are dura cutting needles, while Whittaker and Sprott are dura splitting needles. What are the advantages and disadvantages of both? See, dura cutting needle is very sharp. So the advantage is that you have better feel of structures while you are passing through them. Better feel of structures while you are passing through them. So the chances of failure of the block is less. But the disadvantage is that it has high risk of PDPH because it will create a permanent hole in the dura. The advantage of a dura splitting needle is that it has less risk of PDPH because it will simply split the fibers of dura, but at the cost of high failure rate. 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 Okay, let's come to management. So first line management is always symptomatic. First line is always symptomatic. You do this only when you fail in managing the patient on symptomatic management will you go for definitive treatment. So first line management is symptomatic. It's a headache, so you will give analgesic. Simple analgesics like paracetamol, opioids. It is positional, so you will advise bed rest to the patient. You will give them stool softeners so that they don't strain. It is happening because of leak of CSF, so you want CSF production to rise, so you will maintain adequate hydration. You will give certain CSF stimulating drugs like caffeine, causes CSF stimulation. And finally, it is because of vasodilatation, so you can try sumatriptan. But when all of this will fail, then the definitive treatment or treatment of choice is the one that acts on the pathology of the condition. That would be epidural blood patch. What we do in epidural blood patch, we take patient's own 20 ml blood and we inject it in the epidural space, either one space below the site of dural puncture or one space on the same space of the site of dural puncture. So what will happen, this blood will go and spread in the epidural space and will clot, and with this clot the hole in the dura will be sealed and the leak of CSF will stop and the patient will automatically have control of symptoms. Okay, that is the definitive treatment or treatment of choice or best possible treatment for PDPH. Definitive treatment of choice or best possible treatment for PDPH. Okay. Next complication that you need to know about is pruritus. Write down everything about it. It is an old AIMS question. It is most common side effect of intrathecal opioid administration. If you have injected an intrathecal opioid, you can expect it in almost every patient. Pruritus occurs more after intrathecal than IV, and it is not dependent on the type and dose of opioid administered. So this is the part that was asked in AIMS, that it is not dependent on the type or the dose of opioid. So it doesn't matter which opioid you have injected. If you have given an opioid, then most likely it will cause PDPH. It will cause pruritus. The mechanism is unclear, but it is mostly because of central opioid receptor activation. Friends, it is simple. There is a hole in the dura that is causing leak in the CSF. So you will take patient's own blood and inject it in the epidural space outside the dura. This blood will clot and it will seal the hole in the dura wherever it is present. Done. And the last one is infection, and this is a potential question. It has not been asked till now, but it can be asked. Staphylococcal infections are the ones that will be common, that are common in epidural related infections, while oral commensal, that is Streptococcus viridans, will be common after spinal anesthesia. Central opioid receptor activation. Central opioid receptor activation. Done? Okay. Chalo. Now let's talk something about epidural. Now let's discuss something about epidural anesthesia. Epidural anesthesia. Now epidural is when you deposit the drug outside the dura. When you deposit the drug outside the dura. That is epidural. There is a special type of needle that we use called as Tooheys needle. Tooheys needle. It is a stouter, shorter needle. It is a stouter needle through which we can put a catheter inside the epidural space. What is different is because we are depositing the drug outside the dura, it takes time for the drug to diffuse in. So onset of action is delayed or slow. That is, it takes 10 to 15 minutes for the onset of action to happen. 10 to 15 minutes for the onset of action to happen. Most important thing about epidural block is its ability to cause differential nerve block. What is differential nerve block? At low concentrations of LA, there is sensory block, but motor fibers are spared. There is a sensory block, but motor fibers are spared. Motor fibers are spared. This is used for post-operative analgesia. Post-operative analgesia, where you want the movement and pain relief, and labor analgesia. Labor analgesia. And a common question that is asked is that when you use continuous lumbar epidural for labor analgesia, then what is the concentration of bupivacaine that you use? The concentration of bupivacaine we use is very dilute, 0.0625% to 0.125%. 0.0625% to 0.125%. 0.0625% to 0.125%. right? This is Tuhi's needle. See, it is stouter, broader, and this is the epidural catheter that you can insert through this Tuhi's needle for continuous drug infusion. Now, you identified the subarachnoid space by CSF, right? So the needle goes in, CSF comes out, that is surety. But how to identify epidural space? How to identify epidural space? So epidural space can be identified because epidural space is a space with negative pressure. It is a space with negative pressure. It has a suction pressure. So the most common technique that we use is loss of resistance technique. Loss of resistance to normal saline or air. So after we insert the Tuhi's needle, we take the stellate out and we apply a syringe with normal saline filled with it and a constant pressure. And then we slowly go inside. The moment we pierce the ligamentum flavum, we reach the epidural space, and epidural space is a space with inherent suction pressure. So the constant pressure on the plunger, the moment you cross the ligamentum flavum, the plunger will move in. Loss of resistance. So you will feel resistance, 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 and the moment you reach the epidural space, the resistance will be gone. Resistance will be gone. This is LOR technique. Another technique is hanging drop. Another technique is hanging drop, where instead of keeping the syringe, you keep a drop of normal saline at the hub of the Tuhi's needle. The moment it enters the epidural space, the drop will get sucked in. The drop will get sucked in. And you can also use ultrasonography to identify the epidural space before you actually put the needle in. Now what is important for us to know is a special type of epidural that we use for pediatric patients called as caudal epidural. Caudal epidural. This is epidural injection in caudal region. Epidural injection in caudal region. Epidural injection in caudal region. Indications are for post-operative analgesia in below umbilical procedures, below umbilical surgeries, post-operative analgesia in below umbilical surgeries, in pediatric patients less than 6 years of age. In pediatric patients less than 6 years of age. It is used for post-operative analgesia in below umbilical surgeries in pediatric patients less than 6 years of age. Let's look at the anatomy. So we'll mark the 2 points, the 2 PSIS, posterior superior iliac spine, and we'll join them. Keeping this as the base, we will make an equilateral triangle. The apex of this triangle is sacral hiatus, and this area covering over the triangle is covered with a membrane called as sacrococcygeal membrane. And this sacrococcygeal membrane ossifies by 6 years of age. Therefore, you cannot approach the caudal epidural space after 6 years because the approach is ossified, so the needle will not pass. The needle will not pass. Let's see how we give caudal epidural. See, 2 PSIS, equilateral triangle, sacral hiatus, you insert the needle and then change the direction of the needle to reach caudal epidural space. Final is this caudal epidural space. You inject the drug, take the needle out, the drug will spread and act in the caudal epidural space. Drug will spread and act in the caudal epidural space. Now, since it is done for pediatric patients, therefore dosing is very important. Dosing is very important. And for dose, we have a scale called as Armitage scale. Where we have decided the type of local anesthetic that we are going to use. 0.25% bupivacaine. So type and concentration is final. Depending on the level required for the surgery, the volume will change. Level required for the surgery, the volume will change. Just a minute. So when sacral segments are involved, surgery that requires sacral segments, you will give 0.5 ml per kg. When lumbar segments are required, 1 ml per kg, and when lower thoracic segments are required, 1.25 ml per kg. If nothing has been given in the question about surgery, then you will take 1 ml per kg and accordingly give epidural. The answer. Okay. So this is what I wanted to teach you in anesthesia. This is everything that we wanted to cover at this level in anesthesia. Okay. Now the last topic that is remaining is CPR. So when you are done writing this thing, then you let me know and then we'll start with CPR. We'll start with CPR. Everybody done? Okay. I wanted to actually tell you this thing. If you want, you can keep a 2-3 minute break. Let me know and then I'll start. No issues. Stretch your body. Now you don't have to write. The best part is that the next 30 minutes, it is only listening, because CPR is something that I will give you. Whatever I am teaching, I'll give you as PDF. So you just need to understand the concept. Okay, Bhaskar, look at this. This will make you understand. See, all the systemic manifestations are similar for both spinal and epidural. It's just that in epidural everything happens slow, and in spinal everything is very obvious. So basically whenever they ask you a question, they will always ask you with pertaining to spinal anesthesia and not epidural. In epidural usually we use it for pain relieving and rarely for anesthesia per se, and therefore everything about anesthesia would be in subarachnoid block, but all the systemic manifestations are for both spinal and epidural. Yes, if you can read them, then it would be best for you. भास्कर, तेरी कहानी कहीं और ही चल रही होती है ना? यहाँ पूरी कहानी खत्म हो गई है, तू स्क्रॉल अप स्क्रॉल डाउन में ही चल रहा है. ठीक है. पैरास्पाइनल, व्हाट इज पैरास्पाइनल? अरे रोहन, तू कहां था यार? हाँ, you were not there for the first half of the day. Where did you go? Skipped the class. We all missed you for diffusion hypoxia. And it is not paraspinal, but it's spinal anesthesia. What paraspinal? I've never said use the word paraspinal. Acha, you mean to say what would be the structures pierced when you give paraspinal anesthesia? तेरे डाउट भी एकदम तेरी तरह ही होते हैं, यूनिक. So except for supraspinous and interspinous ligament, or rather supraspinous ligament, everything would be same. नहीं, ऐसा कुछ नहीं है भाई. इवेंचुअली तो यू विल हैव टू क्रॉस द ड्यूरा, राइट? द गिव अवे फीलिंग इज व्हेन यू पेनिट्रेट द ड्यूरा. So you give spinal, paraspinal, doesn't matter. The feel of dura will be there, but dura is covering from all round. Na? So even if you enter from the side, you still have to pierce the dura. But what you will not feel is this supraspinous ligament, because that is in the midline. So you will not feel this supraspinous ligament. You will feel interspinous ligament and you will feel the paraspinal muscle. So initially that resistance will not be there because there will be paraspinal muscles and then interspinous ligament and then dura. Okay. चलो प्रिंस, हो गया ब्रेक, चलें, चालू करें. So there are few things that I want you all to know before we start CPR. Is that CPR is one of the most extremely important topic that you have to cover. ठीक है? Just a minute. All right. It is one of the most important topics that you will cover. It is a sure shot question in the exam. Okay, it's a sure shot question in the exam. So whatever happens, you don't have to leave CPR at all at any cost. Okay. Now CPR, what I'm teaching you is been updated as a file, a PDF of the same PowerPoint presentation that I'm going to teach you. Now, since it is a set of guidelines, I don't want you to waste a lot of time in writing these guidelines, because ultimately you have to read and understand these guidelines for better perception. So you understand the concept behind the CPR. And then you can apply your knowledge, your reading multiple times and the questions that I'm going to give you, and then master the art of CPR. Okay. So why do we do CPR? So CPR is done in a condition of cardiac arrest, right? It is done in a condition of cardiac arrest. What are the goals of CPR? These are the goals of CPR. It is to maintain oxygen and blood supply to vital organs during cardiac arrest. So when the heart has stopped, you want the blood supply and the oxygen to the vital organs because the heart is not functioning. Also, you want to restore spontaneous circulation. That means you want to restart the heart. So your second goal is to restart the heart. So you'll say, sir, why? You are already managing the oxygen blood supply through CPR. Why do you want to restart the heart? Because even with best possible efforts of resuscitation, you do not achieve more than 25 to 30% ejection fraction. So the patient will not be able to survive for very long, right? Also, to minimize post-resuscitation organ injury, that means whatever organ injury will happen after resuscitation, you want to avoid that, and to improve neurological outcome of the patient. These are the 4 goals of CPR. How do we approach CPR? It is a very systematic guidelines that are made to make the life very easy. First thing is a broad chain of survival guideline that will identify the 6 critical steps that, when done in order, will increase the survival of a cardiac arrest victim. It will increase the survival of a cardiac arrest victim. Increase the survival of a cardiac arrest victim. It consists of 6 critical steps, which starts from activation of emergency response system, followed by high quality CPR, followed by defibrillation, followed by advanced resuscitation, followed by post cardiac arrest care, and then recovery. When you do things in this order, then the chances of survival of a cardiac arrest victim increases substantially. There are 2 scenarios. This is the one that you get most commonly, that is outside hospital cardiac arrest. Outside hospital cardiac arrest, OHCA. Another is when you get an inside hospital cardiac arrest, in which you have a high degree of suspicion that a particular group of patient will definitely undergo cardiac arrest, which are high risk patients in CCUs, ICUs, SDUs. So the first step is early recognition and prevention. And once you do that, if it still happens, activate ERS, high quality CPR, defib, then you don't have to go for advanced resuscitation in a hospital. You directly go for post cardiac arrest care and then recovery. This recovery is the point in chain of survival that has been recently added, and it includes additional treatment, observation, rehabilitation and psychological support. That is all the PSM stuff. Okay. Now this is the crux of CPR. CPR is as easy as CAB, that is chest compressions, airway, breathing, right? Chest compressions, no matter what you do, you have to manage chest compressions. Even if you don't want to open up the airway and breathing, make sure that you perform chest compressions. Now we define the CPR based on age group, and we have 4 different age group categories: neonate, infant, child and adult. Neonate is the first 30 days after birth. And neonatal resuscitation is taught to you by pediatrics faculty. That is dealt by pediatrics faculty. We will be discussing infant, child, adult and adolescent. Infant is 30 days to 1 year after birth. The preferred site for pulse check is brachial artery. Child is 1 year to puberty. Preferred site of pulse check is femoral or carotid. And adult or adolescent is after puberty, where you prefer carotid. So you'll say, sir, ab koi cardiac arrest victim hai. So how would I identify whether it is pre-adolescent or post-adolescent? So you look at a male. If you find axillary hair, adolescent. If you find breast in a female, adolescent. Before that, it is pre-adolescent. This is the summary of high quality CPR for BLS provider. We'll come to BLS and ACLS later on. And there are 5 do's and 5 don'ts of a high quality CPR for an adult. 5 do's are chest compression rate 100 to 120. Don'ts is not less than 100, not more than 120. Compress at a depth of 2 inches, that is 5 centimeter, not less than 2 inches, not more than 2.5 inch, 2.4 inches, that is 6 centimeter. Allow full chest recoil between the compression, that means do not lean on the patient between chest compression. Minimize pauses in the compression, that means do not interrupt for more than 10 seconds. And adequate ventilation, that is for every 2 breaths you follow it by 30 compressions and 2 breaths. And if the patient has a secure airway, then it will be different. Do not give excess ventilation. ऐसा नहीं कि चढ़ गए अंबू किए जा रहे हैं, because excess ventilation will cause increased intrathoracic pressure and that will decrease cardiac output. Now this is summary of high quality CPR for BLS provider across all age groups. First thing you always do is verify the scene safety. Second step is to check for responsiveness. We'll come to that in some time. How do we check for responsiveness? Usually we tap on the shoulder of the patient and say, hello madam, hello sir, are you okay, are you okay? Once you have established that the patient is non-responsive, then you will immediately activate ERS and then go for pulse and breathing check. How do you check for pulse and breathing? So according to age, your preferred site for pulse check we saw brachial artery, brachial-femoral or carotid. Okay? You always check pulse and respiration together, 1. Never do it for more than 10 seconds, 2. And you don't waste time. If you are not finding the pulse or breathing, you straight away move on to the next part of the algorithm. When you don't find pulse or respiration, then you activate ERS. And in an adult, there can be only one scenario that you have to activate the ERS and then you have to resume CPR. But if it is a pediatric patient, then it depends whether you have witnessed the collapse or not. If you have witnessed the collapse, okay, then you will follow what is followed for an adult. But if it is an unwitnessed collapse, that means you entered the area where the baby was already collapsed, then you will first give 2 minutes of CPR, very, very important point, and then go ahead with activating of ERS. Compression to ventilation ratio for an adult is 30:2, but for a pediatric patient, again, respiratory causes are more common. So if 2 or more than 2 rescuer, then 15:2. Same goes with advanced airway, 1 breath every 6 seconds. Here 1 breath every 2 to 3 seconds. Okay. Rate would be 100 to 120. Depth 2 inches. For a infant, it would be about 2 inches. For a child, about 2 inches. For an infant, about 1.5 inches. Hand placement, lower half of the sternum bone for an adult. For a infant, if there are 2 or more rescuer, then 2 thumb encircling technique like this is preferred over 2 finger technique like this. You have to allow for complete chest recoil and limit interruptions to less than 10 seconds. Now this is the summary of difference between adult and pediatric CPR. Summary of difference between adult and pediatric CPR. There are 5 points of difference. First is in activation of ERS in a child, unwitnessed collapse. First do 2 minutes of CPR, then activate ERS. Compression to ventilation ratio without advanced airway, more than 2 rescuer, 15:2. With advanced airway, 1 every 2 to 3 seconds. Hand placement, 2 thumb encircling technique is better than 2 finger technique, and depth of compression about 2 inches and about 1.5 inches. Airway, simple opening up of airway is most effective. You do a head tilt chin lift or head tilt jaw thrust maneuver. So you will head tilt, lift the chin as in the image, or head tilt jaw thrust. When you do 3 things, head tilt chin lift, jaw thrust and mouth opening, this is called as triple maneuver, and it is one of the most basic maneuvers that are being done to open up the airway of the patient. Remember few points, you always go from most basic airway to most advanced airway. So always try to give only compression CPR followed by mouth to mouth, then bag mask, then supraglottic, then tube at any point of time. If you are trying to secure an advanced airway, you will not compromise with your chest compression for achieving advanced airway. For breathing, it can be with pulse, without pulse. If it is with pulse, you give rescue breaths 1 every 6 seconds. Without pulse, unsecured airway 30:2, secured airway 10 breaths per minute. Defib. Now defibrillation is what makes a difference between the life and death of the patient. Why? Because the second goal is to restore the spontaneous circulation, spontaneous rhythm of the heart. That is achieved through defibrillation. What is defibrillation? As the name is telling you, defibrillates the heart. So you give a high dose electrical current through the heart that will stun the myocardium. That means it will cause depolarization of all the electrical system in the heart. And most likely after that, the SA node will again take over the electrical activity of the heart. So you pass electrical current to terminate the disorganized cardiac activity. There are two types of defibrillators, monophasic and biphasic. Monophasic are old, therefore require higher energy, 360 joule. Biphasic are new, so require less energy, 120 to 200 joule. But at any point of time, if you do not know that what kind of defibrillator has been given to you, always choose the maximum energy available. For pediatric, you always start with 4 joule per kg, increase by 4 joule per kg, maximum up to 10 joule per kg. Defibrillator are also of two types. In BLS, we use a defibrillator called as automated external defibrillator, AED, which is an automatic device, while in ACLS we use a manual defibrillator called as manual defibrillator. How do you place the electrode? Right upper sternal border and left apex, that is left below left lateral nipple, lateral to left nipple. In a pediatric patient, you don't want the pads to touch each other, so you will keep antero-posterior. This is what happens when there is cardiac arrest. One of these 4 rhythms will be present in a patient of cardiac arrest. These are 4 cardiac arrest rhythms, which is VF, pulseless VT, asystole, and pulseless electrical activity. 2 out of them, VF and VT, are shockable rhythms. That means if you defibrillate them, they will revert back to normal, but 2 of them are non-shockable rhythms, so there is no point in giving defibrillation. This is the difference between BLS and ACLS. BLS and ACLS. BLS can be performed by anyone. Rhythm identification and defibrillation is by AED, and there is no use of advanced airways, IV lines and drugs. But ACLS is performed by a team of trained medical paramedical staff. Rhythm identification is by the person performing ACLS. Defibrillation is by manual defibrillator, and you use everything. You use oxygen, advanced airway as well as drugs. So let's start with BLS algorithm. BLS can be done by anyone in the world, and that is why its guidelines are very easy. The first step in any cardiac arrest scenario is to verify the scene safety. Why do you want to verify the scene safety? So that the rescuer doesn't become the victim. Okay? So first you will see whether you can approach the area safely or not. If you can, then you take the patient from there to a safe area and then proceed to the next step, that is checking the responsiveness of the patient. So you tap on the shoulder of the patient, take their name, hello sir, hello madam, uncle, ajja, auntie, papa, mummy, how are you doing? If they are not responding, third step is always to activate ERS, activate emergency response system, and shout for help, tell them to get an AED, and then in fourth step you will go for pulse check and breathing check. In fourth step, you will go for pulse and breathing check. So checking the pulse and breathing of the patient is not the first, not the second, not the third, is actually fourth step in the cycle of cardiac arrest. There are 3 scenarios that you will get. First scenario will be that there is pulse and breathing present. So this is not cardiac arrest, something else. The patient has just collapsed. You wait for the team to come and shift the patient. Second is pulse is present but no breathing. This is a rare situation in India, but it is common in Western countries where there is opioid toxicity, which causes respiratory arrest. So you will give rescue breaths till the ACLS team comes and then they will take over. Third scenario is the cardiac arrest scenario where no pulse no breathing or only gasping breathing is present, this is the time where you will start CPR with 30:2 cycles, that is 30 compressions followed by 2 breaths, and you will give 5 such cycles in 2 minutes. Then what will happen? In the meantime, somebody will get an AED, you will attach the AED, analyze the rhythm. Is rhythm is shockable, you will give shock. Immediately after shock, you will resume CPR. Immediately after shock, you will resume CPR, right? Give 2 minutes of CPR and then go for pulse check. If it is non-shockable rhythm, you will continue CPR. ACLS, Advanced Cardiac Life Support. It is performed by a team of trained professionals. Trained professionals comprises of doctors, trained paramedical staff, nurses. Minimum 6 and a maximum 10 members can be there in a ACLS team. What are the minimum 6 members? Team leader who does the thinking job, one compressor who is doing chest compression, ventilator who ventilates. They change their role after every 2 minutes because compression is a labor intensive process. One person on defibrillator, one person to give IV drug delivery, and one timekeeper who manages the time. So they always enter in a scenario where cardiac arrest has happened. So they will immediately start CPR, attach monitor, give oxygen, and analyze the rhythm. See, ACLS is by people with some training. So their idea is not just to continue CPR, but to revert the things back to normalcy. So they will first analyze the rhythm. If they find the rhythm shockable, they will immediately shock. Immediately after shock, what do? We resume CPR, and now the person who is in charge of IV will start taking IV or IO access, intraosseous access. Then after 2 minutes, again analyze the rhythm. If it is shockable, shock. Now you have an IV line to give the drug of choice in cardiac arrest, that is epinephrine. Again analyze the rhythm. If it is shockable, shock. And now you have given epinephrine and it is not reverted. So this is a case of resistant VF and VT. So you will give the second drug of choice in cardiac arrest, that is amiodarone or lignocaine. Amiodarone or lignocaine. This is when you found that it was a shockable rhythm. But what if it was a non-shockable rhythm, that is asystole and PEA? So now the 2020 update says that you will give epinephrine ASAP. As soon as possible, give epinephrine. So you secure IV IO access, start epinephrine, again analyze rhythm after every 2 minutes. If you find a shockable rhythm, you go to shockable rhythm algorithm. Otherwise, keep on doing CPR and now start thinking in terms of reversible causes of cardiac arrest. Reversible causes of cardiac arrest, which are 5H and 5T. This is the work of team leader. He is now thinking why this cardiac arrest has happened. So hypovolemia, hypoxia, hydrogen ion, that is acidosis, hyperkalemia and hypothermia, tension pneumothorax, cardiac tamponade, toxins, pulmonary and coronary thrombosis. These are 10 common reversible causes of cardiac arrest, which are 5H and 5T. 5H and 5T. Common 10 reversible causes. So he starts thinking in terms of how I can revert things back to normal. ROSC, return of spontaneous circulation. That means you were successful in doing CPR. How would you identify? Patient's blood and pulse and blood pressure will come back. If you are using capnography, sudden abrupt rise of capno to normal, and spontaneous arterial waveforms if you are using invasive arterial monitoring. Routes of access. So there are 3 routes of access in the order: intravenous is most preferred, followed by intraosseous, followed by endotracheal. IV, there is a specific way in which you give the drug. There is an intravenous bolus push, followed by flushing with 20 ml fluid, followed by raising the extremity above the heart for 10 to 20 seconds so that the drug reaches the heart. Intraosseous, most common, lower end of femur, upper end of tibia. And endotracheal is least preferred. Dose is 2 to 2.5 times and only 5 drugs can be given endotracheally. That can be remembered as naval, that is naloxone, adrenaline, vasopressin, atropine and lignocaine. Naloxone, adrenaline, vasopressin, atropine and lignocaine. Right? Drug therapy in CPR. So you have the PDF, so you can later read, but adult is most important. Adrenaline, you give 1 milligram, that is the dose. Dilution is 1 in 10,000 every 3 to 5 minutes. Endotracheally, obviously dose will increase 2 to 2.5 times, but you always dilute the drug in 10 ml saline before you inject it. Amiodarone first dose 300, second dose 150. Lignocaine first 1 to 1.5 mg per kg, second 0.5 to 0.75 mg per kg. Third and fourth goal of CPR, post cardiac arrest care. So to improve the neurological outcome after a successful CPR in a comatose individual after ROSC, that means the heart has come back but the brain has not, we perform a therapeutic hypothermia to protect the brain. So we consciously decrease the temperature of the body to 32 to 36 degrees Celsius for 24 hours. This is to improve the neurological outcome. You will get it. It will be uploaded here in your class files. Also, you are a part of DAMS exclusive club where I always upload. You will have free access to this PDF. Don't worry, you will get through multiple channels. Okay, but it will mostly be uploaded here. Optimization of hemodynamics and ventilation. So you give 100% oxygen only till the time you are doing CPR. Then to maintain a 94% saturation, do not over ventilate. That means only give 10 to 12 breaths per minute to maintain a EtCO2 of 35 to 40 and maintain MAP. This was about CPR. Now a scenario which is a part of CPR is foreign body obstruction or choking. So for foreign body obstruction or choking, we have two age groups, more than 1 year, less than 1 year. In more than 1 year, we perform Heimlich's maneuver, which is subdiaphragmatic thrust, but we only do it in complete choking, not partial choking. Complete choking means when the patient cannot verbalize and gives you universal choking sign. Only then you do Heimlich maneuver. If it is partial choking, you tell the patient to promote the patient to do cuffing. If the child is less than 1 year old, then you do alternate back blows, 5 back blows, 5 chest compression, 5 back blows, 5 chest compression. A very important point to note in foreign body obstruction is that you do all these things only till the patient is conscious. The moment the patient loses consciousness, is non-responsive, you will immediately start doing CPR, because now this foreign body obstruction would have caused hypoxia, induced cardiac arrest. So now foreign body is no more important. What is important is heart. So you will immediately start CPR. So this is what I wanted to tell you in CPR. This is a very extensive guidelines. You will have to read and understand them. If you have any doubts, you can contact me. I will clear them up. These are guidelines in pen and paper. So you have to really go and read it at least 3-4 times, discuss scenarios amongst each other to be able to remember, and you definitely get one question from CPR in all your exams. Okay. This is what I wanted to tell you in anesthesia. These are the ways in which you can contact me. Best is Facebook Messenger. I'm always available there. I'll reply on my convenience. Sometimes it can be a day or two late, but I'll always reply. You can always tag me on the DAMS exclusive club. I think you are on 22 now, using @Anshul Divakar. Remember, @, not hashtag. And you can always follow my page Inducing Anesthesia with Anshul Divakar for all the updates that are going to come. Okay. So I hope you enjoyed the session over the last 1.5 days. I thoroughly enjoyed with this batch. Very, very interactive, very punctual, very to the point, no nonsense type of a batch. If you continue this attitude for whole year, if you make notes, if you read them properly, then I am making sure that you are going to do very good, right? So all the very best, and God bless you all. If there are any doubts, I'm ready here. You can, if you have any feedbacks, if you have any queries, you can always messenger me. You can also tag me on the club if you want to say something. If you want to give a feedback of the class, you liked something, you disliked something, you wanted me to improve something, you loved something about me, then you can always put it on the club. It gives motivation for students also, other students who read your comments and then they come for class, because you all feel like one whole family. Okay. So my best wishes to all of you. Thank you so much. You have been a very, very patient audience. It has been not easy to sit for 1.5 days, but I hope that Prince, now you have the answer that, sir, how to sit for long hours. This is how you sit for long hours. If you engage yourself in the class, if you engage yourself with the faculty and you get a feel of the subject, then you always enjoy everything. I loved every one of you. I can remember names: Bhaskar, Prince, Sneha, Rohan, right? Aru, who left yesterday. So thank you so much. And if there are any doubts, you want me to repeat, show you some slides, then I'm ready here for next 5-10 minutes till you want me to be, and then we'll hang up the session. Okay. Thank you everyone. God bless you all. Thank you so much, Avinash, Deepak. It was a pleasure to teach first timers. You can go on the club and you can share your experience of how this class was, so that it motivates other people also to attend classes. What happens is, when you get free access on the club, when you get free access on the app for everything, that one tends to miss live class. But this is the live class that, you know, gives you this pumped up feeling that yes, I know this subject. This will not happen when you watch the recorded session later on. Okay. So you can go on the club. I think you guys are on 2022 club. You can go, you can make a post, you can write your experiences, how you felt sitting in the class for the first time, and what all things that you liked, how was the notes, and you can put it up there so that it motivates other students as well as me to do even better. Okay. Yes, what I would suggest is that after this you do the DQB and SWT in the next 5 days. This is your target: revise notes, do DQB and do SWT. There are not many questions in DQB. I have streamlined it to give around 400 questions, 450 questions, and the SWT will have 100 questions. God bless you, Jatin. Thank you so much. Okay, so the pain of propofol is because it is a lipid, it is a oil in water suspension, right? So it's like injecting oil in the vein, and because vein is not accepting, so when you aspirate blood, it becomes little equal to the homeostasis with the blood. It becomes like blood, so it becomes little milder, and therefore the pain decreases. See, for next, the approach is very simple. It is going to be an exam for you, that is for sure, है ना? So just make sure that you attend classes, build your concepts, write your notes properly, and revise your notes. Ultimately, whatever the exam pattern, it is going to come from your text. When the exam pattern clarifies, we will make tests for you based on that exam pattern, and you will get exam feel and test. But what is important is that if you have started early, make sure that you build on your concepts from your class notes. So attend all classes, write everything on your own in your notebook, and make sure that you read your notes. Just don't write and keep it in your cupboard. Make sure that you read it. If you build on concept, if it is conceptual learning, no matter what type of exam will come, you will eventually do very good in it. All right. So as promised that I'll finish before 9, I have finished. If there are no doubts, then I'll hang up and I'll let you enjoy the rest of your Sunday, whatever few hours are remaining, and then you guys can get up tomorrow and then start reading anesthesia for next 3-4 days, do MCQs for 2 days, and then finish off with this subject. Okay. So with this, I'll bid goodbye to you. Thank you so much. God bless you all.